Hello, everyone. It's a real pleasure to have all of you today for this Digital Health Day. Now, digital health is nothing new. It's become more and more frequently used in high-income countries, but also in LMICs, and it does, and it give rise to a lot of hopes in terms of outreach, in terms of access to care, in terms of monitoring patients through telemedicine or telesurveillance or through connected objects, and also tapping into the vast field of digital data. Now, obviously, this is something which is much more widely used in high-income countries, but with a lot of sophisticated tools. And this is not the case in low and middle-income countries. And with IA, there is now an added boost to this trend about what can be done to outreach patients, and we are starting to wonder whether the machines and IA may one day supersede humans to treat patients. Now, beyond all the positive impacts of IA, one may wonder about the safety and efficacy of this care through AI. Is it just a tool, or is it going to become a real pillar of healthcare? And what about regulations? So it does raise a wealth of questions, and all the more so because we work in very specific settings with some very constraining regulations in some cases, or with no regulations or no sufficient regulations. So we're going to listen to people who've got a wealth of experience within MSF, and more particularly outside MSF, in the field of digital health. And it's something which is very important because we can then share about these tools. Now, I want to leave it there because of our very busy agenda, and I'm going to give the floor to Dr. Sophie Delaigue, who is one of our moderators today. She's a digital health advisor at the Geneva Digital Health Hub at Geneva University. And she's also a clinical case coordinator for telemedicine in MSF. And so I'd like to give her the floor now. Thank you very much, Claire. Hello, everyone. And to all of you who are in Paris and
for the translation, we have live translation all day, so you can use. We will do a mix between French and English. Donc, j'ai juste besoin. Voilà. Non. Parfait. Donc, bonjour à tous.
Hello, everyone. I'm going to give my talk in French. So please make sure that you grab a headset. Hello, everyone. Either in this room or if you are listening remotely. Thank you very much to OCP for hosting us today. Also, thank you to Clara and the other organizers, and thank you to the speakers who are with us today or who are going to join us through our connection. I'm going to be the moderator for the first session, and then there's going to be someone else for the afternoon. Now, a few words about the Geneva Digital Health Hub. This is a hub which is based at Geneva University. And we have some 20 years of experience with implementing telemedicine, more particularly with RAFT in Africa. and not only in Africa, in other regions of the world as well. And on the basis of this project, we created the Digital Hub 3 years ago, focusing on digital health and so that we can create bridges in order to share experiences and also create links between those projects to avoid a silo approach. And the way we designed the day today is an illustration of all this. It's a real ecosystem, and this reflects the ecosystem that we've tried to set up at Geneva Digital Health Hub. And I've been working for some 10 years now with MSF, and so it's a pleasure to join my experiences in the hub and at MSF. Now, the objective with the hub is to try and understand what is digital health. Now, let me start with a definition of digital health, and then we'll give the floor to our speakers for 5-minute presentations to illustrate and give you a broad and comprehensive view of digital health. This is why we do have speakers from the private sector or from NGOs or from private-public partnerships. They are also representative of the wide diversity of topics, and they took the floor last year during our conference in Geneva. So we selected specific subjects for MSF, like pediatrics or migrants or so on and so forth. Diversity of regions as well. We have someone from India, someone from Rwanda, and also a diversity, therefore, of regions where these projects are implemented. So this is our roadmap for today. So 5-minute presentations, then a panel for Q&A, and then the Pierre Fabre Foundation is also, which is also with us today, which manages the e-health observatory with more than 200 projects. So the Pierre Fabre Foundation have a very comprehensive understanding of this field, and they're going to give us the conclusion. Now, we'll have plenty of time for Q&A because we want this session to be interactive for people in the room and for people away and participating remotely. Do not hesitate to use the chat at the end of the first series of presentation. We'll have a Q&A, then a coffee break, then 3 keynotes, one from David Morquin from Montpellier University, who's going to tell us about what is AI, what are the different concepts that underline AI. Then we will then listen to Annie Hartley from EPFL, Yale, about the use of AI in MSF settings, and then Stéphanie De Agostini, VT Consulting. Now, I started some years ago as a dermatologist in French Guiana, and this was also my start as clinical case coordinator for MSF. At the time, I found it much easier to get an advice for my patients, for my MSF patients, through telemedicine versus what was possible for French Guiana patients, where I had to wait for long hours before getting an advisor's answer. And this is what is really the good thing with telemedicine. It is the capacity to obtain a reply very quickly. And my second take-home message for me after this experience in French Guiana, at the time, telemedicine was quite unusual, but in French Guiana, we had to use it because the hospitals are on the coastline and the rest of the country is forest country, and therefore it's very difficult to get access to healthcare, and you have to transport patients. And here you can see that these patients with a skin infection, for instance, in this example, the patient could be treated and didn't have to miss school because of admission to a hospital in Cayenne. So it's something which can be very useful, and whether it is because of AI or because of COVID, switching to telemedicine is something which is increasingly important and which we need to take advantage of. In French Guiana, it was because of the cost of bringing patients to the hospitals that telemedicine was more widely used. And thirdly, I like to underline that telemedicine is not that simple to implement. The concept itself is simple, but the implementation may be quite difficult. And this is why I decided to go fully digital, because if you want to have a proper implementation of projects, you need to be very thorough. Now, let's turn to definitions. What is digital health? And let's say that the first point to be understood is that it's something that varies over time depending on technology. So I decided to use WHO's definition, which is underlined here on the screen, on the right-hand side of the screen. This is what you find in the WHO Global Strategy on Digital Health 2020-2025. It reads that the field of knowledge and practice associated with the development and use of digital technologies to improve health. This is what is meant by digital health according to WHO. So there is a very specific aim. It's not technology for the sake of it, or innovation for the sake of innovation. It's really something to be used in order to improve access to care or to improve quality of care, both for patients and healthcare professionals. So it's something which is very important to bear in mind. It's technology at the service of health. And secondly, if we were to supplement this definition about the use of digital health, well, it means that you use digital technologies that are going to change over time, obviously. So digital health is an umbrella notion that encompasses different concepts, different activities, and our different speakers this morning are going to shed light on these various activities. If you take a look at the diagram on the right-hand side, which is a digital health training session available on the WHO Academy website, you can see that it goes from e-health, which is the word the notion we used to use in the beginning. So it's remote care. It's also something that covers LMICs, i.e. everything that is connected with mobile phones. It's also something that covers supply chain and logistics, also EMRs, electronic medical records, and we are going to get also information on the laboratory side. We'll have a presentation on malaria. Now, what are the trends driving digital transformation? Now, obviously, there has been an acceleration of the use of digital health, probably because of COVID. The COVID pandemic created a radical change in the way digital tools are used. And it was shown that healthcare systems that rely more heavily on digital and data did better. It's also something that depends on connection to the web and also the use of mobile phones. And obviously, when gradually very remote areas got access to mobile phones and internet connections, well, this was of course something that contributed to the acceleration of digital health. There's also the need to focus our projects and tailor them according to the needs, like chronic conditions, also the shortage of workforce, and regulatory and policy shifts. Regulation is something which is sometimes forces us to comply with the regulations. GRPD, for instance, in the European Union, did have an impact on our projects. So it's important to keep abreast of these different trends. Now, with regard to MSF digital transformation, innovation is really part and parcel of what MSF does, and digital is nothing new for MSF. We started with telemedicine in 2009, and at the time, very few NGOs had embarked on telemedicine projects. So with digital technology, it's possible to meet challenges that are regularly encountered by MSF, and it's something which is more particularly crucial these days with the development of AI. We know that AI can create inequality in terms of access to care. So this is why we need to look into AI so as to avoid that some regions become islands and with no access to digital health. So let me wrap up. My first take-home message is that digital health has great potential to strengthen health systems. Take-home message number 2, digital must serve people, should be people-centered. And this means either healthcare professionals or patients, or rather healthcare professionals and patients. Now, telemedicine is medicine, obviously, and digital health is health as well. It's just that it uses digital tools. And message number 3, the progress since COVID has shown that digital health is now absolutely part of health priorities. So it's important to look into this now and turn this into priorities so as to avoid creating more inequalities. And my last point, as a representative of GD Hub, I think it is important to stress that it is important to learn from one another and to share our experience. Now, I'm going to give the floor to speakers who are people outside MSF, because we think it is important to get to know what they do elsewhere and how they deal with their challenges.
Okay, because the moderation for the morning will be in English. So I'm very pleased to have Kalol Mukherjee as the first speaker. So Kalol is the deputy for the health program and also digital health lead at Terre des Hommes. He's a public health leader with a lot of experience managing health programs. So he will present today the YEDA project for Terre des Hommes. So I let you the floor. Yes, you can use this. Yeah.
Yes. Thank you. Thank you, Sophie, and thanks for getting us here. So good morning to everybody. I'm Kalol Mukherjee, as Sophie said. I've been working on health per se, but then also kind of went into digital health in recent times, purely because the world is moving towards that. Sophie obviously kind of showed you what digital health can do, and I'm going to present a single application which is trying to use all of that, and one of that is IEDA, which Terre Holmes has developed some 12 years back, using technology to improve quality of care, and that's what we try to do whenever we develop any healthcare solution, whether digital or non-digital. So let's start with what was health program doing per se and how digital came into the mix of things. Way back in 1992, WHO and UNICEF came together and said, hey, a lot of children under 5 are dying because they are not being treated well when they have fever, when they have childhood illnesses. So they created a protocol, which was a very good one, very well thought out and very well researched, and then put it under test also to check how it works. And it promotes accurate identification of childhood illness, ensures appropriate treatment, and actually they figured out it actually saves lives. It actually saves lives when it was evaluated and researched, and multiple papers came out. It actually saves more than 15% of childhood death. However, there was a caveat: if implemented well and at large scale. And there comes the challenge. When you have a great product which can make a difference, how do you do it at large scale? And how you ensure that it is done well at the very remote corners of the world? So what can we do to help IMCI implement it well? What is that digital health can do? And that's where we started thinking. But then we started looking, okay, what is IMCI? Let us get into a little bit of nitty-gritties of it, of why, what is the problem of implementing it well? And this is not a problem, this is actually the solution, but these are the IMCI charts. These were supposed to be seen by nurses and midwives to consult while they are treating a child in Kisarawe in Tanzania or Ranchi in India or anywhere in the world. And they are supposed to remember each of these steps. So for them to treat a child who is less than 5 years old, having fever while crying, they have to do all of this, and we are expecting them to follow each step one by one, and there's a lot of variabilities within it, so difficult, right? Even for me, I don't remember all the steps. So this is where TDH came in, and we developed something called integrated e-diagnostic approach. We call it IEDA in short, a decision support system, a clinical decision support system, which is digitally designed, which helps the healthcare worker forget all the papers and charts and everything and follow the digital protocol step by step without having to remember how to do things, what to do things. You bring in a little bit of e-learning videos to help them follow the steps. What it did was, in the last 12 years or so, we have really grown this in 5 countries across the globe in various sizes, both in West Africa as well as in the Asian region. Last year in 2024, we did roughly around 5 million consultations using this single application. TDH also kind of branched out into multiple other things beyond IMCI, perinatal health, tuberculosis, gender-based violence. Each one of them have certain protocols to follow. You essentially convert that into an algorithm, make it digital, and help the healthcare worker follow the protocol to the T so that they don't forget anything, they don't miss anything, every data is captured. By virtue of that, what happens is it obviously supports the healthcare worker in doing their job, essentially a job aid. But it also does is adherence to clinical protocol and improved quality of service. You can actually figure out where things are missing, where people are getting stuck. So you can actually design the training program based on that to help the healthcare workers build capacity on those areas. The third is obviously reporting, which is a major kind of challenge for any healthcare worker. They have to write so many reports. You take that away, because it is digital, automatically all the data kind of gets collected and the report goes in, both for result-based financing as well as in government public health reporting. Last but not the least is evidence-based decision-making, which Sophie was talking about, that you can actually use digital tool and data visualization to help people in the health authority level to decide where to send the bed nets, where will my next diarrheal outbreak happen, so that I need to send my ORS in which geographic region. It also kind of supports on the evaluation of primary healthcare facilities. You can actually give scoring, because now you get how many consultations are happening in every primary care center, what is the quality of it, and each one of them can be then ranked as gold, silver, bronze, and then you know where to target your supportive supervision. Help those primary cares to improve. So people who are in bronze should be brought up to silver, if not gold. People who are in silver should be brought up to gold. People who are in gold, you most probably do not need to make so much of effort to kind of support them, because they're already on the cruise control mode. So you essentially can target your resources to more where it is needed. Finally, because we now have kind of 12 years of data, we can also move to a predictive model of surveillance. We essentially kind of have thresholds where we know, okay, what is the average or mean number of diarrheal patients? Whenever it crosses or breaches that mark, we know that there's something happening and we need to go a little deeper. So we have these are not dynamic as of now, these are still fixed, but we are moving into the dynamic way to ensure that we have real-time kind of feedback on any kind of outbreaks that can happen. So that's in very short what EADI is like. Thank you, MSF, for this opportunity, and really would love to interact with each of you when time permits. Thank you.
Thank you very much, Carol. So next we have Enya Séguin. Enya leads Baby Shaker at Delft Imaging. She transformed, it was initially a PhD thesis, and now it's a solution widely implemented. So thank you, Enya, for joining. You can switch.
Perfect. Yes. Perfect. So when I was thinking about the most valuable presentation to give to this crowd, it wasn't really to tell you what is Baby Checker and how it works. For that, you can definitely scan this QR code. And if we've met before, you know I always carry a Baby Checker with me. So you can always find me later and I'll show you how it works, tell you a bit more about what it is. What I thought would be really valuable for this presentation. Perfect. Oh, yeah. Ok, je vais parler plus lentement. Ok, pas de souci. Okay, so the most valuable thing I thought I could present to this crowd is more about how we came to innovate on Baby Checker. So innovating in a field of AI in medical image analysis and implementing that in LMICs is from a concoction of many, many different partners. So we didn't come up with Baby Checker in a nutshell, and I don't think to some extent any company alone should come up with anything that influences how AI is being used, especially in amongst vulnerable populations, especially in low-income settings. So how we came up with Baby Checker altogether, of course, requires a good academic partner, people who know what is most novel to research, what is most relevant to research, and a good amount of funding, which people rarely talk about, but it does require quite a lot of funding to come to this. And so I'm going to do this very quickly because we just have a few minutes and I have to talk a bit slowly than usual. But 7 years later, after all of those things came together, that's when we got Baby Checker. So it is quite a long road to get there, right? So we have an academic partner, we have several now, and mixed in with our knowledge as Delft Imaging and how to implement AI-enabled medical image analysis and how to implement that in low-income settings and how to make that a sustainable source of income to actually develop further innovations. It took a lot of field research. So it started first with, well, before even going there, it started first with a couple of publications on are there low-cost ultrasound probes? And I know now today this is not really a big question, but it was 7 years ago. And is the image quality of those ultrasound probes the same, equivalent, or similar to the full big, like standard machine, right? That was the number one research paper we had to dig into with our research partner. And then what we had to do as well is analyze whether this was low cost enough, so do an analysis of what's on the market. Then can we develop a acquisition protocol to standardize and simplify how a midwife or someone who's a non-clinician may be able to acquire an image of the fetus. Then once we did that, we enabled remote analysis. So based on a acquisition protocol of 6 sweeps, then that's when you can send that image to a doctor remotely. Can that doctor actually analyze the image? And so that was 4 years ago now. So I'm going to go a bit quicker. That was 4 years ago. And of course, when we took that image, so you can imagine that's a huge image, right? You're taking 6 sweeps across the abdomen. That's like 800 stills that you have to then transfer into a pipeline of teleradiology for a clinician to review. And that would take me 8 hours. So that is not at all a good solution for a setting that has very limited connectivity. Also, clinicians were not available on the go, so they couldn't give live feedback. So this all starts to build the story for why AI could be interesting and relevant in that setting. So that's just also to illustrate that we didn't come up with AI off the bat. AI is not the solution in itself, right? It's years of learning what's going on the field, always consistently assessing what the need is, how people are responding to it, is it interesting, is it relevant, and soon, hopefully, is it cost effective, and is it improving maternal health outcomes? So it's a very, very long story of product development, if you will. So how we came up with what we have today is very much by, once we have all these research publications showing that low-cost ultrasound probes are good, we can have an acquisition protocol that can be used by any community health worker, midwife, nurse, which is basically 6 sweeps across the abdomen. Then it was to see, is this interesting? Because they can use it, it works. One publication 4 years ago showed that AI could be possible. Sorry, that's my timer. Maybe I'll have 1 more minute. And so once we got on site, so the first time I went to Sierra Leone 4 years ago, it was very much to see, is the AI we're implementing better than what they're doing with their 2 hands? And that sounds kind of obvious now, but if it wasn't, we were going to kill the project, right? Because AI shouldn't be there to kind of remove the need for a physical examination. It still isn't, by the way. But it definitely shouldn't be proceeded with until we assess the fact that midwives, nurses, and CHWs are not assessing gestational age, for example, better or the same as AI. If it was the same, then AI is not, there's no point in doing AI, right? So that was kind of like the process of how we came up with Baby Checker. I'll stop there, so I'm timely, but as you can imagine, it's a very rigorous, very fulfilling, very fun product development story, and that's more what I thought would be valuable to share here. And of course, if you want to hear about what it looks like, how it works, and everything, just come find me later. Thank you.
Thank you very much, Amy. Yes, you can sit on the panel. Thank you. Perfect. So next we have Patrick Delcroix. Patrick is working at Swiss TPH and will present the project CISREF. Just. So Patrick is an IT specialist focused on clinical decision support, and he will now present CISREF. Thank you, Patrick.
Yeah. Good morning, everyone. Can you see my screen? Okay. It seems that it's working fine. Can you hear me?
Yes. Yes, you can go.
Okay, fine. So I'm Patrick Delcroix. I'm working for Swiss TPH since a few years, 6 years. And I want to present you the CISREF project we worked on. If you have other questions, because I'm not physically there is also my colleague Nora, which is present and that could answer all the questions if they are not technicals. So let's precise a bit the context of the project. So CISREF project happened in Chad. So Chad is a fragile setting, and especially for refugees. Especially for refugee, because there were and there is a lot of conflict around, and there is kind of an influx of refugee that end up in refugee camp. So our setting was in south of Chad for 4 refugee camps that were actually managed in 3 health centers. So we are financed by St. John's Foundation, and we were partner with the UNHCR, a local NGO, and we also work with the Ministry of Health. What I want to say today, it's also on the process, because a lot of people see the final product, but it was mentioned in the previous presentation, there is a process to get there. And during that process, we strongly believe that it's important to include local stakeholders. So from the initial phase where you actually define your scope and you define what you will do and what are your trusted source of information, then you must also take the local stakeholders, because you will need to use also local laws and local ordinograms, so you can build on it. And then you will have to merge that all together, so that's time consuming. It's an iterative process where you have to review it and so on. And once you get on the stage, you can actually start digitalization. But what is prior to digitalization is really important and require also local feedbacks. And then for digitalization, also the local stakeholders are important, because then you need to make sure that the actual content that you will actually display on the tablets are adapted to the local language, what we call localization, but also that it works and doesn't disturb the care. And that is also an iterative approach where we develop pieces by pieces. We train the people both on the health and on the technicalities, and so we can ensure that they will be able to use the software. Because it was a fragile setting, also we had to build a solution that works offline. But I think it's the same kind of settings Yeda mentioned before. Regarding the content, our solution try to address the one patient approach, in the sense that a patient doesn't come with like his silo on the front end. They don't come with I don't know, abdominal issue. I mean, they can say abdominal issue, but it can also relate to other kind of issues. So we try to have an approach where we can start from one point and lead to another if the symptom and sign actually lead the case to a specific diagnostics. We address different domain, I will say. So the IMCI that we integrate with MSF guideline, local guidelines, and also other source of information. We added like immunization support, so people can actually have some history on immunization if they enter the immunization on the tablet. And that's for the children. For the women, we did the digitalization of the different registries they have in Chad, so ANC, postnatal, but also vaccination for women. And the last piece, unfortunately, we were not able to fully test it on the field, but it's the adult one, which was kind of new because of the size, but also because we merged it with mental health. We started with mental health as a standalone, and we realized that the boundary between mental health and somatic issue are so unclear that it doesn't really make sense to have two different flows. So we merge them together, and now we have a comprehensive approach that we are looking for delivering. So I think 30 seconds left. So basically, the biggest issue we have with digitalization are the infrastructure, kind of. So both electricity and internet are really challenging, because having internet it's critical for data sharing, but also for supervision and also for remote training. So without internet, that's very difficult. But electricity is far more difficult, because if you don't have electricity, you don't have digital solution at all. And last but not least, there is a huge turnover in this kind of setting, and that means for the training, it's a problem, because new people don't always get a training on the digital solution, and therefore the digital solution can be less used with time. The outlook, the impact and outlook. So basically we were, I think, able to, all the users, not all, most of the users had a very good feedback on the solutions that improve for them the care by providing new kind of diagnostic, but also some help in drug calculation and so on. And also on the perspective we have is to go, because the project has stopped. So now we try to go with other partner in Chad, but in other kind of setting, like more hospital, in order to have a better infrastructure and to build the knowledge in Chad, and in the second phase go back in the remote field. Yeah. And that's it. I think I'm already out of time. I'm sorry about that. I hope it was clear in that very, very limited time. Thank you for your attention.
Thank you, Patrick. Thank you very much. Okay. Patrick, you can stay online. We'll have the panel just after. Up. I'm just sharing the screen. Perfect. So now it's my pleasure to call Cécile Casque. She will present the project Wakobo for Halima. Cécile is a nurse with a doctorate in epidemiology. She is leading maternal and child health research with the Global Health in the Global South Halima partnerships. Thank you, Cécile.
Merci. Bonjour à toutes et à tous.
Good morning to all. Thank you for giving me this opportunity to tell you about the Wakobo Tikodro project. It aims at improving the screening of pregnancies at risk by involving traditional birth attendants through a digital app. In Central African Republic, maternal mortality is very, very high, and there is very little prenatal screening, many home deliveries. 40% of deliveries take place at home. So traditional birth attendants play a big role. It's a reality. Studies showed that training, overseeing, and involving the TBAs, traditional birth attendants, with health agents and prioritizing risk pregnancies is positive. In RCA or CAR, we reintroduced TBAs, traditional birth attendants, in community healthcare. Digital health showed the encouraging signs that it could improve maternal care, even though it was not documented for TBAs. So the Wakobo project is based on 3 components, including the development of a digital Android-based application with an interface for TBAs and another one for community health workers. The TBA interface serves for registering pregnant women in the community and recording the signs of a risk pregnancy. It's only done with icons, pictograms, and audio messages, no words. The pregnant woman gets a QR code, then she goes to the health center, and the community health worker, CHW, on her own interface, would register the pregnant women to enter key data, gestational age, the status of a pregnancy at risk or not, and it generates a calendar for pre- and postnatal screening and follow-up, and it triggers alarms on the TBA interface telling them they should do a home visit and also to schedule a consultation in the health center. It's a POC, proof of concept study, a pilot study. We did an experimental study. We also implemented a study of an exploratory study of a cohort of pregnant women. Also, we checked the acceptability of the project. We are currently doing the final monitoring of the quantitative data, but I can already share with you some preliminary results on how this application is accepted and received. Regarding TBA's good feedback, it gives them confidence to screen pregnancies at risk and improve the screening and follow-up of pregnant women. Using the tablet help TBAs to better detect pregnancies at risk. They feel safer having a tablet at home with them all the time to work. The main problems were technical ones due to the difficulties of a low signal for mobile phones. Also, it was difficult to recharge the devices. For community health workers, they were also happy to use that tablets. It makes them save time, and more women come to the health centers, both for pre and postnatal care. And the husbands also perceive that as quite acceptable, a real working tool, good for screening and following up women, and reinforcing the trust in the work of TBAs and reinforcing their credibility. Now, what about the durability of that project? We ask questions, and all TBAs unanimously want to go on working with the digital tool and with the project. They'd like it to be extended to other communities, but they are afraid that previous practices might come back after the project is stopped, like more home deliveries again instead of deliveries in health centers. Then we want to discuss that, see how it could be expanded nationally, and we'd like to test this strategy in other contexts. This application was designed to be accessible, free of charge in its final version. Thank you for your attention.
Thank you, Cécile. Let me just stop sharing the screen so we can see Patrick. Good. So we'll just take a few minutes now to discuss a bit more about the challenge. I will give you the microphone. So thank you again for the presentation on the YEDA. Maybe, Carol, you can share with us, I'm sure you have faced many challenges, but maybe some that you can share with us today in about 1 minute. Thank you.
Let me keep the time. So I guess the challenge is knowing the future, and which we always struggle with. Unfortunately for digital health, it's not for 1 year, 2 year, 3 year, 5 year, or 10 years. Once you set up something, it is there, and you cannot take it out. The community becomes dependent on it, the healthcare workers become dependent on it, and so does the health administration. So we have to then foresee the future, what is the requirement. Like in what we started in YEDA was, the whole thing was designed on a notebook from 12 years back. And as you know, now notebooks are obsolete. So all that was developed on designing of a particular hardware. That hardware by itself is no longer available. Then we moved on to tab, and then again, tabs again, configurations change. So that's one side. Second is 12 years back, there was no data security, data storage protocols. There was nothing called data sovereignty. Nobody even thought about where to keep the server. And we never knew how things will develop. And these were the challenges which we still work with because we don't know what firewalls are going to come, what kind of hacking system will come in, who all would be interested in getting all these data out of the thing. Is tab the right thing to do in a primary healthcare setting because tabs can be taken out of the healthcare center? So, so all of those challenges, I think, is a major one to prepare yourself for the future and look what the future holds, where and which way this whole digital health ecosystem is going to move, because you are not alone. EDI is one application. There are several applications, how we communicate with each other. Today, a 5-year child will grow up to 13-year, 14-year, 15-year, will reach adulthood. How do we pass on all this information that is already there in the childhood? The immunization to the whole life cycle thing. How do we connect with applications across board? So these, I guess, are the major challenges which any digital health application faces. And we also face the same and across countries. And we try to overcome them as they come up.
Thank you very much. For today, we have two challenges. We have to keep the time and also to speak slowly for the translation. Sorry, it's you again. So maybe, Enya, can you also share some challenge for Baby Checker?
Yeah, so I would say let's say some smaller addressable challenges would be lack of data, which we can address through research projects. So when people want more accurate AI estimations at the first trimester, we just don't have that data because women are not coming in the first trimester in a lot of our settings. So we're working now on a project that's showing that attendance is actually doubling and tripling in some of the CHCs where there's a baby checker and women are starting to come earlier. So that's a sort of challenge we're addressing. The development of more algorithms with more data, we're kind of addressing that too. But these are just, I would say, standard challenges that any of our AI products face. I would say the biggest challenge is financing. I mean, that can't, we can't just not talk about the financing behind all of this. So we have fully self-financed Baby Checker for 7 years. We've got a small grant in the beginning to develop a proof of concept, but then us as a social enterprise, we've just pumped our revenue from our other products and tuberculosis into Baby Checker. So it's made it very self-sufficient. We're not codependent on any external financing for the development of Baby Checker. But now who's going to pay, right? Who's going to pay for this? And I feel like there's never enough opportunity to really discuss this more thoroughly. So I'm just going to leave it out there. But I feel like this is probably a common challenge for every single digital health intervention right now. Also to find out if they are cost effective, if they are improving health outcomes. I feel like those are studies that we're struggling to get financed right now as well. So not just who's going to pay for the devices like this, but who's going to also support these more groundbreaking studies that really show that this is a good intervention.
Merci. Alors pour Wakobo, le premier challenge.
Regarding Wakobo, the first challenge when we were developing the tool was to develop a tool that was suitable for the users, most of them not being able to read, like traditional birth attendants, and they're not used to handling digital tools. That was a big challenge. We had to develop a simple, user-friendly app. And that was a challenge to develop that tool that was really tailored for the users. It's a key aspect. We were not sure that it would be acceptable, and well accepted and feasible. So I think we met that challenge, indeed. At the beginning of the project, we heard that it was a bit difficult to use, but we provided training, support for TBAs, traditional birth attendants. Another challenge we met was related to IT proper. We were in an urban, semi-rural setting near Bangui, so we expected the network to be robust enough, but we had cases of non-conformity. So we had to review the way the application was designed. But those are usual challenges when developing a tool. There are various stages. Sometimes you have to curtail your ambition because something is not feasible, but we worked harder and harder. It required synchronization of data because you have two interfaces with data that are updated on one server. So we had to integrate that with the systems of the health ministry. But IT specialists are developing a version 2 with separate modules. So you don't have the TBA interface and the CHW's interface. We just do the diagnostic phase offline, an application that can be tailored offline or online depending on the context.
Thank you very much, Cécile. Now, Patrick, you told us about challenges to access connections and or get power.
Challenges and training. We have another challenge when it comes to scaling up, because when you work in one facility, it's easy, you kind of control the settings, and it's likely that you have only one project in that facility. But if you want to scale up on a country level, then you have two, for me, major issues. First, the content, because the prevalence of illness might not be the same across your country. And therefore, because CDSS are working, it's not elaborated guess, but close enough because you don't have access to a lot of tests. So somehow it's a differential diagnostic, but it's with limited information. And if the prevalence changes, then the way, the likelihood of one issue or another is different, and it might imply a change on your algorithm. The basic example, if you have a malaria-prone and a non-malaria-prone area, then the fever management would be different. That's the first one. The second one is when you go national, then you might have other alpha cities that have other projects. And here you have a much more difficult problem, is how do you make sure the people still have access to a solution while not having a chaotic work process? Because if they have to switch between tablets, imagine they have like baby care and CISREF and EIDA. For the worker, it will be a nightmare to switch with all those tools. Maybe they will have 3 tablets, and that will add even more difficulties. So that's I think one really important is to respect the care worker and make sure that somehow we can have like merging solution even from different providers, and that's very, very, very difficult. Okay.
Perfect. So thank you, Patrick. Thank you to all the speakers. We will now close the panel and move to the next 4 pitches. Thank you. We can round up the So for the next speaker, I will call Dr. Laurent Bonardo. Laurent Bonardo is a French emergency physician specializing in telemedicine. He was involved in the very, very early stage of the MSF telemedicine program, and is now the co-founder of MIC. And it's my pleasure to call you here to present MIC. Thank you. En français, c'est bon.
Bonjour à tous, vraiment ravi de pouvoir vous présenter MIC, qui est un dossier médical avec...
Hello everyone, I'd like to tell you about MIC with a full integration capacity, and Professor Pierrot will also tell you about it because we are partners in this. Now, MIC development is very closely linked to the development of telemedicine at MSF, started in 2009. It's really on the basis of this experience that we gathered through the telemedicine project with MSF that we could lay down the basis for an electronic health record to share the wealth of data. Now, with the development of secure cloud platforms in digital health, it's been possible to set up an offline tool which can be accessed from all over the place with a system that is interoperable. And it's something that allows us to manage the complexity and the diversity of sites and languages, and to therefore exploit data. We are in more than 50 countries for NGOs or corporations. Now, MIC covers about all fields of telemedicine, tele-assistance, monitoring, expertise, among others, and with one particular focus on data. With data structuring, it's then possible to tap into this data. And this is what makes it possible for us to take AI on board in order to optimize analysis and management of patients. Every day, we can see through MIC that with a cloud platform, with real-time access to data, it's possible to improve reporting. And it's also something that makes it possible to get a live map guided by AI in order to strengthen the coding of medical activities, is to strengthen our capacities and or maybe come up with preventive measures. Now, Professor Pierrot is going to introduce an example showing that the structured data is something that enabled us to combine human expertise and structured data hosted on the platform to boost our diagnostic capacity for malaria cases. And as Patrick was saying, Patrick Delcroix was saying, there's this challenge of scalability, but with AI, it's possible to strengthen the lifelong training of staff. And you get more detail on that with Professor Pierrot's presentation. Finally, digital health, because of the return on investment, is something which is a political issue. So we do need public authorities to support us because this goes in the right direction, and we need to show that. And our project on malaria with public hospitals in France show that it's possible to work together, combining private and public partners. It's important to combine all these different experiences in order to set up high-performance tools. So, and of course, this is also a call for MSF to join this project. Thank you very much, Laurent. Our next speaker is not with us in this room. He's going to tell us about the Cushy Baby project. Pranav Savanur is the global partnership, global strategy lead, from India with us today. So let me give the floor to Pranav Savanur.
Thank you. Can you see my screen?
Yes, we can see.
Okay, perfect. Hi, I'm Pranav. I lead partnerships and strategy with Cushy Baby. Thank you for having me on this very insightful day. It's been very fruitful to learn more about the other panelists and sharing more about their digital transformative journey earlier today. I'm going to try to add on to value points that hasn't been discussed so far, since it's been very insightful already. So the topic of my presentation today is around restoring health back in digital health. So just a quick summary about Cushy Baby. We are a 10-year-old digital health nonprofit with a mission to bridge gaps in primary healthcare delivery. And we do that by empowering community health workers, health officials, and partners with innovative digital tools. So India faces a very unique challenge in digital health, that there's too much digital health happening in the country. So because of over proliferation of digital health, there are multiple different applications that exist that a single community health worker has to use. So the promise of digital health that came into the ground was you're able to now pick up high quality data from your community health systems, primarily through the community health workers, which in India's case are ASHA workers, and then make sense of that data. But however, because of this over proliferation of data, we still don't have high quality of information needed for health officials to plan resources and build public health programs. And then, of course, if you don't have a digitized ecosystem, there's already a delay in data that's coming in to the health officials, and they can't really have the right information at the right time. For example, if you need to have an information around which BCG vaccines need to be reached to which specific villages and by what date, the only way you're able to effectively collect that are through digital tools. So this is just a journey of how Cushy Baby has evolved over the past decade. We started off with only child immunization in 2014, did a 2-year RCT, demonstrated impact. But at that point, we were using a pendant and then a tablet model. So the pendant would be attached to something called a kala dhaga, which is a black thread that every child in India wears before the age of 5. So it was a very culturally relevant solution that wherever the child goes, the child is carrying their immunization records with them. And then with simply an NFC technology, a community health worker would be able to load that data on a tablet and then update their immunization status. But however, after spending more than 250,000 hours on the field with these community health workers, we learned that they're using a solution like Cushy Baby and then 10 others to do their work. So digitization was actually causing more harm than good. So through that was born what we call the Community Health Integrated Platform, which became an example of what interoperability looks like on the ground through a one-stop solution where community health workers could collect all the relevant information they would need for different vertical applications on a single app. So think about it as a super app that's built on the national digital health framework, which in India is called the Ayushman Bharat Digital Health Mission. So what it did was it reduced more than 50 million collective hours that community health workers spend, or on a personal basis, more than 25 hours weekly on just reporting purposes on different fragmented digital applications and then paper-based registries into a single application. So you don't have to enter in somebody's blood pressure more than once. And you also have different data quality checks that are baked in. And the magic of this was hyper granular insights coming in from the community, because community health workers are not overburdened on reporting tasks. And then they now have a streamlined measure of collecting data and also understanding and making sense of that data. So through this, the entire state of Rajasthan has been digitized through our flagship community health integrated platform. So a few different health system use cases are that with some of the data that the community health workers have collected as a part of this, it's not just health indicators. We expanded the scope to truly leverage community health workers as researchers in their communities to check if they could collect socioeconomic indicators, occupational hazards, gender data, and then their family size data. So all of this really helped us to envision what India's first village-level multidimensional poverty index looks like. And this information is super relevant for the government, not just at the health sector, but beyond the health sector. Think about any public programming. And we're now layering the socioeconomic data with health data and then climate data to work on building India's first climate and health vulnerability index with the village level granularity. We have mapped the routes of which villages are further away from a hospital, so that if somebody has a stroke in an XYZ village, they know that they need to get to the closest hospital in less than 90 minutes. So the health officials and the health system now has the information on where they can potentially build hospitals, where they need more resourcing and staffing at different levels. And then we're also now working on building clinical decision support systems and then community level surveillance for antibiotics through our antimicrobial resistance platform, which we're calling CHAMP. And these are some high level focus areas of partnerships that we're able to achieve. And this is primarily possible because we had few fundamental policies or guidelines or values in mind when we're designing to scale. So one was having a 3I blueprint strategy in mind. So when I say what is 3I, 3I actually means ink-free, making sure that community health workers have the policies and mandates in place to completely shift away from paper-based reporting to digital reporting. Second is integrate. Make sure that there are no multiple redundant applications collecting the same health indicators, which increases the burden of community health workers, and rather have a one-stop solution. And third is incentive. Make sure that community health workers are incentivized through the public health system to adopt digital tools to drive a high level of adoption, and then also understand how their own pay-for-performance-based income could increase through adopting digital tools. So when you've achieved some sort of like a market capture in that terms or scale in that terms, you can identify very specific partners who have very niche domain expertise. So for example, Audrey, a Seattle-based firm, is working on RDTs and other AI-based innovations, which would partner like Cushy Baby on deploying their solutions where they could leverage that scale. But it also means that Cushy Baby follows an ethos of partnership where we're not trying to build everything in-house, and we bring in the best experts from different domains to make sure the best quality of AI or any emerging technology tools are available for last mile care. And another key learning that we have through deploying AI and machine learning partnerships on the ground is that you can't really generalize the outcomes and outputs of AI models. So in our experience, many partners who want to come in and scale with us bring in evidence or positioning papers that focus on AI validation at a facility level, but they want to scale that at a community level. And that's a whole different thing. So you need to really think about, is AI something that I would actually need to solve this problem, or am I just parachuting this technology in because it's cool? And then second, if you actually need this technology on the ground, how can you make sure that you're starting a small scale pilot and then replicating that pilot to actually say that this AI is needed and is relevant for this particular setting and context? Because the more fine-tuning the AI has based on locally trained data, the more comfortable you are and the more confidence you have in its ability to deliver on its promise.
Sorry.
And some of the other lessons that we have.
Sorry, Pranav. Can you please just conclude on the presentation? Sorry.
Yes.
Thank you.
In our experience, we've had these 6 different stages through which we systematically take an approach to scaling with governments, with our end goal being the government being the funder and doer at scale. And we're in different stages of this across different states in India. And currently, we have reached 45 million people in just one state in Rajasthan, empowered more than 75,000 community health workers, and the government has committed more than 20 million US dollars as part of that scale strategy of being the funder and doer at scale. So happy to talk more about this in detail with anyone who's interested. This QR code leads to a video, less than a 10-minute video that we filmed recently for the closure of a partnership with Gavi, which really talks about how an end-to-end digital health system could work at a community level, which gives you a good understanding of how community health systems could be digitized. And yeah, I'm gonna pause there and open up for any questions and then other panelists.
Thank you very much. Merci Pranav. Donc, merci à tous. Merci beaucoup à la traduction pour le switch entre le français.
No, thank you very much, Pranav. We've already have a number of questions in the chat. We're going to take those questions pretty soon, but we'd like to listen to our two next speakers, and then we'll have the conclusions by the Fabre Foundation. But before that, and then afterwards we'll get the coffee break. However, before we do so, I'd like to give the floor to Professor Renaud Piarou, who is with Hospital La Pitié-Salpêtrière in Paris, who is an expert in cholera, but who is going to tell us today about the project, digital project for malaria.
Merci Sophie. Je précise que le choléra n'est pas un parasite.
Thank you very much. Cholera is not a parasite, and I've had several caps, and and I had Sophie as a resident doctor in my team, and this is how I got to become acquainted with Laurent Bonnardeau. Now, let me turn to this project MIC. MIC, it involves MIC, the company, but also PHP, Sorbonne University, and also the teaching hospital in Montpellier. And there are also several teams in Africa, some of them at INRB in Kinshasa and in Lomé, and other teams are going to join us shortly, I'm sure. Now, the objective is to improve the diagnosis of malaria. There are several techniques. However, the microscopic examination is really the gold standard. It's one of the crucial parts of the diagnosis. And if you take a look at the screen, and you take a look at the thick smear or thin smear, you come to realize that you just see the white cells, and Plasmodium is much more difficult to identify. It's much smaller, and obviously in remote places where the microscopist is not supervised regularly, you get false diagnosis. Now, this project, as I told you, involves 2 centers in France, because we're also faced with this sort of diagnostic problems in France. And there are also teams in teaching hospital in Lomé. There's a team in Kinshasa. And one of my students has identified a possibility for us in Dakar, in Senegal, to train microscopists. And with MIC and also Aide Médicale Internationale, further centers will join in South Sudan, in Liberia, and Sierra Leone. So what does it look like? Well, we also use this in our lab at Pitié-Salpêtrière Hospital in Paris. You just get a rig on the microscope to take pictures with a smartphone. It's something that costs only a few euros. Then you send them to MyC, the MyC app that shows the pictures to experts who can give their diagnosis, and it's also run through AI, and it can identify parasites both on thin and thick smear plates. So there are two sides to the app: the side that sends the pictures, and on the other hand, the experts who receive the pictures already seen by AI, so as for the experts to focus on the areas that are the most relevant for them to observe. Now, on paper, it looks fine, of course. However, the biggest problem with AI is generalization. For instance, for thick smear plates, we designed a system using efficacy indicators that are very good, like giving us 95% of true returns, which is very good. Now, we also used pictures from Montpellier without any prior training of AI, and then we lowered and we were down in terms of efficacy. Once we fed the images from our other patients, patients from our center, well, we could see efficacy raising again between 90–95%. So the accuracy goes up. So the important thing is to make sure that there is learning, and also there's diversity with images from France, from Togo, from CAR. You need to take all these diverse situations into account. So you need both to design the model, to train the AI, and build the network that is going to use this. And you need to do all that at the same time in order to hope for a positive result or a good result. And I want to stress again how this is important. We did likewise for thin blood smears, and here again, the app is very good if you use it just in one center. If you test it on images from another center that had not been included for training, well, it doesn't do as well. So we think that adding images from more centers, we're going to be able to overcome this problem of reduced efficacy. This is really the challenge we need to meet in terms of image recognition with AI. Thank you very much for listening, and I'll be happy to take your question.
Merci beaucoup, Renaud, pour la très bonne présentation.
Thank you very much, Renaud. Now, our last speaker is Dr. Jana Lagaraja, who is in Rwanda. He's a psychiatrist, a public health specialist, and until recently was the technical lead in TriLab. He led and implemented a digital health project in Rwanda and the other one in Tanzania, but I'll be corrected by him if it's not correct. Now, thank you very much for your talk.
To Sophie and Nada for the invitation. It's a pleasure to be here. Let me just try and share my screen. Okay, slideshow. Hopefully everyone can see. Yes, okay, cool.
Yes.
So I'm going to try and speak slowly for the translation, but my name is Dr. Jana Legaraja. I'm digital health and technical lead at an organization called Y-Labs, and we co-create digital health interventions with young people, focusing on climate, sexual health, and mental health. And as Sophie said, I'm a psychiatrist by background, specializing in public health. Firstly, I want to highlight that from a global health perspective, there's a pressing need to focus on youth mental health in low and middle income countries for 3 reasons, and this is the focus of the brief presentation today. Firstly, populations in low and middle income countries are predominantly young. We also know that young people are disproportionately vulnerable to developing and suffering from mental health issues. And we also know that young people in the global south face significant barriers in accessing mental health care. For example, stigma, lack of specialized workforce, lack of mental health infrastructure. And all this leads to a treatment gap for young people accessing mental health care between 76 and 85%, quite significant. Okay, so what are the solutions? So today I'm going to focus on an intervention that we created at Y-Labs and I led. It's called Tegera Ejo Heza, which means in Kinyarwanda, prepare for a better tomorrow. This is a youth-driven, holistic digital learning and peer support program, and it aims to increase mental health literacy and psychosocial support for Rwandan youth aged between 10 and 19 years old. We launched it in 2021. And it has 2 key components. So one is called Bahoka, which means free yourself. And this is an online learning platform that provides mental health education and resources. And it helps young people to understand and manage their own mental health. You can see a picture of it there. The second component is called Turi Kumwe. It means we are together. And this is an offline peer support program that facilitates in-person support and community engagement. And it encourages a supportive environment through peer interactions and shared experiences. Crucially, both of these components were implemented with the assistance of trained peer advisors called wellness warriors, and they were very, very important in the implementation of the tool. I want to highlight that this is a very innovative intervention. This is the first of its kind in Rwanda and one of the first of its kind in the area, in the region. So it's a very interesting example. Just to go over some of the key aspects of it. So as I mentioned, we co-create with youth. So we took a human-centered design methodology to pilot this intervention. We carried out 24 workshops with 2,000 young people. And we then evaluated the intervention. So we used a pre and post methodology. And basically what we found is that the intervention improved a range of different validated mental health scales. A few examples are 21% drop in severe stigma, as well as an 8% decrease in substance use, improvements in well-being scores, depression scores, anxiety scores. So we were focusing mostly on stigma, but we also saw improvements in a range of other key mental health scores. So I'm just going to focus on some key lessons learned, and hopefully this is relevant to both MSF in terms of reshaping their digital strategy, but hopefully to a lot of other stakeholders in the room. And I think these lessons are also important irrespective of specific disease vertical. So hopefully it will be relevant to the audience. Firstly, co-designing is crucial to create culturally tailored interventions, as well as build community engagement and community trust. And by creating culturally tailored interventions, this is a way of increasing the efficacy, the engagement, and sustainability of interventions. Rwanda is a post-genocide country, 30 years since genocide. And this quote is from one of the young people. It shows the specific cultural context that the mental health is operating within. So the young person said, it's not a culture to talk about mental health. And then the second bit is around being very strong and having this sort of facade of strength. So only by understanding how young people conceptualize mental health can we create an intervention that can effectively improve their mental health. I know that sounds like a very basic thing to say, but one of the issues around digital health solutions, especially in the global south, is that they aren't created for those populations in mind. So this is I think, a very interesting example of using local conceptions of mental health to build an intervention that is bespoke and tailor-made for that population. The second key lesson is to use diverse delivery channels. A few of the speakers have already noted some of the barriers around limited internet connectivity or access to technology. So we really try to prioritize the importance of using analog and digital alternatives. So we have the peer support workers delivering the intervention in person. We also have the online platform as well. And we also try to use familiar technology. So for example, using mobile phones. A lot of young people have access to mobile phones here. So this is something that they are already familiar with, which should increase accessibility and familiarity. And the third key lesson is design for low levels of digital and mental health literacy. We used health literacy principles to create an intervention that could be used by anyone. We want to increase access. And what that means is we used plain language, minimal text, clear layouts, and relevant images to address barriers around language and text. We also use multimodal content delivery. So for example, audio, video, and text, not making it too text heavy. And we also incorporated vernacular languages. So using languages that are youth friendly, not formal, super technical languages. And this again helps accessibility, equity, engagement, acceptance. And what's next? So what we did is we presented the evaluation results to the funders. We showed it worked, and now we've got $2 million to scale nationally to reach 140,000 young people across the country, train 184 wellness warriors and 150 health workers to deliver the intervention. So three key takeaways are: there's a treatment gap around youth mental health. Digital health technologies can play a role in addressing this, but to do this, they need to be co-designed with youth and also designed with limited digital connectivity and reduced digital literacy and mental health literacy in mind. Thank you very much.
Thank you very much, Dr. Jana. So it was our last pitch. Now I will call Maxime Collin. He's a digital health project manager at the Pierre Fabre Foundation. Thank you, Maxime, for the closing remarks. Can you just close, Dr. Jana, your sharing your screen, please?
Yes, I'm trying to do that. Give me.
Yes, thank you. Should be at the bottom, the green button. Thank you. Et pour toi, hop. Parfait.
Bonjour à toutes et à tous. Merci.
Good morning to all. Thank you for inviting me to talk about the challenges related to the implementation of digital health in LMICs, limited and medium, low and medium income countries. I was asked to tell you about that in 5 minutes. It's not an easy task. I will not be comprehensive, but let's go back to the key messages that Sophie delivered this morning. She mentioned, one, the potential of IT in healthcare, and then patient-centered approaches and user-centered approaches. Let's look at that in detail. Those two approaches, systemic, contextual approaches centered on the needs and on the people, that allows us to address some of the challenges that were mentioned in the previous presentations. The idea of approaches centered on the needs of users and non-users is quite straightforward. The idea is that in order for we want solutions useful, effective, that are really useful for the users. And for that, solutions have to be based on their needs and used by themselves in their daily clinical practices. Often, tools are deployed but are problematic in terms of privacy of data, confidentiality, adoption, change in practices. We need to give out and collect data. We have systems in silos. Prana was telling you about that with Cushy Baby Project. And all that rests on community health workers, nurses, doctors who are already very busy and who don't always take part in the development or testing of these apps. We need to take them in the loop, to bring them in the designing phase, implementation and evaluation phase, and in the decision-making process too. So that's how we worked on this user-centered approach. Regarding data, we need to integrate that data collection so it can be used more widely. It's got to be painless. Of course, we don't want to collect jillions of data we will not use, and it's got to be painless. You shouldn't have to use a dedicated form, but it must be integrated in your daily use of the tool. We heard this morning that these approaches are quite well implemented and used by the various players and ecosystems, but a small caveat, a warning about AI. We tend to forget the lessons we learned over the 20 past years. It's like AI would be a miracle solution, a panacea solution, and we tend to focus too much on the technology only. Contextual and systemic approaches. When implementing a solution, we have to look at practical uses, not only clinical uses, but also the use of digitalization, the level of literacy, the social media that are the most used when you want to sensitize patients. There are also digital gaps, gender inequalities in access to internet, in the knowledge of best practices. And then you have to look at how it articulates with the architecture of the health system, healthcare systems. Laurent was telling us about interoperability. That is absolutely key, because you want information systems to communicate. Interoperability means having a common language for data so the tools can talk to each other. We don't want a single tool used everywhere because contexts and needs vary greatly, but we need a common language for those tools to communicate. We should not neglect the training and support for final users, bearing in mind that integration is key also. Now, the limitations, it was mentioned, it's about digital sovereignty, legislation, and infrastructures. Often regulations are in place without infrastructures, or regulations are only partial and do not help us to address innovation issues. Now, sustainability and how to make those digital health projects sustainable. We often talk of sustainability in economic or financial terms, but sustainability is also technological, and it calls for being aware of that sovereignty issue when you start out, particularly for scaling up. It's key, because you don't develop an app the same way if it's for a handful of people or lots of people, and you want your app to be reusable by other players. And then the economic sustainability, economic models are still to be demonstrated. In our foundation, we see those 4 types of economic models. It's a bit of a caricature. They each have pluses and minuses. NGOs are cyclical because they depend on the money of funders. Universities would focus on research, but they have difficulty scaling up in practice. Then you have the private sector that's tied to the market that would not address inclusivity or vulnerable populations. And then the private non-profit making NGOs, which are interesting models, but difficult because often they don't get funds from traditional funders, so their financial balance is very fragile. They don't have enough money to finance research and development. Those are only a few challenges at stake. Thank you. Okay, now we're going to have a short panel discussion. We have a few questions already. Lots of questions, actually.
Maybe Laurent and Enya, there is also a question for you. You want to sit on the panel? It's not a panel, it's just to answer the question. So maybe 2 first questions from the chat, and then if you have question. Okay, so I will take 2 questions from the chat, and then if you have question, we will have microphone in the room. So the first question is for Enya. It's regarding the AI Act. So the question is a bit long, but you have spoken of using AI. To what extent are you planning the implementation of the AI Act and the new EU regulation? Maybe you want to comment on that, the impact of the new regulation from EU on your on baby checker. C'est un peu long. Just quickly, the impact of regulation maybe in general.
So as I just mentioned in French, I'm happy to write more about that because it's an ongoing process, right? We're continuing to be highly responsive on all these new regulations. We are a European company. We have different offices across the world, but we are registered in the EU, meaning that we are highly responsive and adherent to all the EU regulations. So of course, when it comes to having local cloud servers, and I mean, there's different things that the regulations follow on. But also, even I would say equally important, we have to be adherent to the regulations of all the other 85 countries we're working in. So I'm kind of going to also mention that as a challenge, not to say, yes, we are adherent and we're compliant, but it's hard. It's really hard to be compliant to every single country we're working in. Everyone has their own form of FDA. Of course, we have CE certification. And it is very difficult to remain kind of in the know of what every single country is doing. It's incredibly resource intensive also to keep your products at that level all the time. So, I mean, the simple answer is yes, we are following up with what's going on in the world and with regulations, but it's highly, highly difficult, to be honest.
Can I ask just one thing? Ça montre vraiment l'importance aujourd'hui.
This illustrates how important it is to work together. At MYC, we have 2 lawyers that work only on compliance-related aspects, compliance with regulations. So it's good to have a partnership to do that, to keep that watch. A comment for Laurent, a question from the chat to Laurent. Professor Pierrot said it's important to have several sites to improve the performance of the algorithm. In Gabon, you have a high malaria prevalence. You have the CERMEL Center in Lambaréné working on research on malaria. It would be good if you could get in touch with them. It's more of a comment than a question. Yes, MYC already is based in Gabon too. We'll get in touch with them. We're mature enough to have deployed and done POCs, proof of concepts. We put all the communication channels in place, so we're scaling up. And we see the value in adding value to data coming from endemic countries with low income and sharing that knowledge, that expertise. So we're really working on implementation and trying to overcome the difficulties, including political ones. Last question for Carol or Maxime.
This context where MSF works, how do you ensure that there is sustainable handover and ownership of local partners of these solutions? So maybe Carol, because you have great experience with IEDA.
Yes, and I guess where it starts at the beginning. We cannot wait for an external agency to come and throw us out. We have to start from the very beginning, that we look at who are the local partners who would take it over, whether it's the public health system, whether it's a local NGO, whether it's local social business that would take this over. And that plan has to be at the very beginning, not when we are at the fag end. So if you see I think all the presentations that happened had this timeline showing. Even in Cushy Baby, you saw the timeline of what is the end goal. And this is a question which we always ask, that what's the end goal? We want to help the public health system, or we want to help the community have better health. So who would run it? For an NGO, it's not possible in the long run to ensure the continuity. The fund challenges that Inea was talking about, it's a perennial issue. Yes, now we are hit a little bit more than what we were being hit maybe 5 years back, but this is going to happen. So grants are going to come down, donations are going to come down, and we will have to fight with it. And the only solution is localization. So within TDH, what we have looked at is ensuring localization forms part of the project management cycle itself, rather than as an external entity which comes up in the second or third phase. So let's look at localization as a policy, as a way to go, rather than as an afterthought or as the end goal. So that, I guess, would help us a lot to ensure that we do not have this uncertainty at the end of the period.
Thank you. Maybe Maxime? Non. Est-ce que vous avez des questions, du coup, dans la salle?
Questions in the room? We'll only take a few questions because we're already running very late. But there are questions you can ask directly to the speakers during the 10-minute coffee break. Felix, I work at MSF head office. 2 questions. The first one was probably raised, but with a little nuance. All the presentations were centered on a given context. Yes, countries where MSF works. But as Claire said, in those countries, there is no legislation, or the legislation is insufficient. So, was that an obstacle in developing your projects? Second, Professor Pierrot, we have to do things well and quickly. So, the time when you send out a thick smear or thin smear, how long does it take to get an answer? Because when you have a malaria outbreak, everything is urgent. Professor Pierrot. In the current state of things, when we deploy AI, we first want to evaluate the results. Even when we get the results, we want to evaluate them and we want to be sure it's a better job than what a microscope technical worker would get. So AI is used by experts and we're just in the evaluation phase. The first results we get is supervision in the centers where they have microscopes. In the Democratic Republic of Congo, we receive pictures, photographs that tell us lots about how the diagnostics are done, the quality of the dye, the way the microscope is used, the stain. So we check the quality of the microscope, and once the model is well evaluated, once we demonstrated that the performance with AI is better than what a lab technician can do, then we can activate a very quick loop. So in a few seconds or within 1 minute, you get the results of the research done by AI. But we don't want to go too quickly at first. We don't want to generate problems of wrong diagnosis produced by AI because it does have consequences for the patients. Okay, on the first question, yeah, the lack of regulations. Is it more convenient? Is it a hindrance? We are still only developing. We are fully compliant in LMICs, fully compliant with regulations, but European or North American standards allow us to deploy. And our standards are sufficiently rigorous to deploy the projects everywhere in the world, because we do take on board the best standards, and we talk with the national authorities to validate all the projects. Another speaker would like to answer on that? As Laurent said, well, back to regulations. Unfortunately, for the last couple of years, yeah, we can barely hear, says the interpreter. So unfortunately or fortunately, the regulations have changed in the last couple of years. When a medical decision is made, those tools are considered as medical devices. So we think the regulations will be deployed in most countries. You have EC marking or FDA approved. You need to register and be aware of the fact that you cannot just upload those tools. They need to be registered in the country where you work, and they need to be approved. In LMICs, it's like the telecom revolution. We went from no signal to 3G, 5G, everywhere, 4G. But with the surge of AI, lots of countries are putting in place some legislation like FDA approved software medical device or EU marking. Otherwise, legally speaking, you couldn't use them for managing cases, patients. It makes our life a bit more complicated. You need to anticipate on those changes in regulations that are coming up very quickly. Okay, one very last question. We really have to start the coffee break. We're running late.
presentations. One quick question, perhaps, I mean, considering that we have a massive knowledge in the room, a lot of the presentations focused on healthcare providers, actually, except for the last one, which was focusing more on the beneficiaries or the patients themselves. So my question is, out there, are there lots of tools that exist, digital tools, that are actually focused on the end user, meaning the patients themselves? For example, to understand the natural history of their disease, to understand what it means to have this kind of treatment, or, for example, to go through a process that will end with, for example, consent, and to say, okay, I've checked everything and I understand what's going to happen to me, and I agree, and you click and you sign digitally or something like this. Just for me, just a curiosity in terms of what is out there for patients. Thank you.
Maybe Maxime, as you have this overview at Odès, do you see like changes over time?
Je peux répondre en français. Ouais, super, j'en profite.
There are many solutions made for patients. You have many tools for awareness growing, sensitization. There are many on the market. They were developed by all kinds of players. You also have solutions that aim at putting patients in relation with health professionals and helping communications, but the limitations with those tools is accessibility, because necessarily it's made for urban people with a certain level of income. It's often the case. And USSD technology, for example, to have links between health professionals and the patient through SMS. It's the main two types of solutions deployed in the field, informing patients and facilitating the connection between patients and health professionals for referrals, and to be sure that the patients go to the right health center or the right doctor, depending on their condition.
One part of the whole ecosystem that is there on digital health. There are obviously other applications which are on the ground, which works more at the community level and feeds into it. A very simple kind of example is ISA, which is obviously used at a healthcare facility. But also the communities have an app which kind of looks at the 5 danger signs of a child. So the mother or the caregiver knows and quickly kind of checks, okay, my son has fever. Is it really, really dangerous? I need to run to the hospital, or yes, I can do home care. And she quickly runs the checklist and figures it out. So those applications are also there, and each one of them feeds into this. I'm just giving one example. There are kind of multiple of them. Same goes for antenatal care, same goes for postnatal care. There are multitude of applications which are available at the community level. But again, the penetration of smartphone does have a challenge, and we still need to work on it.
Thank you. I'm sorry, Jana, because I see your hand, but we really have no time for more comments. Sorry. Yeah? Okay. So, maintenant, c'est l'heure du café.
Now, let's have a break now for coffee, and let's resume in 5 minutes. Sorry for this shorter break than planned.
On va reprendre, s'il vous plaît, si vous pouvez prendre place. Merci. Parfait. Merci beaucoup. Oui? Yes. For translation, if you need, the presentation will be in French. So if you need English translation, you have at the back of the room for the translation. Parfait. Donc, merci à tous. J'espère que vous avez une première partie de ma...
Thank you very much for being back. We are going to listen to 3 talks now. We'll give the floor first to David Morquin, an infectious disease specialist with the Teaching Hospital of Montpellier. And he's going to give us the key concepts of artificial intelligence in health. Hello, everyone. I'll try and speak slowly, and I'll try to explain key concepts that are cross-cutting for AI. We heard a lot of very important things this morning, and I'll try to link them all in my talk. I work at the teaching hospital of Montpellier in the unit of infectious disease, and I'm also part of the areas research and integration space for digital health in Montpellier. So this is where I'm really doing my work on AI. Now, image processing isn't new, or predictive analysis. Well, nothing new here, but more recently, we've started to extract information, more particularly from structured data. And it's only recently that the processing of natural language has become more present. And this is important because with this evolution, it is now possible to combine data which couldn't be combined in the past. Now, for AI, you need a huge number of data. You need also computational power, and you need also some skills in order to design models that can be used for prediction. And these models use historical data or germ-related data for a given patient, or disease-related data. And this is what we used to call classifying AI. Now, nowadays, we are faced with generative AI, and these are AI systems that can predict the next word. Now, let's come back to the general scope, general overview of what AI is today. And we are going to take a look at what we've already seen this morning, i.e. image recognition. Now, you can train models with millions of images, and you design the algorithm, and then it gives you the answer you need. Now, like this paper in radiology showing that for detection of pulmonology, of tuberculosis, pulmonary TB, they looked at 165,000 or so images out from 22,000 patients, and they could show that their system could say whether it was a TB case or not. Now, as Renaud Piarou showed you, well, you can have these images that are used in order to know whether this is one disease or another. In infectious disease, AI has been used for diagnostic or skin lesions. And as Renaud Piarou told you, you need then also to have the external validation of those models. It can be image acquisition, but it can also be video acquisition. And this is what you see here on the screen, i.e. the capacity, for instance, to shoot a footage of someone washing their hands and then showing it right afterwards how this was done. So this is computer-based vision. Now, computer-based vision is just one subcategory of predictive analysis, whereby
Donc, y compris des données comportementales, psychologiques, des données administratives, des données issues d'objets connectés, des données génomiques, qu'elles soient pour l'hôte ou pour le pathogène. Et donc, on va avoir...
So this gives you a possibility of a huge number of combinations for prediction, for predictive purposes. Now, there was a paper published last year in Science looking at the leveraging of artificial intelligence in the fight against infectious diseases. And you get the input and then the output, so you need to know what sort of input data you need, then what technique you should use, and what sort of output it gives you. And this, of course, has a bearing on the capacity to develop a new chemical entity for treatment, how this is going to impact the pathogenicity.
Ok, bon, si là c'est mieux, ok. Donc là ça va être notamment pour faire de la reverse vaccine.
For instance, for reverse vaccinology, you can identify the immunogenic, pathogenic couple to design vaccines or to improve treatment or to have synthetic biology or AI-enabled diagnostics. And they've produced a review of literature with some 10 to 12 articles per subject, showing that there are already some success stories. Now, it's also something which can be used in order to have a better management of AMR. Now, of course, all this is very well, is very good. It works. However, it works in a given setting. Now, does it work in a specific population in any given health systems? So this is, of course, important to say that these technologies are successful. However, it's not good enough. We need to know how they can be used and proven useful to improve patients' care. Now, some reviews of the literature have shown that it is possible to have a predictive or prediction of epidemic propagation in any given unit of a hospital. So a lot of different players show positive results. Also using this technique for reverse vaccinology, and this is a very long table, and in this table you can see whenever in the lab there is a validation of a mathematical prediction. Several hospital systems are now have reached a readiness stage so as to forward patients' data in real time to trigger warning, an early warning. And they've shown this at Johns Hopkins for early warning system for sepsis. And it was also shown by UC San Diego. Here again, for prediction purposes, you can see that on the screen the discovery of Baucine was discovered by deep learning. This paper that was published in Cell is very important. It could be considered a gold standard for a lot of discoveries. In this case, they looked at a lot of microbiomes, human microbiomes, and eukaryotic cells, so as to identify antimicrobial peptides. They discovered 1 million of them, So these peptides could be predicted on the basis of genomes, and they could isolate 100 of them with an efficacy in vitro tested in mice. And these peptides are very promising. So this is really a new deal. Now, I've told you so far only about predictive analysis. However, the real game changer here, and what makes things perhaps more complicated, but also with more potential, is generative AI. I'm going to tell you to explain this about what we do in my lab. Let's imagine, for instance, that you look at the residents' on-duty reports. You know, there's this report with a lot of jargon. And then you ask the following question. You ask the system, can you tell me whether this patient can be enrolled in one of our research protocols? There are 1,500 research protocols in my hospital in Montpellier. So you need to know about the inclusion criteria, and it's a lot of information to bear in mind. So what if you use AI in order to know whether this patient can be entered in the study? Second example, let's imagine a child is at the A&E with the family, and you get the pediatrician's report, and you want to issue a report for the parents. You don't, of course, obviously, you don't want to use jargon for so that the parents can understand everything in the report. And we need to identify what should be the human interface involvement so as to rule out any mistake in the report, and also identify how this was received. And it can generate this document for the parents within a few minutes. And this is a process you can use in a lot of different situations. And I'm going to give you another example of that. We were told about the importance of quality of structured data. Now, in this case, I fed the data, and these data are translated into an interoperable format. So you can see that it can create a lot of value. And so what we do at Aerios is that we test the risks associated with the use of generative AI to see whether there are some risks associated with it. Could the expected usage be bypassed? Is it possible to improve the man-machine interface? What could be the impact on the level of care or quality of care, and also the carbon footprint? It's also something that can be used for training. This is the example of a student getting training through AI, and the AI system scores the how well the student did. For instance, the student may have forgotten to introduce himself to the patient, or to prescribe some complementary examination.
Alors, je pense qu'on n'aura pas le temps de faire... Ouais. Donc en gros, qu'est-ce qui se passe? Quand on utilise un LLM, en fait, il a fallu entraîner un modèle. Pour entraîner un modèle,
LLM. To train a model, you need a huge number of documents. And this is only possible because we, all of us, uploaded a lot of texts on the web. If we had to read through all this, it would require, as a human being, 100,000 years of reading. PubMed corresponds to less than 3% of this published data. And when you read by using token with AI. Each element is converted into figures, and the model just does one thing. Generative AI does only one thing. It predicts the next word to be used. Like if I tell you the boys went to, well, the system, depending on the data it was trained with, will give the end of the sentence. If the context is different, if the context is, say, a conflict or a war or an examination that is going to take place on the next day, if the context tells the system that this is a sunny day and the boys wear sneakers, well, it will give you a different word for the end of the sentence, like the boys went to the beach.
Montrer ce qui se fait actuellement en termes de performance. Je vais vous donner 2 exemples.
Now, let me give you 2 examples for to show you what it can do in terms of performance. Here is a memo written by a doctor. And if you feed this memo to an LRM model, and this is based on OpenAI, so this, of course, is this is not a real memo because confidentiality couldn't be protected, and you can see that the model takes more time. And this is it gives you a medical reasoning, which was tested during several meetings we had, multidisciplinary meetings, and the system does very well. It is as if you had an additional colleague with you in the room. And this is a system that can help you to plan ahead your treatment. Here is a woman, 87, with a decompensation after a bout of flu with a heart failure. So the system tells you whether you should go for a fluid replacement, how you should manage fibrillation, and so on and so forth.
Tout d'évaluation de robustesse et ainsi de suite.
Now, robustness wasn't tested, of course, in this case. Currently, there are several papers showing what these models do, focusing on patients' communications, text processing, and documentation. But we realize that it's going to be increasingly useful for clinical trials or for managing antibiotics treatment. And you can see that the capacity to answer open-ended or close-ended questions or the antibiotic susceptibility test response, the capacity to recognize antibiotic susceptibility test, and so on and so forth. It can also be used for chronic conditions, but in some cases also it can be used to generate data that is fake, and so it's a risk. It can be used, on the other hand, to generate documents that are easy to understand, so as to boost the relevance of the guidelines regarding patients' management. Now, I didn't tell you about everything that can be done, but here are also some cases where agency is possible. These models can have a conversation on the medical model, and they can trigger several tools. In this case, this is an oncology situation. You feed a scan image to the system, and the agent, based on LLM, will give you the process and will tell you what you should do. So these tools then reach the agency stage. And so you can orchestrate all these tools and get some help on an everyday basis. It's not the case today, but some people are working on it. Now, some conclusions. Of course, I can't pretend to know how this could be translated in your settings. However, in our case, we are wondering about how we can use this in our hospital. Now, the free of charge models are now very close in terms of capability to the models that you have to subscribe to. Now, of course, this is AI isn't, or the use of AI isn't compensated for in the reimbursement scheme. Now, what we can be sure of is that it's going to play a major role, and we'll have to identify what is more of a gimmick and what is truly useful. And there are also mistakes that can be made by AI, and so it raises a number of issues, in particular with regard to training, and also if you hand over your capacity to do all these things to AI, are you going to be able to retain your skills? It's very unlikely. Every time we handed over some skills to technology, we lost them. So there are two challenges. What are the consequences in terms of cost, also independence? So we need to know how we can use these tools and adapt them so we can keep the human being in the loop and be in line with our vision of healthcare.
Est-ce qu'il y a des questions dans la salle? J'en ai pas en ligne. N'hésitez pas. Oui.
Are there any questions? Thank you very much. As a student, medical student, we also learn how to process information during our training. So if we stop doing so, we may lose our capacity to hold this reasoning. The typical example or comparison would be that you no longer perform a clinical examination palpating the abdomen, but just switching over to ultrasound scan immediately. Well, it's the case in all sectors. How can we use this sort of tool in order to go on developing our knowledge and our critical eye, so it goes well beyond the field of healthcare? So you can look at things in different ways. The capacity to use reflexive AI is extremely interesting, and there's some research showing that you could do everything and you could see an inversion of the typical bell curve shape models, whereby in using AI, you could have tools to adapt your educational approach to the students who are the most advanced, while helping those who are lagging behind. So it's not a black and white answer. Some uses are, and applications are very promising. It all depends on how we supervise, what sort of oversight we have over AI. It depends very much on how you use it. It's just like for any tools, the big issue is how to use it. It's not the tool in itself. I have a question about the acceptance, not only by the patients and by the management in your hospital. And how do you deal with your IS colleagues, information system unit? Now, I'm manager and I'm a member of the board, and we work a lot with social science specialists. And with a reflection on the various tasks that are threatened by the use of AI. And this is something which may affect more administrative employees and not so much the doctors or the healthcare professionals. And the transformation is going to be less radical, maybe, in the hospital setting. Someone said earlier that it took us 30 years to understand the impact and the challenges of the implementation of the systems. And AI isn't plug and play. It requires a lot of reflection, and to tackle the numerous questions that implementation of AI raises. So to answer your question, our manager of the hospital in Montpellier is at the forefront of this trend. We were one of the first hospitals to invest in a computational system that was robust enough and powerful enough to host DeepSeek, for instance. There's a question about the risk of becoming too dependent on those tools. What I find very worrying is to become dependent on those tools, but also to become dependent on the people who sell these tools. And if I maybe exaggerate, if we don't work on this, we're all going to be dependent on Google in a couple of years. So can we retain our independence and then make sure that the tools still serve our needs? Because it all depends from which source you get these tools. And a very last question in the audience, and a very last question online. The last question online is on the risk to have these tools used by the general public, and so that people may end up trying to manage their own health without a doctor. Now I now see some patients who come to me and say, well, I asked ChatGPT, and ChatGPT told me I should be taking this drug. What do you think? Now, of course, this is much more personalized now. It's not like the sort of answers the patient used to get from online fora. They get answers from these AI systems that are very precise, and some studies have shown that AI is capable of having conversations on forums used by patients, for instance. Now, to adapt AI to our settings at MSF, we know that we sometimes have a shortage of data in our settings, and medical records are on paper. If you train AI on the global north data, don't you think that there's a risk of introducing a bias and ending up with poor results in our settings? Well, for classifying AI, as Renaud Piarou showed, the diversity of the data used is a big parameter, is a big criterion for good results. However, whenever you use generative AI, you ask it to produce text, so you can require the text through your human control, or because of its capacity, you ask not for a diagnosis, but for a line of reasoning that you may criticize. However, of course, there are biases in the language models.
Et il est sûr, en fonction.
The majority of texts fed to these systems are in English, so it's more on in this regard that it can introduce a bias. I think that for medicine, it's going to be difficult to identify, but it's going to be more limited in medicine. We all know that there are cognitive biases. These models, of course, are biased because of the training data used.
So what we have to do is to be able to evaluate those biases and use them knowing all the risks, the biases. Okay, that makes for a good transition with the next presentation by Professor Annie Hartley.
Donc, Professeur Annie Hartley qui va nous parler.
Professor Annie Hartley will tell us about a case of the use of LLM in humanitarian concept. She is the head of LIGHT, a laboratory, a research group working on AI and health. We're delighted to have you with us. Yeah, the transition is great because I'll be answering the latest questions you asked with my presentation. I will continue in English, though.
Sophie, vous pouvez passer les slides.
Okay.
Vous pouvez faire le micro comme ça.
Ah oui, c'est parfait, merci. Okay, so thank you very much just for inviting me and for also allowing me to not just give this presentation, because it's not a presentation, it's really an invitation. And it's an answer to the question that was just asked about contextualization, because lots of people until recently have been really trying to seek something in AI called generalization. Oh, well, it doesn't generalize enough, therefore it's not a good model. And we are now moving right back to the opposite side of the spectrum, where we say it's generalizing too much. And the issue about generalization, right? Okay. Okay. Like this? It's good? Okay. So the issue with generalization is that by definition, it means that we will be inequitably inaccurate in places that are underrepresented. By definition, we will have biases. It's the context that creates biases. If we have a context of the entire world, we are going to get the representation of what is available in the entire world on the internet. And so this is an effort to contextualize models, to control them, to own them, and to make one, as you see from the invitation, to join a movement, right? It's called MOOVE, and we'll go into what that means, to make AI chatbots for your setting, directly according to your setting. You don't need to be an AI expert. You can control them with your own expertise. And for the first time with generative AI, we can speak with these models. So it's a way that we can actually nudge them and correct them and push them into the places that we want them to go. So if you want to learn more about this, we're also having a workshop, a 3-hour workshop in French and then in English tomorrow. So please, those who are here and have already registered, you can look forward to us going a bit more in depth, and you can also play with our tool to see how it works. Okay, so I've got two big words up here, Meditron and the MOOVE. So let's just get us all oriented what this means. So Meditron is the name of our model. It's not just a model like an LLM, like OpenAI or something. It's a suite of models. It's open models and not OpenAI. It's our own models, chatbots for medical knowledge, and they're specifically adapted to resource-limited settings, right? And then the MOOVE, well, this is a platform, and it stands for something. It's, the M is very important. It stands for massive. And it's really important that it's massive, because if we want to validate these tools, we have to do them massively. How many questions can you ask ChatGPT? An enormous amount. It's infinite. How many questions can you expect to get back? An equally infinite space. So we have to really explore that permutation of spaces, and we have to ask these questions massively and specifically for our setting. It's an open platform, but it's not really open. There isn't some teenager in Iowa that is correcting our tools for medical use. It's open to experts, and obviously that's why we are here today, because this room is full of experts, and we are inviting you to do this. We're not a company. I'm simply, we have a lab, and our lab is making open source software. We happen to be, that's what we're trying to drain the resources basically of academia to make useful tools. And in our academic institutions, we have access to a huge amount of compute, and we want to make this massively available. So it's a validation and evaluation platform, and basically you're allowed to then change the tools, nudge them, move them to your context through your critical evaluation, correcting them, finding hallucinations, finding biases by adversarially probing the model and then pushing it to your context. Okay. So what we really want to do here, right, is to calibrate our trust, because we don't know how much to trust these tools. You saw all of the opportunities that they can do, all of those impressive documents that they were making. But how much do we trust the documents? They may look good, they may be on great formatting, they may be coming from a well-known model. But how do we calibrate that trust that we have in them with evidence? Some people are cowboys and some people are skeptics. The real answer is somewhere in the middle, and it might be more on one side than the other if you're in a certain context.
We need to create ownership of these models, ownership through our co-development of them. And if we are co-developing these tools, we own them directly. And that's really important. And that's through experience, we can know how they behave as well. Okay, so getting into it, why do we even need a chatbot? I think we saw this, so I can gain some time, because I was asked to gain some time. So we all know that we can use these chatbots. And when can we use them? Now. And when are people using them? Now. This is urgent. We really need to evaluate these tools now, and these things need to happen quickly. So that's why we're inviting people to start immediately. This is Carol. She's a community health worker in Kenya, one of the places where we're working, and she used it right there in her consultation when the wife over here of this patient was asking about stroke. She didn't know anything about stroke, and then she asked ChatGPT. She asked ChatGPT, how can I explain to this woman? And here it's written, but actually it's on the day she asked it in her own voice, in her own language, in Swahili. So I'm just like extrapolating here. But in Swahili, she was able to ask what was wrong with the patient and give more explanations. And she got a really useful answer back to her in her own language right then and there. And she didn't need any training to do this because it's intuitive. We don't train people to use WhatsApp. So it's really important that we have these intuitive to use tools that we can give patients and empower them and also our health workers. So this is contextualization. And she can even go a step further, and she asked the patient, she saw he had a high blood pressure, and she said, hey, do you have are you taking your medications? He's like, yes, I'm taking my medications, and he put his medications on the table. And she's like, okay, great, yes. But the medication that he put on the table, if there are any doctors in the room, you'll see that it is an antihistamine. And this was an issue. So I asked Carol, I'm like, hey, how do you know? And she's like, I wouldn't be able to tell, but you know what I'm going to do? Takes a photo, asks ChatGPT, and was able to come to a conclusion, which she trusted because the tool's already there, right? And she said, which recognized the tool, and she asked in her own language. And there you go. It's not an antihypertensive. It's antihistamine. So please change course of action. And that's what she did. So these tools are being used right now, and that's why we need to do something right now as well. And I think this is a game changer because it provides the most important thing we can possibly give to a patient. Possibly. It's information. And information that is mostly right. And that is more than we can say for the majority of medical workers and doctors in general, right? And the information is not just mostly right, but it's at the right time and in the right place. And that is what changes this. It's the access to it. And I think that that's why people are so excited about large language models, is because we have this massive opportunity to give the most powerful thing we can possibly give to patients. And we can scale that massively. Also responding to... Ok, un peu plus doucement. Excusez-moi, je vais essayer mon meilleur. Okay, excusez-moi. Okay. I think that's it really also responds to one of the questions here as well about how do we make sure, I think it was you that asked, that we don't have this cognitive atrophy, this diminution of our skill set. And this is a high resource setting problem. If we understand that it will take us nearly 900 years to create a workforce that we need for medicine to serve our population, we realize that that's a problem that doesn't exist for the majority of the planet. And so it's really to access that knowledge in places where it doesn't exist, and we need to focus our efforts on that. A little bit about our lab, because this is a collaborative effort, of course, so I just wanted to explain. So you already know that this is our lab's called LIGHT, and we're based in 3 different places. So in Harvard in the School of Public Health, and then in EPFL in the School of Computer Science and Carnegie Mellon University in Africa, purposefully because we want to make sure that we can take the resources from these places to have this massive scale initiative that we want to undertake. So it's really about coalescing and understanding that we have to collaborate massively in order to make these tools good enough to use in the same way that we'd be able to use them in other places. I'm also a big fan of ultrasound, so I was so happy to see that some Baby Check and others were here. I'm looking forward to dig into that kit. So thank you for that, but I've just been also collaborating quite a bit with ICRC and Médecins Sans Frontières for a while. But with ICRC, they actually are, they were supposed to be here co-presenting this with me today. Javier will be speaking a bit later. But they were the initiators. They asked us to make a model for them, and now they are having their own humanitarian move, and they are taking our tools and housing it within ICRC to also host it in there as well. So that's another way of collaborating. So what we're trying to do here, basically, just to understand, someone said it as well, data is the model, right? So what we try to do in our group, we collect data, and then we ethically manage that data, and then we make models with it, right? Because a model is data. And then we try to close the gap. So this is the model then, right? So that would be Meditron, right? So that's a model we're talking about today. But we try to close that gap because we try to make implementable models. And there, it's where the MOOVE comes in, because how we implement these models, you can use it right now. We try to implement them in a way that it's continually learning, right? Machine learning, it should be continuous. We should never decide to just freeze a model and be happy with it. It needs to be validated all the time, and this is this continuous learning platform that we are developing. So to get into the meat of it then, we know that data often looks like this. That was mentioned here today as well. And so you can't even use it. And if you want to use it, it's often not accessible for a range of reasons. When I got this picture is actually in a place I couldn't go inside, not because there were data protection strategies in place, but because there was a live snake or several snakes inside. And people were starting to throw their dossier through the windows, right? So there's a range of reasons why we can't access data. It's not going to happen. It's not going to happen in our lifetimes. It's just not going to happen. So even if we do have PubMed over here, it's still going to be completely useless to us, because PubMed actually for Africa, for example, less than 3% of PubMed represents the African context. So you can just imagine how little it represents in our context. So we just have to accept that we have an imperfect model. Even Meditron, we try our best with Meditron. We really trained it with MSF data, and as much as we could, we put it there. It's still going to be imperfect because it's always contextualized. So what we then try to do is nudge the model through use, so we don't fall behind and wait for this data to materialize. It's not coming. So then you can get a model that's adapted. And again, we did try. We took all of these guidelines, and now we are making it so the formatting is a bit off on this computer, but I promise it looks beautiful in the original format. So then here we have these models that you can get that are adapted to each setting, right? That you can get as an outcome. So this allows us to focus on some values of what we're trying to do. We try to make them locally owned and do that through community alignment. So local doctors that know best would be able to align models to their context. We try to make sure that it's co-created through expert validation, and that they are accountable and transparent, because it's the community that's openly validating them, and we can get that consensus from people about which model is best for their setting. So you don't have some company coming to you later and going, we have the best model. What you can say is, prove it, and let's test it. And let's see which model is best, not just in terms of accuracy in answering multiple choice questions, but in terms of its real world applicability and its safety and its empathy and its contextual alignment and its cultural understanding. And so that kind of granular oversight we can compare. And then we want this continuous learning that's dynamic and updatable, as well as then finally what we really want is an adaptive model that's representative. So these kinds of values are important to what we're trying to do, and it's become then a community which is trying to foster better performance in these models. So what is performance, right? So Meditron is doing great. It's a wonderful model, but it doesn't matter. This is not a Meditron project. We're making one model at least that people can own, because we are up against strong competition. If we don't make something that's great to own and is really nice to use, people are just going to end up using ChatGPT. So we do have to rise up our standards to make sure that small models that are runnable are good as well, right? If OpenAI gave us their model today, we wouldn't even be able to afford to host it, right? So we are at a huge disadvantage where they've got billions, trillions of parameters, right? About an equivalent brain size of a dog versus a swarm of bees. So one honeybee's brain is about 1 billion parameters. We have a 70 billion parameter model. So 70 honeybees put together, right? Versus the size of a dog's brain, probably, in terms of the synapses, if they were actual parameters. So we're at a huge disadvantage, but we can still produce really good results. And these are the results of exam questions, right? So this is how benchmarking usually works. But I don't think anyone in this room has ever asked their doctor, and no patient has asked you, well, what did you get in your exam? You know, no one cares. No one cares, and they don't care for a very good reason. Medicine is more than multiple choice exams. And we have to, sure, it's helpful, but it's to understand how much it knows. But we need to go further. We need to have higher standards for our tools. So that's what we're trying to do. And it's also bad to do this. You know, if medicine is not multiple choice, you know, patients don't come up to us and say, oh, doctor, I've got heart pain and it's either A, B, C, or D, you know. Sometimes they do if they've looked at ChatGPT before. But the thing is that we have to evaluate them a bit harder. So, you know, when a measure becomes a target, it ceases to be a good measure. And some of these models, if you actually interact with them, they are actually quite bad, right? They just are like knowing A, B, C, or D, and they don't go much further than that. So we have to make sure that we don't make it oversimplified, our evaluation. We want to make sure that we keep it fresh. It mustn't be static. We need to surprise the model. And we need to make sure that it's not biased in a high resource setting. I mean, those are USMLE exams that were being tested there. And it becomes easy to cheat, so people can just train the model on those questions and then it performs well. But the most important thing is to be context specific. So I'm a medical doctor in South Africa, and the context specificity of our patients, the patient journey, is really particular. And it's not going to be represented in written literature. I think someone said that as well. Like a lot of the stuff in MSF, the tricks of the trade are just not represented. So how do we represent them? And this is a way to try to do that. Our patients pass through traditional healers. They have a lot of herbal remedies, and they represent things linguistically very differently. I mean, here this guy's treating something called worms of the woman, right? How does predicting the next word after that look like, right? Speaking to some people in Cameroon, no, it was in Nigeria, they were saying, you know, there was a new fake news that came out, which is also important, you know, like new fake news that came out that you could get COVID from eating chameleons. I mean, that's a string of words that you don't hear every day, right? So how will the model behave? And you have to test that, right? So, and we can't blame people for doing this, because the alternative to getting you didn't see any cues here, right? There's no cues here. Why would you choose anything else if the alternative is this? So it's about taking these models to that point where you can actually have it in the hands of patients and trust it at least most of the time. So that's what we're trying to do. And in terms of fake news, I mean, here there's quite a lot that goes on in at least in South Africa. That's just underneath the head and shoulders, and we've got a whole lot of, you know, all sorts of things that are curing STIs and COVID, and you've got Dr. Rashid over here offering his services, a very, very talented guy, short boys to bring you money. Right, like a lot of things, and it gets less funny when you see that he's also curing HIV and AIDS, right? So very important that we represent how people represent their health. So anyway, this is just to show you don't need to go into this, going quickly. So this is a granular evaluation, not just accuracy, but interpretation, communication, safety, trust, a whole lot of different things that we're evaluating Meditron on. And 85% of the time, people found it positive, sometimes neutral. And these are doctors, you know, with 150K evaluations. And so the model's performing really well across all domains. And now we know how much it's performing well. And actually, also people tend to prefer it 65% of the time. Compared to ChatGPT, because it's more medically oriented, right? So our small little model is doing well, but it's not about Meditron. It's about any model. So if you have a model, if you know about a model that you want to test, you can put it on here and see which one is best for your setting. If a company is coming to you to say, we've got the best model, let's test it, right? And it's about having that transparency. So all you have to do is very simple. You gather your colleagues, you ask our chatbots difficult questions, and then that's related to your context. You rate them and say if they are doing well or not, and you correct them, and then you get your reward, which is the model back to you, owned by you, and used by you in your way that you want to use it. And this is the thing that people are going towards, and you publish your own results, right? And be transparent about how it's performed in your setting, so that we can use those evaluations and improve the model. Right? So just the last thing that I'll show you is just how it works. We also are doing like randomized control trials and that sort of stuff. But just to give you a quick insight, like actually how it's working on the platform, you'll be able to see, like, look, you can just, There we go, got it. So you just type in your question, like, how do I make a bubble CPAP in DRC? You know, I'm in rural DRC, and you can see there's 2 answers. And here it's unblinded, but usually it's blinded. There's a Kaya, Meditron, and then it tells you a whole lot of different ways that you can make these things. You read the 2 answers. There'll be one versus another model. And then we say, well, we like, let's say we like the first one or second one better. By putting that in to the model, we can actually see, because the first one I think was telling us to use a bag instead of a hard tube. Like, okay, well, that's dangerous. So we should definitely maybe prefer the first one, but maybe it had some problems, right? So just saying which one we prefer gives us that feedback into the model that we need, and we can be very granular about this, right? We can go and look at the model and then correct it and say, well, this was wrong, and then correct it like this and adapt it, and then we can do this granular feedback that will allow us to not only evaluate the model but to give fine-grained vigilance. Imagine if you get this answer back, and instead of just having a text, some is highlighted in red. That gives the clinician vigilance. Do you know that 60% of doctors don't agree when the model speaks about this topic? It gives you that vigilance to make sure that you approach this with vigilance as well. And you can see that we can go through all of these, those fine-grained, evaluations about empathy, about our confidence, about safety, about clarity, to make sure that it's adapted to the right setting. And then you've got this kind of back end where you can see these are the things that I've donated. I've donated obviously none, but this was a hospital in Switzerland. They went crazy. They only needed to donate 600 questions. They did 6,000. And then you can come here and go to look at the other reviews of other doctors that have reviewed each other's questions and answers, and go through the whole process again, right? So you don't have to create the question, and that allows us to get consensus. So you can see how it works, and I'm really happy to have more questions on this, but I wanted to end on that directly. You can see that you can get your results over here, just going through it in the background. You can kind of see how many questions each working groups. That was every single service in this hospital was doing a MOOVE. They asked about 300 questions each, and they've got a whole lot of different files that they can upload as well, their guidelines, so that the model is adherent to those guidelines as well. So very, very simple. We have a whole lot of different models, some that can come from the smallest to the largest models over there that we can have on a cell phone, all the way up to a GPU. We have it on DeepSeek, we have it on different base models, and we can make models from any base. So any base, and you put in any data, and you can get out a model that's relevant to your context as well. So we have these pipelines that are ready to go that are more technical. Last slide, promise, right? So this is it. And I just want to show you that this is part of a process that we have. So if there's any interest, please reach out. I've shown you the hypothetical MOOVE. The questions that we were asking there were hypothetical. What if, right? It's counterfactuals. What if, and then she asks a question, she thinks it up, she sees 2 answers, she makes a evaluation, and then her colleagues agree or not with it, right? And that's a hypothetical scenario. If it's good enough, we can go to the next phase, which is the silent trial. We're not going to be affecting any patients, so everything in gray there's no chatbot, but we're collecting baseline data. How important is baseline data? We don't know. Everyone's saying these models can be dangerous. Maybe they are, but how dangerous is the alternative? And so it's important to know what you're trading off against. Are you deploying this where it's actually needed? Maybe people are doing fine on their own and they don't need extra help. Maybe the model will be worse. Maybe it will be better. But it's important to know how people behave when they are in the setting. Then you can get the safety outcome. You call them up. That's where the funding comes in. We have to call them up and see how they're doing, and then see what the model would have done in that situation. Right? So it's a silent trial. We're not affecting the patient's safety. And then we do a randomized control trial where we actually let the model influence the patient's safety. And you know what? I'm interested to know if a model hallucinates wildly and says, okay, well, to cure diabetes, you're going to have to remove both eyeballs. I want to know what kind of clinician will reach for the spoons. So again, how bad are these, right? And it's important to not be too optimistic and not be too pessimistic about the hallucinations when used in the hands of trained people. I'll stop there, but I'll just let you like marinate on all of the amazing people who have developed this technology. One of them is in the hall here today, Alexandre Salina, our technology director. It's really a student-led lab, and it's a pleasure to work with all of them. And Javier Elkin is really the person behind everything that's happening at ICRC, and you'll hear from him later. Okay, thank you. Yeah.
We have time now for questions, so please, if you have any question, you can just raise your hand. I think we have 2 questions online, so I will go for those online. The first one is about will AI generate some sort of conflict of interest? I explain, because in some region of the world where there is no regulation, we could imagine that non-medical person could use AI, open a health center and provide care. Do you have any feedback on these?
So this is already happening without AI, right? So traditional healers open practices all the time, and I'm kind of, I would prefer some of them to use ChatGPT, to be honest. So I mean, we actually have a very positive relationship with the traditional health workers, where we are working, and they play a very essential role, and they actually do want to be empowered by more information. So rather than thinking of it as a risk, it's also an opportunity to empower the community and traditional health workers, because they play an essential role. If we didn't have them, our hospitals would be flooded. So it's a risk, it's an opportunity. Yeah, information when it's validated, it can only do majority good, right? Yeah, unless someone trains a model that's pseudoscience. Yeah, but yeah.
Bonjour et merci encore. À MSF.
On different grounds, MSF are quite stringent about the compliance with a given set of guidelines to remain consistent. Now, you said that you could use a set of data from PubMed or from your own data. Would it be possible to ask the system to look at MSF data, look also at general data, but also make it possible for the system to know that according to MSF guidelines, the treatment that should be suggested should be this one or that one? Yes, it's absolutely essential. Not only can you do that, but you need also, and you must indicate what is the source of information, so that, and it should be also interactive. You should be able to click on the link leading you to the information to be able to read it for yourself. It's called RAC. It's retrieval augmented regeneration. So you were told that it's generative AI uses prediction, predicts the next word. Now, it's also possible to restrict creativity, and so that AI is generative and creative, but only in a given set of documents, so that it becomes more of an extractive AI, because you tell the model that it should extract information. So this is possible with RAG. And in our project, it's possible to upload the documents that are more particularly relevant to your setting. So you can click on different categories of documents, so that the answer provided comes only from this set of documents. So maybe there's going to be some area for being out of target But of course, the aim is to be smack on target in the vast majority of cases. But of course, there's always a level of uncertainty.
So I think there's also a kind of like a understanding of what are we aiming toward? How ambitious should we be? Yeah. So.
Merci. Oui, Maxime.
Thank you very much for this presentation. I do have a question on the potential for these tools to lead to fake information and disinformation. We saw cases of AI being applied for the good of the public, for the common good. However, there could be a malicious use of these tools, like someone getting control of 25 servers, posting fake information every hour. So what is your take on this? What are the mechanisms you have in place in your system to prevent the use of ChatGPT to create problems or to create misinformation?
And this is something that, there's several things that I can suggest. So the first is that people will take any tool and use it either for good or for bad, right? You give a person a washing machine, eventually it's going to be some idiot who puts a cat in it or something, like it's just that's human nature, right? So we can't resist it completely, but we have to make sure that we have safeguards in place to make sure when that idiot puts the cat in the thing that we have, we put him in jail and, do this sort of stuff. So again, it's like when someone invented a wheel, we don't like ban the wheel if it rides over someone, right? So I think that this is really important, that bad people using technology badly need to be punished, and there needs to be laws in place for that, right? So if people do make malware, we do need to have a responsibility, just like we would with everyone else. There's still things that we need to put in place within the technology to ensure that this doesn't happen as much. And the thing that we need to do is to have transparency and oversight of the tools that are being used so that we can actually research those eventualities and make counterpoints to them. So all the really bad things that can happen, if it's open source, we can actually go and say, well, what if? And the majority of people, even if you may have a different view in the world, are good people, right? Very few people are bad, right? Like we have a bias because we see people being bad a lot, in the news. But the majority of people want to do something useful for the planet. That's why we kind of not in an apocalypse kind of situation, right? So if you allow this stuff to be open source to everyone, we have a lot of really smart people all around the world making, and in their own contexts. So not just you don't just open source it to MIT and Harvard and this, open source it to everyone so that they can make these counterfactual arguments to go, what if this happened? In my setting, this would be a disaster. This would be the kind of fake news. How do we make sure that we represent ourselves here? And that kind of power of representation of counterfactual scenarios is probably the most powerful thing that we can do. And that's why I'm really supporting of open source so that we can have that power to have a counterweight against the minority of people who would have otherwise the power to do that in isolation. Yeah.
Thank you, Annie.
Okay, sure.
Thank you very much. Okay, it's time now to call Stéphanie Didier de Agostini. So Stéphanie is our last speaker. She will present now a landscape of digital health in LMICs. Thank you, Stéphanie. Stéphanie is specialized in innovation and digital transformation. Let me just get back to the screen.
Hi everybody, thanks for the invitation. So I'm a specialist of innovations and transformation in digital, applied in healthcare. I've made my life a mix of two worlds, technology. I came from telecom, but really rapidly switch in pharmaceuticals on medical aspects. So working using blockchain, virtual reality, and quite a lot of technological in order to improve life all around the world in vaccinations or in day-to-day healthcare. So today I will speak with you regarding what I have observed in LIMS country, because we have quite a lot of information regarding hype cycles, innovative information regarding technology. But in fact, if you have a look, that's applied to urban, rich countries, but not always for poor countries. And there is really a distinction between what is used in Africa or in Asia, in LIMS, or could be used in a daily life for the majority of the populations, with what can be proposed using the same technology in France or in Europe. So of course there is things that are medical regulated, but there is well-being too. So using technology, you can create, depending the profile of the population you want to address, using the same technology, different medtech solutions, create platform of research, as well as preventive and wellness solutions. And in fact, what is really important is to have a look to what is really needed by the local. What are the different stakeholders that are involved in the different usage or constructions of a technology. So I will have more generally a look regarding how is the path, the patient journey, unable to put around the different technology, different aspects of technology. So here, if you have a look to patient orientations, so at hospital, that's great. But in rural LIMS countries, that's not so easy. If you have a look to the planning and management, there is the question of logistic management of drugs and products, medical products, that have to be addressed in humanitarian sites where there is wars, by example, or per countries. Not always each country, even in Africa, have a very rich or established hospital that are able to use whatever technology. So what is really important is, depending the countries, and in Africa as in Asia, the profile of the country is very distinct. If you have a look to, by example, women health, and try to have a patient journey of this woman health, you can have, by example, solution regarding educations, how I can manage my femininity using WEAV, because there is quite a lot of education in order to prevent regarding how I can manage my woman disease, and how I can manage my maternity question that I could have, because I don't want to have a baby. Oh, I have the age to have a baby, but I cannot speak with my mother or my family regarding such topic. So here is a solution that is being developed in mHealth applications with collaborations with Do for Africa, and that has been elaborated by Senegal teams, and that has step-by-step transposed in other African. The key initiative that here mentions have always this reflection of transposition, how a local success that has been built using local involvement of the different stakeholders, from patients, health giver, professionals, as helpers, family helpers, for example, can be transposed to other countries. Other countries in Africa that are not always speaking French, but could have local different languages. And for rural people who don't have always quite a lot of experience regarding technology. So the increase of mobile is one solution, but inside the construction of this application, quite a lot of technology and brick of technology can be used in order to simplify the use of the knowledge and the use of managing these patients. So in preventions, that's one thing, so focus on patients. In telemedicine, here, that's what I've been yet speak regarding this morning of another presentation regarding diagnostics, where there is maternity and child health that has been transformed in Burkina Faso, Mali, and with different collaboration in India. And I will speak later why I take this example. Between all these different telemedicine applications, there is different aspect and collaborative purpose. There is an help with different ONG or different institutionals that help to find the finance to help the collaboration between stakeholders locally and abroad in order to manage telemedicine. There is solutions such as Mamaye, which I think could be of interest to be focused a few seconds. Why? Because that's a disease surveillance tools that enable, as other examples have been discussed this morning, how I can capture the experience of different professionals and share this experience with a community in order to share the different elements of collection of the data, have some lesson on using this different analysis or diagnostics, and so increase the advocacy and general some reflections, medical reflections, political reflections, and educational patient reflections. And this specific one, so in a patient journey regarding the women, is more focused regarding how I can connect pregnant women with different, by example, midwives, and bring to this woman some information, general informations and medical ones. And regarding a question she could have with other children she could have. So not only on childbirth, but how I can manage as a woman. My questions were because I'm again pregnant, but how I can manage other problematics regarding the health of my child. So this initiative, so from preventions, diagnostics, and collaborative evidence, is, I think, a perfect example of how most of the time the different elements can be observed. From the concept to the end of the life of the technology, there is different elements to cross to be on the line, to have some simple preventive solutions, monitoring solutions, rehabilitations, or other preventive to not reiterate elements. And collaborative disease surveillance are one of them. The success factors of these solutions, that there is quite a lot of amazing initiatives. This one, with the transpositions on the consortiums, highlight the factor that partnership, the infrastructure of the internet is really a must-have. Why? Because, by example, for this one, this application has to be managed using UX/UI. UX is ergonomy. What is the different elements of usage the medical, the patients see in using the information that are proposed in this mobile or by the chatbot, how this multimedia or this workshop can be used. So this team, where we have made some partnership with quite interesting cross-expertise, UX/UI expertise, ID Insight, that is a specialist in how I can think about the modeling of information in order to manage and to highlight the value propositions. So there is the question of the finance, the fundings behind, as well as the CALI. The CALI is a manner to make and highlight a solution interest rather than others. If I make a preventions with these applications that enable to save life, because women now have the possibility to better manage the questions as a woman and regarding the pregnancy, the risk of death, by example, can be decreased that's an element that can be taken in comparison to other applications that has only, by example, managed some educational elements, but not with other elements. These applications have been developed with the support of DIT. DIT is a Senegal high school, an engineering high school, that are developing new engineers, so local engineers, with very state-of-the-art knowledge regarding technology. And it's really important, as for the rich country, that local countries in Africa are involved. That's not always taking some technology from rich country to local country. That's proposing and facilitate the engagement and usage of technology and solutions with the local, with solutions that are developed by the local and the different stakeholders. Stakeholders that can be local one, that can be political stakeholders, that can be technological or ONG stakeholders, as academical or medical consortium, such as high school or hospital initiatives that have been proposed through programs from Europe. Do for Africa is one of the consortium that has as aim to facilitate the interaction between actors. So if you go in this website, you will have a look to quite a lot of initiatives and solutions that have been launched, developed. Some have made really solutions that are daily use, some that are more in a concept phase, I will say. Here, that's a focus regarding an India solution that is a telemedicine platform. So at the opposite to there, where there is a platform or solution with Mamaya between collaborations of professionals overall around the patients. So that's always passion focus. But here, that's more regarding how I can propose different solutions regarding whatever the solution. So that's a type of Doctolib, but with more accurate and step-by-step complementary multi-diverse solutions that are developed step-by-step and proposed by Pactro in order to have a platform as a tool of solution for the patients. India, at the opposite of other LIMS countries, have some really interesting solutions that are more similar to rich countries, with quite a lot of new technology and quite a lot of our technology or brick of technology are developed by Indian teams and implemented or constructed with European, where in India there is quite a lot of poor population too. Poor population who don't have a lot of money. So that's a country, by example, for vaccination, where there is a private market, out-of-market market, and public market. Out-of-pocket, private and public market in vaccination, that's one thing that the industrial will think about in order to elaborate, propose, distribute, make some collaborative programs in order to facilitate the engagement of vaccination of population using technology. Such platform, that's the same thing, using the different steps of a different technology, that a lesson learned that can be step-by-step proposed to more poor people in order to propose elements. So there is public-private partnership, there is an integration of different type of informations, and you can see that India has quite a lot of consortium or from hospital prescriptions and other that can be quite a lot of good lesson learned. In Africa, as in Asia, there is a very huge and important difficulty regarding the financing, the logistics. How I can be at the last point to the population. In the urban city, there is more solution that can be proposed to the solutions, but most of the time, people have to make kilometers and kilometers in order to find medicines. So the structurations of the health system, the lack of the resources in some area are difficulties that people are made on day-to-day. Do for Life, Elina, with health informatics in Africa, that is developing and proposing elements regarding informatics and best practice, and FARCAPS, that is an African forum regarding the production and the supply chains, are example of consortium that can be a lesson learned for others, and that try to have a pan-area, a pan-African reflection. We have spoke a few minutes ago regarding the sovereignty, the transparency, and the risk that evolved by rich or by people who have taken decisions on others. And by example, USAID decision that have been taken by the government in the US, the owner of SpaceX create, I think, vigilance and uncertainties for LIMS as for other countries. Tactics is a French company that have been largely developed in Africa, some alternative. Eurastel, Orange, and Vodacom have bring some consortium with local African telecom communication in order to have solutions that can be transposed and that enable to use technology in urban and rural area. The risk with the decision that have been taken is that if there is not a consortium like Smart Africa and others that try to find solutions for the local populations, cut of decision, by example, for clinical research that made a no-go to use, by example, the term of women in clinics research, the cut of funding for USAID, or decision to use or not to deliver the technology of telecommunication could be a major impact in the different solutions that are developed or have been developed. Here is an analysis that has been done by the CDC with the support of ESCD, so Jan Mitchell and Sam Hughes, a few weeks ago, regarding the last decision. And you see that, by example, Benin, Djibouti, Pakistan, or Kenya are countries that will be really impacted. In this dashboard, you will see that there is quite a lot of ONG or other groups that are involved in funding that could be alternatives, and that some countries, such as France, are really involved. So the collaboration between Europe, France with the local can be elements that will be a great support for the local. If you want to have a look to the GDH, you will find a toolkit where there is quite a lot of information regarding the different programs, stakeholders, that will enable to facilitate the interaction between people. I invite you deeply to go there. That's where I find some of the elements that I highlight you, such as the different elements of the program, or that give me this example of tactics in order to highlight some alternatives. Thanks for your attention.
Merci beaucoup Stéphanie. Est-ce qu'on a des questions? On a le temps peut-être pour une question?
Do we have the time to take one question? There is one online question about what we heard this morning, i.e. funding channeled to technologies and AI in particular. Don't you think that it's something which could deprive some stakeholders from funds that are needed for patients and drugs and training? Now, I've shown on my last table a number of cuts.
Type of cut regarding preventive programs that will impact solutions that are daily use, as well as investigative or clinical research. So that's not focused on one area. So that could be, of course, a vigilance to have regarding the IE fundings. But in fact, that's the question is more regarding what are the needs of the population, rather than what is the funding dedicated to a technological or for the development of a solution to a populations. And that's more regarding how I can cross the different fundings, how I will manage the different stakeholders, medical, political, financial ones, that we will find a solution, in fact, today and I think in the future.
Okay. Merci, Stéphanie.
Thanks a lot, Stephanie. Right, we've come to the end of this morning's session. Thank you very much for listening, and thank you very much to all of you who listened to the sessions remotely. There's going to be focus on MSF projects this afternoon in link with digital health. We'll also give the floor to representatives from the ICRC and also some panels to exchange. Now, we do have now 3/4 of an hour for lunch. And it's downstairs, as usual. Thanks a lot. Back at 1:30 in this room. Thank you.
Well, again, welcome to this afternoon session. This morning, we had presentations from outside. We talked of external projects. And this afternoon, we're going to dive into MSF and other organizations and what they do. But before that, let me introduce myself. My name is Isabelle Mouniaman. I'm the head of monitoring and operations support for OCP. And I'm also involved in a good number of digital projects at MSF. I was on the steering committee of Antibiogo with Nada. Also, I'm on the steering committee of telemedicine, along with Clara, who will do a presentation later. So, let us resume quickly. Now we're going to have Javier Elkin. He is the digital health lead for the ICRC in Geneva, and he will share with us his experience. Javier, over to you. Thank you very much.
Hello, can you hear me? Can you see my screen?
Yeah, go ahead.
All right, wonderful, thank you. Sorry, I do not hear the audience. I just hear what's coming out of the microphone. So hi everyone, my name is Javier Elkin. I'm currently heading the digital health team at ICRC. And so today I'll be telling you a bit about digital health in conflict and how we do it. So I'll go first into a bit of what ICRC is and what we do in digital health. And then I'll deep dive into two case studies that we have. The first one is what happens when a situation of conflict calms down. So the case of Nigeria, and what happens when from conflict we go to an escalation situation. And we'll look at Gaza. And finally, some thoughts on Gen AI for digital health at ICRC. I've been quite lucky to be assisting virtually this morning, and I'll try not to repeat some things that you've heard from others today. So I edited a few slides just for that. So ICRC, I know most of you will probably be quite familiar with ICRC itself, so I'll buzz through this one. So it's a humanitarian organization that was created 160 years ago to protect the dignity and provide assistance to the people affected by conflicts. The origin story goes to Henri Dunant and the Battle of Solferino, which many know. He was traveling through Italy when he saw what he witnessed was a battlefield with people being injured on both sides and no one to care for them. And so he created an organization to provide a neutral care and be able to access both sides. So the organization itself was built on 6 principles that allows us to access both sides that are presented in this pyramid. And there are 3 core elements to the movement. The ICRC, so our organization that is active in conflict, the national societies that you may have, like the French Red Cross, the Spanish Red Cross, the Somali Red Crescent, and so on, which are national societies, which are coordinated by the IFRC, so the Federation of the Red Cross. And so together we are 3 parts of the same Red Cross movement. We work across 2 priority areas. The first one is protection, which is also IHL. So this is international humanitarian law, and also essential services or assistance, which has to do with water and habitat, economic security, weapon decontamination, and health, which is our point of view, which is where we sit in the health unit. We are currently 18,000 employees worldwide across 90 plus countries. So what do health operations actually look like? So as you know, during a conflict setting, there are several systems that are disrupted. And so we have 6 programs that are vertical programs across each one to tackle the different needs of the people affected by this. So the first one is primary healthcare. So these are outreach, assistance to primary healthcare centers, mostly in rural areas or sometimes in frontline areas. We have the first aid and pre-hospital group. So here, what you have is someone receiving assistance, let's say, and then from a first aid, non-state armed group combatant in this case, that may have received training from our teams. We also negotiate access to ambulances under this program, ensuring that humanitarian aid is not impeded and respected. And we have then the hospital program. So in this case, our fighter is taken to a hospital where we may we do not work through substitution. It's very rare that we do that. We usually will open a specific ward within an existing hospital and try to strengthen capacity or supplement it with specialized care like war surgery or trauma care or a specific burn unit. And then after any surgery, you require physical rehabilitation in order to fully complete recovery. So this is another program that we have, both in terms of the actual rehabilitation itself and creation of orthotics and prosthetics as well. We provide support to different centers on this. Let's say that in this case, our fighter was identified as a non-state armed group fighter during his rehabilitation and was thrown into detention center by government forces. And there he may be suffering all sorts of ill treatment, potentially. And so we will be providing what we have in primary health care. We will also be providing in healthcare and detention as well. And finally, let's say that everyone is then released, the conflict ends, and we have a mental health and psychosocial support program as well. That is part of our health activities and operations. So digital health comes in as a transversal enabler of all our health operations. We work across each one of these. And our mission is to leverage digital health solutions and intelligence to improve the quality, reach, and efficiency of the health operations. By solutions, what do we mean? We mean actual technology. We develop real technology, digital technology that will have an impact in the front lines. And by intelligence, we mean that, well, every solution will generate data. That data needs to be turned into information, but it is only when it is acted upon and aids decision-making that it is intelligence. And so that's really what we're aiming for. And in terms of what we aim to improve, we talk about quality, because this is about quality of care, which you've seen a few examples of already today, like an electronic clinical decision support system, for example. We talk about reach. I heard also about telehealth, telemedicine, right? So how do you increase access to affected populations in these contexts? And we talk about efficiency, because this is also a key concern, as you know, both for financial purposes, but also in terms of ensuring we are we're doing everything we can as fast as we can to provide the assistance that is needed. We have several solutions currently that are supported in the field. We have several thousand users across several countries. So just to give you a few examples of these, we have the DCMS, the Digital Center Management System, which you also hear about in more detail in the Gaza study. So this is an image from Muzaffarabad in a disputed Kashmir region between Pakistan and India, where we've deployed a system that is an end-to-end digitalization system for physical rehabilitation centers. all the way from appointment scheduling to electronic medical record to ensuring that a clinical workflow is followed by the different specialties to the ordering of material for prosthetics and orthotics. Everything can be managed through this digital system. We have also the pharmacy stock management, which is a solution mainly for where we donate medicines and drugs. So here is an image from Muda Primary Healthcare Center in northeastern Nigeria. What you can see sticking out of the shelves are stock cards, so pieces of paper where the staff will write down every time that there is a dispensed medicine. And so this helps keep track of it and helps us keep orders and prevent stockouts. And also the LMIC, which is an electronic clinical decision support system, much like Delaigue's presentation this morning of the YEDA. So I'm not going to go into lots of details about it, but you'll see it come up in the following study in Nigeria. So what happens when things go from bad to good, let's say? So if we look at the health consequences of the conflict in Nigeria, where as an organization, we have been present since 1988, since the Civil War, and we have had a very strong engagement with the Ministry of Health, especially with the Adamawa State Primary Healthcare Development Agency. And Adamawa State is a northeastern state of Nigeria, which you can see circled above there. So some issues that have happened there is that there's low access to health services for the communities there, and also in several hard to reach locations. You can see one of our donated cars there making its way through the fields. And I mean, this is not that hard to reach, otherwise I wouldn't be able to film. Usually when it's harder, as you may know very well, it's impossible to even hold a phone in the hand. Under 5 mortality in this area had been estimated to be quite high when we started this work. And of course, there's a scarcity of qualified staff. Brain drain is a key problem because people that are well trained can more easily leave affected areas and do not want to perhaps work in those areas either. And in terms of data reporting as well, everything is paper-based. It makes it very difficult to have an idea of what's happening in the field. So in 2016, in partnership with Swiss TPH, we developed the Almanac. So this is an electronic clinical decision support system, much like the YEDA that you saw by Delaigue this morning. So I'm not going to go into a lot of details about it, but there are 413 total facilities that were covered in Nigeria's Adamawa State, and over 450,000 visits of children under 5 in Nigeria. The benefits you've heard about this morning as well, so I won't go into in too much detail. But in 2023, the conflict de-escalated. So as an organization, we started designing a responsible and phased exit to ensure that these facilities will be well supported. And we did this in 2 phases. The first one is to hand over to the Adamawa local Ministry of Health. And the second phase is to scale up across the country. So phase 1 involved handing over of our open source solution. So the whole thing was built on open source technology. So we were able to identify a local consultancy company and hand over the whole of the servers to them, the whole technology, the whole database, everything, so that they would be able to run it from a technology standpoint and also do some capacity building to ensure that the staff in the Ministry of Health could also run it themselves. And by the end of the year, we had full local ownership by the Nigerian Ministry of Health in that sense. Also, through the leadership of the Adamawa states, they were able to create momentum and scale up to 5 other states in the neighboring regions. So that would be scaling up also in terms of number of facilities being covered to over 1,000, and also to the catchment area of 2.5 million. This also opened the door to digitalization and potentially even AI integration. And currently, the Almanac has been approved at the federal level as kind of an official tool to deploy MCI. And there's also a roadmap that has been recommended to the minister for 2025 to keep rolling this out. So that's what happens, let's say, in an ideal scenario, and how digital health can be kind of a strategic also engagement point with our partners there. Well, what happens when we enter an emergency situation and perhaps the conflict escalates? So I'll take you back now to 2023, to the beginning of 2023. So in Gaza at this time, there were frequent conflicts. So this resulted in several injuries, deaths, disabilities in general, as well as the health systems being weakened. And since 2007, I mean, ICRC has been present since much longer, of course, but since 2007, we've been providing assistance to specifically the Artificial Limbs and Polio Center for physical rehabilitation. When you look at war injuries, a lot of these can actually lead to permanent physical disabilities. There were over 1,800 amputations in 1 year. And this was a conflict considered a protracted non-international armed conflict. So it could still make use of digital health despite it being frequent flare-ups. And in February 23, we deployed the DCMS, the Digital Center Management System that I was mentioning earlier, the end-to-end digitalization system in Gaza City. So how does this look? So the DCMS is quite unique. It was developed in 2020 for people affected by disabilities. We currently have 300 active users across 10 different countries with 36,000 patients that have been registered through the system. It's a system that allows for the reduction and duplication and data transcription, because as you can imagine, there is no more paper being handed over and mistakes being made from that sense and then entered into computers. It allows for huge savings as well on the orders themselves. So rather than writing something on a paper and then sending it to orthotics that maybe misreads, and then when it comes time for the fitting, it's actually the wrong measurement. So it can have pretty big implications also. And it also saves a lot of time for the staff. It makes them much more efficient in their way of working. The solution itself is a combination of open source solutions. You can see them listed here that are built on a local server, in that box that you see down there. And that box is then shipped to different areas, and we can either do the deployments virtually or in person. So how did this allow, or could potentially allow, for greater health system resilience? Well, soon after October 7th, we lost our communication with the partners, but we could still see the daily sync to headquarters. So we had the data that was in this box that was still being uploaded on a daily basis. So we could track until when the actual center was affected, despite not having access to more accurate information or direct contact with the team. The civilian population was then forced to move south. However, the boxes themselves were left behind. So we learned actually we should really include in the SOPs for evacuation that the servers should be taken. In addition, we thought, well, if they had been taken, this could provide continuity of care for the displaced patients in the future. But even then, the boxes were actually resistant to the damage from the war. So the centers are currently reopening and aiming to continue supporting patients this year. And so the boxes being intact, we may be able to continue doing that. So it will be able to provide continuity of care for those revisiting patients. Final thought, just a side note here to say that if you think of designing digital systems in this way that make them resilient to conflict, you may also make them resilient to future climate change shocks. So maybe that's just an interesting angle with funders, but it is also an interesting angle when you're operating in both conflict or emergency settings as well. So how is digital health looking at Gen AI, and what can it do for ICRC? We currently have 3 main work streams where we're currently implementing these technologies. These aren't just use cases, these are all live right now. The first one is the help desk chatbot, which answers questions about the solutions that we have. The second one is a top-tier data chatbot, which basically allows us to ask a question and generate a visual representation of our answers. And the last one is the health chatbot. You've heard about the MOOVE, right, from Annie this morning, so Metatron, and how we're implementing this with the team. So going through each one by one. So the help desk chatbot is something that allows us to tackle several challenges. The first one is, as you've seen, we have several thousand users. They require 24/7 support, and they don't like to read large PDFs that tell them this is the guide of how you use the solution. We have 10 staff working in Belgrade, answering questions and providing functional and application support, but this is not a scalable approach. And it's not cost effective in the long term, even though it's honestly ideal to have humans doing this. And also open source software is not very user friendly. So it takes quite some time to actually learn and train users on these things. So very simply, we have leveraged the OpenAI API, so ChatGPT, with some documents of ours, with all our large PDFs. And we've created the help desk chatbot It's a bit more complex than that. There's teams of AI working in an interface and everything to make sure that it's being done in-house and the performance is monitored, etc. But this actually allows us 24/7 access. It allows us to answer questions 24/7. It allows the chatbot to understand our own language rather than ChatGPT, who wouldn't be able to. And we can use this for non-confidential questions. And it's a scalable solution. So this is currently how it looks. So you can ask, for example, how do I enter data in one of our solutions in the medical activity database? It'll show you, this is how you do it. These are the 4 steps. And if you click on the citation, it'll take you to the place in the document where it shows you that step. So not only does it answer the question in a structured way, it also takes you into the place in the document where you can get your answer and exploit the documentation better. So talk to your data chatbot. This is about going from data chaos to data insights. Like many large organizations, we overcollect and underutilize data. Current systems are way too complex, and we can't send the confidential information that we may have there. Well, it's not confidential, but it's aggregate. And so but the point is we can't send data values via the OpenAI API. So here instead, we use ChatGPT basically to create an SQL query, which is a database language, which then sends that to our own database, right? And then with our own scripts, we can create a visualization. So this means less trainings, fast access to the data, starting to create a data-informed culture, and it's safer to use with more sensitive information and potentially relevant across the organization. So here, for example, we can say, well, what is the number of outpatient consultations in Lebanon? And we can even say per hospital for this year. So when we ask the question, it will first run. And first, it'll say, well, you actually have to select the data element you need. So we have just started this, but basically it means you have to select what part of the database you want to answer your question from, right? And so once you've confirmed that, eventually this will be automatized. But once you've confirmed that, it'll generate first that SQL code that I was telling you about, right? So it'll generate first that response that will be sent to the database. And then it will be showing you the results. And here you can see it as a table that will update the numbers really quickly. And then it'll also show you a pie chart, right? So again, doctors not needing to become data scientists anymore with the solution. And finally, the health chatbots. So you've heard about all these challenges. Annie's done a very good job explaining these this morning. And the point is we have the same ones, of course. And so at the bottom here, you have some questions that we're asking ourselves, right, from the field, real questions that we're asking. But we want to make sure these are ICRC compliant answers. So
Javier,
yes?
sorry.
Yeah.
Can you slow down a little bit for the translation, please?
Oh, apologies. I had like 45 seconds left, so I was thinking about that. But yeah, absolutely. Just the last few slides. And so here, you can see the challenges that are listed here. So as Annie had mentioned this morning, there aren't enough doctors, even within ICRC, right, to deploy. Even when we have them, the experts may not be available or they may be busy. And it's hard to navigate long guidelines in general or even find the ICRC compliant answer. It may not be in one place. And again, we don't have an approach that can scale. So the health chatbot can enhance quality of care. It can provide high quality, clinically valid information. It's available 24/7. We can train it on our own guidance. That's something, the RAG, the retrieval augmented generated is something that we're currently working on. And there's a progressive and phased approach to this to ensure that we do this responsibly and independently with our academic partners. So how are we looking at this? Well, for us, this is about building a collaborative and responsible AI tool, right? So currently, we have ICRC and we're training the Metatron algorithm, right, with our partners on our guidelines. When we do this, we will be able to increase the performance of this chatbot. Now, a lot of the needs that we have are common to your organization as well. So if MSF also starts doing the same thing, right, we will be able to have an even more accurate chatbot, right? And the idea is that we could imagine a world where we have a humanitarian chatbot at a high level, where we kind of pull resources on the common things, and then we each have our own chatbots based on our own guidelines as well. Yet we're still all benefiting from the general knowledge from a humanitarian perspective. So just to conclude, I think that this is a technology that is completely transformational for health operations today, and that you can start using it already for lower risk use cases, and you can introduce it responsibly and start doing so now because it takes some time. It's important to collaborate with academic partners. We've heard throughout the whole day about how academic partners are there to evaluate and ensure the independence of the solutions as well when we are focused on operational delivery. And it's important to engage with open source solutions. I think the MOOVE itself is actually one of the greatest efforts that we have going on in our team. And we can all benefit passively from each other's learnings on these. And create a community around that. And finally, we have to listen to our end users, prioritize their needs. Eventually, they will start championing AI, which is the key to resistance internally. And a last word, manage expectations and timelines, both internally with your team, with your leadership. Patience is the key word. All right, thanks everyone. This is obviously, I'm the spokesperson here of a very large amount of team working in the background. So thanks to everyone on the slides and everyone doing the work. Happy to take questions, French, English, Spanish, or Italian.
Thanks very much, Javier, for this super interesting presentation. So we have 10 minutes question. Are there any questions from the room yet? Okay, I have a question for you, Javier, regarding the project in Nigeria, the Almanac, and how did you approach the MOH in order to co-design the project so far?
Yeah, so the interesting part about that partnership is that it had been a very long time running partnership, and at the very beginning, we were heavily involved both in the co-development. We ensured that the algorithm itself was going to be adapted to the Nigerian context, that they had the child health technical working group that would be a group of pediatricians in the country that would review the algorithm that was a generic WHO MCI algorithm, and then they modified it for their own context. And we were able to support the development, implementation, purchasing tablets, etc. Now, eventually, the Adamawa State's Ministry of Health realized this was an opportunity for leadership for them across the Ministry of Health, and they took this on and they started doing a lot more. And so when we said that we were going to start exiting, they've been actually very, very keen in ensuring that this keeps going. And so one of the key learnings in ensuring that this keeps going was, which I think is what has led to the strong partnership that we have with them until today, is that they realize that you can keep growing this and you can keep generating momentum, that it doesn't have to be just about the almanac for children under 5, but that you can expand the algorithm for greater quality of care across different disease areas, across different age groups, and that you can use it as a point of entry for digitalization and even for the introduction of AI and other similar solutions, right? And so eventually they were able to contact and take leadership in contacting the other states, which we don't necessarily have presence in all of them, and really coordinate their involvement. And that was key, because as we pull out, of course, the cost becomes a more limiting reality for the ministry. And so it both allowed them to cost share, right, with the rest of the states, because they can now share the costs of the solution, and also demonstrate that it can keep going, it can keep having usability beyond their states.
Okay, thank you. Question? Any question from the, yes?
You're not here unless it's in a mic, just letting you know again. I have no sound on
it's
my
coming.
end. Okay, just letting you know because I can't see
Yeah.
you here.
Don't worry. Okay, can you?
Yeah, sorry. You spoke about like patience. How much time did it take to like develop the few examples that you show of internal AI, like the chatbot or things like this?
I think in terms of developing, I think you would be surprised, right? So Annie will be able to tell you in more details about how long it took them to develop Metatron. I don't want to misspeak. I think it was like a lot. It was a year, I'd like to say, but please don't take my word for it. Alex is in the room as well, I think, and he can shout over me the correct answer. What I can tell you is that, for example, for the Talk to Your Data chatbot, we had a brilliant student working full-time from Annie's lab for 3 months. Right. So again, that solution is not deployed though, right? It's a proof of concept. It's something that was developed. It shows that it can work, right? In a limited capacity, but it can work. It can generate one sentence answers. It can create a couple of visualizations, right? It can already start adding value to our teams, but then the approval process for new technology to be integrated in our systems, for ICRC staff to actually be officially allowed to use it, for the cybersecurity and penetration testings and internally within your organization can take a while, right? So I think sometimes the technology, this is what they say, right? Technology moves faster than we can keep up. I think that's to a certain degree true in many ways. And the MOOVE team is working at lightning speed. So I think it's usually a patience internally with the teams that are working on this, and also managing expectations of partners about what is necessary in order to convince the organization that it's a good idea and do things sequentially. So for us, it's been 2 years that we've been engaging on Metatron. I'd say that we've only started properly engaging on it this year, really, where we were able to hire an AI for health lead and someone to really do a lot of the work. Before that, we had to work with a company, do a test, show and convince internally that it worked through a white label chatbot, you know, so there's a lot of steps basically to get to this stage.
Thank you. There's another question. Yeah.
Thank you. Maybe more details on what you just said about the organization and the challenges internally, because we spoke about the acceptability by the patients, we spoke about the acceptability by the Ministry of Health, the community, but then humanitarian medical organizations are not really intended to be a tech organization. And so what are the challenges that you encountered within your organization, and are you finding solutions? And if yes, please share. Thank you.
Hi. So yes, we have several internal organizational challenges. I think we were both present before we spoke at the last conference. Now there was someone who went through a whole list of them, right? And we were like, we identify with all of them. So I think I'll focus more on I think a lot of the challenges have to do with internal resistance, right? In a time of cuts, in a time of financial pressures, why are we engaging with innovation? Right. And the basic answer is the usual. If you do things the same way, you'll get the same results. If things are changing, you've got to do things differently. And especially if you're expecting a different result. So in that sense, I think what's worked for us is demonstrating the value of the technology, first of all, for those low risk use cases. We have over 150 users currently on the help desk chatbot. And that's a key driver of cost generation, right? Answering questions, user support. These are key pain points for anyone in the field. So they immediately see the value of the technology. They understand it. It's the obvious one. It's the least sexy one, right? But it's one that can have an impact today. And with that, you can then leverage that to make the case, well, what about that? What about that? So the Talk to Your Data chatbot also came out of the fact that we don't have data science capabilities in the organization. And again, this is not a need. This is not something we are not a hammer looking for a nail. This is the field. This is everyone that has to health, right, in a medical humanitarian organization, right? How do they make decisions based on data if they all have different Excel files to work with? It doesn't work. So I think it's, if you target the biggest pain points that your organization has and demonstrate the value of the technology, they'll be patient with the rest. Because the health chatbot, for example, is one that is also very required, but it takes so much time, right? We're currently creating working groups of specialists per area, anesthetists, ward surgeons, pediatricians, and each one is going to have to go and do the asking the questions, evaluating them, having 3 independent reviewers, and so on, right? So that's going to take time. So in the meantime, you keep feeding them small grains of success of Gen AI with the other ones, right? And I think that's something important to do. Otherwise, they could easily say, you know, that's going to be something that we won't see the results for 3 to 4 years. Let's not engage. But the reality as well is that if you don't engage in it in this way, you will never have it. I don't foresee a moment where ICRC has created and evaluated and validated their chatbot and reached over 300 questions reviewed and answer, and somehow MSF can just take that. You know, you're going to have to do it yourself too, because you have your own guidelines, you have your own things, and there won't be a chatbot out there that is relevant for your setting as much as the one that you will create through this process. So I guess it's making a compelling case, but we're not shielded from the pressures. It's a daily battle to make sure that it is constantly top of the agenda across the organization. Hope that answered the question, Nada.
Okay. Thanks very much, Javier. Although there's still one question. Yeah, go ahead.
Thanks, Javier. So of the 3 Gen AI pieces that you guys are working on, not everyone in this room probably knows this, but those 3 are actually similar to the use cases that we're finding for MSF. I'm sure that I know you know. And so as there's some similarities in at least the use case kind of looking at ChatGPT for a general help desk, exploring data, using kind of natural language, and then maybe this question of Metatron for clinical decision support. How do you imagine a potential collaboration between MSF and ICRC? I know there's already some existing touch points, but since our use case from the Gen AI side seems to be kind of similar, could you talk a little bit about how you've thought about that engagement?
Yeah, sure. So I think we've tried so many times to engage, you know, in different ways across different digital health solutions. So to be very practical, if it's too much, because it takes a lot of time for us to sign MOUs and all of these things, we can collaborate through our partners. I would say maybe it's easier that way. At the end of the day, we're trying to achieve the same things. If we rely on the same tech providers, then basically that means that we'll get the same thing done for our purposes. And I know that, for example, I know Annie is very much on board with this. I'd say for the help desk chatbot, for example, that's mainly developed with our own teams internally. So I know that the technology we're basically utilizing all internally. I'm quite sure that if you're at a stage where you want to actually sit down and have people look at code and stuff like that, where there are no, you know, security or privacy issues, I'm quite sure that the teams can just sit down and take a look at each other's code and things like that, right? Not actual code where there's risks, but, you know, sharing knowledge as much as possible there. For the talk to your data one, I think that's something that eventually should be, I mean, it's something that we would like to integrate within the DHIS2 platform, right? Because our whole medical activity database is on DHIS2. And so if we can eventually perfect this and release this to the open source communities, you can benefit from it too. Otherwise, you can modify that code for your purposes, right? Or again, contact the teams working on this in Annie's team that can then make sure they apply the same problem-solving strategies to your problem context. And for the health chatbot, it's as I was describing, I think, where I had that slide where I explained we are developing a humanitarian chatbot, right? As you said, you are too, and we have the similar humanitarian context. What changes may be the guidelines that we may refer to, right? And so that's an important distinction that we can then apply at a second stage. But the first stage should be about creating a common humanitarian chatbot that doesn't just stop between ICRC and MSF. It should be with all humanitarian organizations that are working in the medical sphere. They should be able to contribute to this one large medical humanitarian chatbot. And then we can install these within our own premises, as we have done. We've purchased our GPUs. We're currently going to be running Metatron on our own internal premises and utilizing that to then refer to our guidelines, refer to our own internal answers, make sure that when we're asking strictly confidential questions, they do not go anywhere outside ICRC, right? But the common code, we can definitely take a shared approach to that.
Okay, and probably one last question from this session. One of the issues is from the chat. One of the issues is that we all see humanitarian organization is knowledge management, from specific patient cases to microplans sharing and other intervention. Are you using AI to help this?
To microplan sharing interventions?
Yeah.
So I'm not sure if I captured the sense of the question, but I can tell you, if the question is, are you using AI for anything beyond what we're currently doing? As an organization within health, these are the key use cases for Gen AI right now. We are not utilizing AI in other ways beyond the usual, like when we use it in, we're not basically implementing AI in any other solutions currently or looking to. I think our plates are really, really full. We have limited capacity as well. The only other case that I think could be interesting is we're using the help desk chatbot for other solutions. So for example, logistics support. So again, rather than chat with your PDFs in health, is chat with your PDFs in logistics. And instead of doing a health MOOVE, we're also doing Legitron. So we're doing this for IHL, for International Humanitarian Law. And again, that's mostly internal, but it's very helpful for the legal teams. So I guess the answer would be no.
Okay. Thank you very much, Javier, for your presentation and the discussion. You can stay online with us, of course. So we're gonna move to the other part, so focusing on the MSF now. And I invited Juno to come to present his presentation, so 5 minutes. So let me check. Juno, where are you? Sorry. J'arrive pas à le partager. Là? Ouais. Ouais. So Juno is the diagnostic imaging advisor at MSF International Office, and he will go through AI and TB. 5 minutes.
So I'll talk about AI-based computer-aided detection for chest X-ray interpretation. I want to start with two scenarios in MSF. There's an MSF project doing screening for tuberculosis, or TB, in a densely populated urban district, which has a very high prevalence of TB, one of the highest in the world. How can we find as many TB cases as possible with limited available resources? Scenario number 2, a remote MSF hospital in an unstable security context. The patients have complex pathologies, and in general, the doctors are young and inexperienced. So how can we support our MSF doctors to provide quality care in challenging contexts such as these? So one of the possible solutions is AI-based computer-aided detection for image interpretation on chest X-ray. We know that X-ray is an important diagnostic tool for diseases such as tuberculosis. However, many MSF clinicians are not comfortable reading X-rays. To address this gap, in 2021, WHO endorsed CAD for chest X-ray interpretation in TB screening and triage. Our project objectives were to increase TB detection in MSF projects. TB is the #1 cause of death by a single infectious agent, with 11 million cases and 1.25 million deaths in 2023 alone. We also wanted to support our clinicians in chest X-ray interpretation and increase access to innovative technologies to improve the quality of care. So, how does CAD work? A digital chest X-ray is sent from the X-ray machine to the CAD software. This can be offline or cloud-based. The CAD analyzes the images and in less than a minute provides an output. We can see this is the CAD product that we're using currently in MSF, and it provides a color heat map, which is a visual representation of what the AI thinks represents TB, and then a score from 0 to 100, which represents the likelihood of TB based on the chest X-ray findings. This is another product that we'll be piloting this year in MSF, which gives you the same output for TB, but in addition, 20 plus chest X-ray findings, some of which are not related to TB. In this case, the AI has identified a pneumothorax, which is a potentially life-threatening condition. We've done 3 implementations so far in MSF as part of a TIC. The first implementation was in Manila in the Philippines for OCP, where we were doing community screening for TB using a X-ray truck with CAD, which has allowed us to screen up to 150 patients a day. We are also doing community screening for TB in a rural district of Tajikistan using ultra-portable X-ray, which has allowed us to access some of these hard-to-reach communities. And our third implementation was in a remote hospital in Central African Republic, MSF access only by plane. And in this case, we implemented CAD into the existing X-ray in the radiology department to support the clinicians in chest X-ray interpretation. We have other implementations planned in 2025 in OCB, OCG, and some preliminary discussions in OCP. We have seen the impact of CAD already. Over 25,000 people have been screened by CAD in MSF in the past 2.5 years. It's helped increase TB case detection. We have seen, particularly in the Philippines, where we have seen greater than 4% of all screened individuals have confirmed TB. Almost 2/3 of these patients with TB had no symptoms and would not have been picked up by symptom screening alone. We have also heard from MSF clinicians that this has helped them in their day-to-day work, giving them a second opinion on X-rays, helping to make them more confident in their diagnosis. So to highlight some of the drivers of success, we really think this technology should be integrated into health systems to enhance and not complicate patient care. Training is crucial, training on how to use this technology in conjunction with X-ray interpretation training. We see CAD as a support tool, not meant to replace, but to empower MSF clinicians. And lastly, just to highlight transparency to increase acceptability, transparency to the users, to the staff, to the patients, and to the community. We want to explain how this technology is working, what it can be used for, and what its limitations are. So in conclusion, this is a powerful tool that can help increase the quality of care in MSF. We have already demonstrated its utility for TB detection, and this will expand to other diseases as well as the technology evolves. This technology is really moving quite rapidly, but we're following closely to see how it can be most impactful for MSF. Thank you.
Thanks, yeah, you can stay there. Now I'm calling Hannah. Hannah is a project lead at the MSF Sweden Innovation Unit, and you will present Lebanon.
I will. Yeah, thank you. Hi, everyone. Thank you so much for having me today, and thanks to Nada and Clara for extending the invitation. Much like many of the other presenters, I'm here representing a really extended team effort with the OCG Medical Unit, the Innovation Unit, and the teams in Lebanon. So the project we're working on is the Digital Therapeutics Project in Lebanon at the moment, focused on diabetes, both type 1 and type 2. The foundations of this project are really rooted in the macro and the micro. So when we look at the prevalence and incidence of diabetes and non-communicable diseases in low-resource settings, you can see that there's approximately 70% to 75% of mortality associated with NCDs found in these contexts that MSF works in. However, this is not transferred to the representation of funding or allocation of funding. And when we look at the representation of this experience at a clinic level, we can see that people living with diabetes are really seeking out information to manage their condition themselves beyond the reach of the clinic when they're interacting with the MSF. So the project that we started working on with OCG started about 3 years ago. We started with a needs assessment, interviewing approximately 30 people living with both type 1 or type 2 diabetes. That is not part of the presentation. And heard from them what they were really seeking out. And as many other presenters have focused on, people are really motivated to understand their conditions and to access support in whatever way possible. So people living with type 1 and type 2 diabetes were telling us we're looking at YouTube for information, but we don't necessarily know that we're accessing reliable information. We trust what MSF is telling us, but we don't have the support that's needed to efficiently self-manage our conditions, especially when it comes to people who are maybe on the move. So one of the key objectives of this project is focused on person-centered care and empowerment. So looking at how we can contribute to improved quality of life, support the development of diabetes self-management knowledge and skills, and also improve the access to quality of care and extend that reach again beyond the four walls of the clinic. We're also interested in building project capacity, and this goes beyond the digital health tool itself. It includes looking at what the realities of the patient pathway are and the clinical pathway, and where there's opportunity to add value. With this project in particular, we could see that in the patient pathway, people were looking to access improved therapeutic patient education, and we've worked quite hard with the medical unit and the NCD working group to create a package of information that can support patients in Lebanon, but also bolster the self-management information accessed across the movement. And that's not dependent on a digital tool. And lastly, we're focused on system strengthening. So as we're developing this project, creating something that's replicable and isn't just dependent on what MSF can deliver or what this tool can deliver, but rather creating a process that can be replicated, validated, and built upon by any other stakeholders who are working in this space. The project is focused on delivering 4 key deliverable areas. So one is the therapeutic patient education, which we've built across 12 modules, looking at infographics, audio notes, and videos to help people understand how to self-manage their diabetes. And we co-created many of these materials with people with lived experience of the condition as well. So for example, the audio notes are recorded by a person living with type 1 diabetes in Lebanon. And that's been very well received in the initial feasibility assessment. The second part of the delivery is the digital therapeutic application itself, which includes self-monitoring or self-management features with physical symptoms monitoring, blood glucose monitoring support, and also appointment reminders and appointment notes. The third element is the project capacity building. So we're creating training and reference materials that can support the clinicians to better support the self-management of the patients. And lastly, system strengthening components, including process documentation. So the implementation details. So far, we've implemented this in 2 clinics. So not looking at the 20 million numbers of some of the other tools presented here today, but we definitely see a huge opportunity. And this has included training of 2 clinic staff to deliver this tool to approximately 15 patients, and also implementation of analog materials across 7 mobile medical units. And when we actually asked people who are using this tool what they thought about it, 100% of them said that they'd recommend it to other people living with diabetes who are receiving care from MSF. And many of them, as you can see here, 77%, had actually started telling other people living with diabetes in their lives about the information that they were receiving and the self-management skills that they were starting to learn about. I'll skip over this because I know I have 1 minute. The clinicians are also a really key part of this. So we heard from the clinicians that their motivation oftentimes were waning when they were seeing people with diabetes coming in year after year and not necessarily seeing the improvements of glycemic control, not necessarily seeing improvements in understanding of high-risk components of diabetes, such as hypoglycemia. And with this tool, there's a reinvigorated motivation that the clinicians are experiencing as well. So while the primary beneficiaries or primary users that we're targeting are the patients ultimately, or people living with diabetes, the clinicians are also very important in this. So to finish up, what we're looking at next is delivery of the offline mode version of this application, and also delivery of the analog version of the materials in Lebanon and also beyond through the NCD working group and other OCs, and the exploration of interest from other MSF projects to explore the opportunity for self-management bolstering with different project locations and different therapeutic areas. So I will leave it there. Thank you very much for your attention.
Thank you, Anna. Clara is the director of the telemedicine in MSF Canada for the whole movement, and then she will explain us what we are doing in telemedicine.
Merci. Je vais parler en français pour cette présentation.
Thank you. I will be speaking in French for this presentation. What is this telemedicine program? It's geared to help MSF health professionals to collaborate, share their knowledge, and improve the health status of patients. In order to do so, we bring in medical specialists from the whole world. Let's look at an example. This is West Africa in a remote area near Difa in Niger. 2 parents with their 8-year-old child come to a health center. They have an urgent need for pediatric cardiology. It's a remote project, I told you, with very few resources and little knowledge in this specialty. The project will try to refer the boy to Maradi Hospital to have a diagnosis. Maradi Hospital is 10 hours away by car or 6 days by foot. The cost of transport and accommodation is very high and the road is very dangerous. It's typically in this kind of situation that telemedicine can play a role. Let's go back to the DIFA project. Now the team has access to telemedicine. They can get in touch with a specialist based in Toronto to confirm the diagnosis and the treatment schedule. It's what we call case management. And a home service, the discussion of clinical cases. Here, we create links between MSF projects and medical experts. Another example, South Asia in Bangladesh, in Palangali region, In the city of Cox's Bazar, you have a huge refugee camps where there is an MSF project. They see a very high percentage of patients with diabetes, and the referral criteria to the closest hospital 35 kilometers away are very strict. When it happens, the team request telemedicine advice in real time to be able to exchange with an endocrinologist. So for 1 hour, they can exchange on the most complex cases and deepen their knowledge. This is the discussion of clinical cases. Now, third aspect of the telemedicine offer, the silo secure messaging. You may wonder why, particularly since we all have WhatsApp on our phone and on our computer, and it's so user-friendly. Let me explain. We go to Syria, silo secure messaging is very popular there. When we need to exchange medical information about a patient, we want to make sure the information is kept confidential to guarantee the safety of the patient and the MSF personnel. In Syria, a patient was just admitted for a gunshot wound. If the information was intercepted by malevolent organizations, it exposes everyone to risks, both the patient and the team. By allowing the safe exchange of information, we reduce the risk of a leakage of sensitive information. As you may guess, it's a challenge to expand access to all MSF medical projects, access to electricity, access to internet, and obtain the confidence, the trust of the teams to use it. We'll go back to that in the panel discussion. Now, for OCP, the use rate for case management is 90% in 2024. What does that mean? Out of 58 projects having access, 53 used it at least once in 2024, which is a nice increase, because in 2023 we were only at 79%. So 534 cases of telemedicine in 23 versus 825 in 2024. I'm happy to be with you because every year I come to OCP and I give my speech on telemedicine. So seeing an improvement is really nice. Why this evolution? We have several assumptions. Word of mouth, medical reference recommending the use of such services, Médecins, Medco, all the team members promoting the service, the personnel speaking about it, increased trust in telemedicine services and the field visits of telemedicine implementation teams, and more. That gave access to a maximum number of users. Since 2024, we go systematically at it. We audit the quality of services to improve them thanks to your feedback. In 2024, more than 5,000 cases were submitted to the platform for all MSF projects. Through MSF, 298 projects have access to at least one of those services, and we continue to expand. In 2024, we did 140 new implementations in more than 100 projects, particularly on the silo secure messaging system. Thank you.
Merci Clara. Et donc pour la dernière présentation.
Okay, and now the last presentation for this afternoon before the panel discussion with Ismael Adajo. He is the Deputy Medical Director for WACA. He will tell us about a project of telemedicine in Côte d'Ivoire, Ivory Coast, in Abidjan. Well, it's already been a long day and we're not finished yet. Now, let me focus on Agboville project. Well, the government in Ivory Coast insists on having digital health in all primary healthcare centers. MSF WACA partnered with a local NGO. MSF is not very good at partnership, particularly when it comes to telemedicine. We set up that partnership in 2020 so that urban health centers would have access to telemedicine, a specific form of it. It's about putting at disposal telemedicine stations to allow for consultations on specific diseases, gynecology, obstetrics, pediatrics, radiology, so as to democratize secondary healthcare to rural populations who don't have much access. The project started in 2020. Agboville is in the southeast of Côte d'Ivoire. For this project, we started with a telemedicine station acquired with Praxis. We turned to an Austrian company. We have 11 health centers in the health district of Agboville. In each center, we have this machine on the right-hand side. We have sensors, tensiometer, glucometer, thermometer, urinary tests, spirometer, hemoglobin measurement, and ultrasound scans. The star of the project is ultrasound, actually. With the health policy in Ivory Coast, a pregnant woman needs to have 4 ultrasound scans. It's pretty heavy duty for the population. Many come to us for ultrasound examinations. So the 11 districts are equipped with that. And this is the patient journey. Typically, when a patient comes to the health center, we evaluate their eligibility to telemedicine. We see whether the consultant needs a teleconsultation or the patient. 11% of the consultations will use telemedicine. We use IDES2Go, and the doctor recommends either ultrasound or urinary test or whatever. If we decide to refer the patient to secondary health centers, now impacts, as I told you, 11% of our patients in 2024 required the use of telemedicine, particularly in rural area, but giving them access to specialized care, obstetrical ultrasound and ECG or urinary strips. Many patients have cardiovascular disorders that can be screened when they come to a health center. The benefit of that system is to improve access to healthcare. We can lift the barriers of access to care, mainly financial barriers, financial difficulties. It also helps to reinforce the skills of the health staff, nurses, midwives, general practitioners. Were trained in ecography or ultrasound techniques and the interpretation of the results. So that's capacity building. That's one of the main impacts we noted. The project was recently evaluated, and we're waiting for the report. So that's for Agboville, and I'll be glad to entertain any questions you might have. Thank you.
panel. I have a first question for you, for all of you. How would you describe the opportunity and the challenges for MSF to transition to what we can call a digital health revolution? Who wants to start? Opportunity and challenges in this new world. Yes, Juno.
I think the opportunities, to me, at least on the, for example, for X-ray interpretation, are clear to address these gaps that exist in terms of the complex diseases we see, and in some cases the inexperience and the absence of formal training of our clinicians. Also, the opportunity to improve the access to care, to innovative technologies, as I said in my presentation, to make access more equitable. I did want to really highlight the challenges because we've seen in our experience a number of them. I think it was mentioned before in one of the presentations that this technology is not meant to be plug and play. And that's one of the key messages I do want to say, particularly in the technology we've been with. It's been sometimes marketed as plug and play, where you can just plug in this technology and it can run by itself. But we've seen that it requires a lot of work, a lot of preparation, guidance on how to do the implementation, even before you think about doing the implementation. The implementation itself is challenging, requires a lot of technical support, a lot of medical support, how to integrate this technology into algorithms, for example, and the follow-up, the monitoring and evaluation, the data collection, all these things that sometimes aren't considered enough. I think it's one of the biggest challenges. Another thing that I did want to highlight in terms of challenges is what is the impact of this technology? And that's something that there's not enough information, not enough studies have been done to look at the impact of these technologies. Are we actually improving patient care? So I do think we need to look, because that's a key question, and I think we need to answer that before we progress much further. For example, before we look into wide-scale adoption in an organization like MSF, we need to look at that question. Thank you.
Thank you. So I think the challenges from my perspective are inevitable. I think the greatest risk that we have is inaction, especially when we're looking at things like non-communicable diseases. They're risk amplifiers for everything that MSF faces and works on in terms of climate change, political instability, and beyond. I think innovation and digital therapeutics in particular, coming from our perspective, is really an opportunity to reimagine long-standing challenges that we've been facing as an organization for a very long period of time. So reimagining how we actually work genuinely as partners with patients to enable them beyond what MSF is interacting with them around, and to give them the capacity and the capabilities to feel empowered as stakeholders in their own health. We can't do this with business as usual. It's just not possible. There's approximately 57 countries globally that are classified as having critical shortages in human resources for health. It's not possible with the growing size of the population that are living with non-communicable diseases and many other conditions. And we're seeing all of the other complexities of our world at the moment as well. We need to find alternate routes to support people to be meaningful stakeholders in their health.
In terms of opportunities, I would say our capacity at MSF to potentially synergize and mutualize more in terms of what we are doing, even with day like today, to be able to collaborate and to be aware about what we are doing in that team, in that OC, and to learn from that, just to avoid to replicate that work and to waste our resources at the end of the day. And in terms of challenges, exactly like Juno said, it's not so easy. It's not like nothing is plug and play. It takes time, and it also takes time. It takes digital literacy, and we have to acknowledge that not everyone knows how to even use Teams or to launch a video call or to troubleshoot easy things. And we have to think about our patients as well. How do we want to reach them when they cannot come to us? So yeah, for me, that would be definitely digital literacy to train our teams and to make sure we are fully aligned about what we can do, and what we cannot do, and to bridge that gap.
Merci beaucoup. Je pense que beaucoup a été...
I think a lot was said about the challenges and difficulties and opportunities. Of course, we have the possibility of mutualizing, sharing, exchanging. We're not the only ones working on digital health, and every decade a new technology appears, emerges. The humanitarian sphere is shrinking for many reasons, but this technology can help us to break barriers, like the testimony of a mother crying. She was going through her 5th pregnancy, and it's the very first time in her life that she had an ultrasound scan. She cried with joy. We have to look at that case by case and adopt an approach towards synergy and sharing, and we have to be humble at MSF. We have to look around what organization is ahead of us so we can learn from it.
No? Sorry. Well, during the break, we can continue to discuss. Thanks very much.
Merci.
The 4 of you. So we will continue. Why it's always difficult to share this. So we're going to move to another 4 presentation. Pourquoi ça marche pas?
Why isn't it working? I always have a hard time sharing my screen. I don't know why.
For the technology. I'll introduce Bhargavi. Bhargavi is working at the Médecins unit, MSF UK, MSF OCA, and she will present a project on malaria called MAP. Indeed.
Apologies in advance.
So 5 minutes also. So we'll have 4 presentations and 10 minutes discussion before the break. And please continue to ask your question in the chat. So yeah, go ahead. Sorry, you just have to...
Oh, perfect. Thank you. Apologies for not speaking in French. And thank you. And a bit like all my colleagues so far today, this is a large team. And we've been working on the Malaria Anticipation Project, which at the moment is based in Lankien within an OCA project in South Sudan. So the reason we started this was from a field-identified need. At the time, I was the malaria advisor for OCA, about anticipating malaria peaks within an operationally feasible timeframe, with the aim of being that if we intervened early, we would reduce mortality, morbidity, and also, for instance, allowed prioritization of other things. And this was particularly important because the team were noticing that the timing of the malaria peaks was changing with climate. And you can see that here in the graph that I show, where we have unseasonal malaria peaks. We had extra seasonal peaks and things like that. That they wanted, given the tightening of funding, to be able to prioritize better. And importantly, new preventative interventions were coming into play, but needed to be timed better in order to have better impact. So our hypothesis here was that we could use historical environmental variables paired with routinely collected clinical data to predict a future malaria dynamic. And that was using machine learning in order to predict its both timing and intensity of that malaria dynamic to enable what we call anticipatory action. And so we used the help of some data scientists at Arup and at Equal Experts who gave their time pro bono, and with the support of the Sapling Nursery, we started to develop a model using outpatient weekly data, so routinely collected data, a variety of ensemble modelling techniques, including XGBoost regression. We inputted over 30 climatic variables that were all open access and automated to be able to put into this model. And we trained it on about 8 years of data and then verified it on the preceding 2 years. And then and basically all of that was using routine surveillance data. The model basically showed that the shorter the lead time, the more accurate the prediction of the upcoming malaria peaks. But obviously longer lead times gave you more time for planning that anticipatory action. We paired this initial work with some community-based surveys to understand what the local communities felt around malaria, about climate, and how predicting peaks might land with them if we did things in advance. And the results, I'm not going to present that here given this is digital health, but were really profound as to sort of insights into malaria and anticipation that we were not tapping into as part of our routine operations. We developed a dashboard with local teams and stakeholders, and you can see the front end here. And then at this stage, we then secured some funding from TIC for a pilot phase in South Sudan and Nigeria. And I think the important thing here that we really learned was this project was maximising the use of the vast mountain of historic data that MSF sits on. It was really about shifting power away from those of us at headquarters who were making a lot of these big decisions to enable a tool that could be held at field level, routinely just tapped in a sense, in order to model out what might be able to make best decisions at a field level. And it was also a use case for embedding a climate lens into our operations, as well as how we looked at our data systems and AI. And so we're currently in the pilot implementation phase at the moment. We developed an early action protocol looking at what sorts of interventions we could put in place at different timeframes. That at the moment, that's been done with Imperial College London, although we are looking to bring that in-house in order to, again, ensure that the power for this sits at field level. We have a pilot underway in Lanquien at the moment, and this is some of the trainings that have just been going on at the project level in the last couple of weeks, and you can see the current levels of predictions. Interestingly, it's predicting a low year, so that's enabled the team to use their money to do something else. But some of the sort of questions that are now coming out of our pilot are, of course, how to increase the prediction length to make this more operationally useful, because very little is done in terms of ordering at a 2-month interval, although implementation is done at a 2-month interval. So what kinds of thresholds are acceptable for a good prediction or not in order to do proper anticipatory action? How do you even develop M&E for anticipatory action? How do you develop, if you avert things, how do you decide whether that's a success or not? What does business as usual look like for this sort of approach? How do we embed both machine learning and anticipatory action at a field level? Who presses that button? How is it put into our SOPs? And then, of course, what we need to start developing is starting to look at this a completely different way. What are thresholds for anticipatory action? How do we alert within our planning cycles to do this appropriately? And then how do we ensure that there is trust in this system, that fixes are able to be done rapidly and avoiding as much headquarters as possible? And then, of course, where is the ownership?
this sort of project. If you're interested, we have a SharePoint address that is available to everybody, and this is an email address for anyone who has more interest. Thank you very much.
Thank you, Marguerite. Joanna, please join. Joanna works in OCG, and she's the digital health lead. She will talk through snakes.
Cool, thank you very much. Yes, so I'm from OCG, here to present one of the projects we're currently working on in our medical technology and innovation unit called Snakes. And Snakes is a snakebite project. Snakebite envenoming, we know, is one of the deadliest and most mutilating neglected tropical diseases, affecting about 4 to 5 million people annually. And there were 7,000 admissions due to snakebite in MSF last year. And one country that we know is particularly burdened by this is South Sudan, where we've been working with the Ministry of Health on snakebite since 2014, looking at improving clinical management, prevention, and access to safer antivenoms. And we know that appropriate antivenom can make a really huge difference to rates of disability and death, and that rational antivenom prescription can be enhanced by accurate snake identification. But this is still difficult. Often clinicians are relying on picture books, a little bit like the ones we see here for identification, or on remote support, but this is quite challenging. So the Snakes project was put in place to try to solve this. Our plan was to create a database of snake photographs from South Sudan with the collaboration of local experts, our field staff. The database would include geomapping, and it would generate knowledge on the snake diversity and range, and help us to better understand the needs in relation to snakebite to contribute to wider discussions such as on antivenom. And then using this database, we would be able to build an AI tool which would accurately and instantly identify snakes based on a photo. This idea of automatic snake identification is maybe not new. There are tools which may work very well in the US or Australia, where there's a wealth of data and photographs on which to build algorithms. But in South Sudan, they're not going to be effective. So that was the problem we're trying to fix here. And just increase that evidence of knowledge. And finally, in parallel, we were going to work with our local team on raising awareness in the local community and try to increase local knowledge to prevent risk and really build on some of the interest that was generated by the project to raise awareness of those activities. And there were several steps that we took in order to be able to do this safely. We identified a team drawn from volunteers from our health promotion colleagues who were working over a wider area in Twitch and Abia, working very closely with the local community. We held a series of workshops which were co-run by our team and with herpetologists, clinicians, and snake handlers, in which we discussed first aid, snake ecology, toxinology, and crucially safe snake photography. And we armed all our health promotion project partners with small but ultra high zoom cameras, and then supported them as they built this database. And crucially, they were only taking photos of snakes which were encountered as part of their daily activity. They were not seeking them out and only doing so when it was safe to do so. And you can see just some of the photographs that they sent to us and which we received from our field teams here. And we also enhanced that database with photos which we crowdsourced from international staff and HQ visitors. We had a team of expert herpetologists who identified the snakes, so we had a training set for our AI, and finally built the tool. And our last stages will be to finalise, deploy, and test this in the field. This is where we are today. I wanted to show you a prototype of the tool that we're developing. You can see on the shot 1 where we upload our images, we can add the date and the country for greater accuracy. On the second screen, you'll see the results that the tool will give. So it's a list of snakes that it's identified with a percentage likelihood of that being the snake. You can see it a little bit better zoomed up on the final picture. Sometimes it will give you a very clear 99% it's this. Sometimes it will be a little bit more uncertain and hard to give a definite. A few things to quickly highlight. The tool is not complete. The accuracy does need improving, and to do this we need more photographs, which will help us to develop the algorithm. It has been challenging to collect enough data because we're reliant on the window and the timing of snake season, and crucially because our teams are not actively looking for snakes, just photographing that those are encountered. And so we will be continuing to collect data before finalising the tool and deploying it for testing. And if it's successful in the future, we have the possibility to work on other underdocumented areas to make the tool more widely useful and to further supplement future prototypes with other features such as clinical support as well to enhance the user experience. Thank you very much for the time today. Thanks for listening. And if anybody has any photos of snakes from South Sudan, please get in touch so we can build our algorithm. Thanks very much.
Thank you very much. Super interesting. Snakes. So we change a little bit. We go to e-care with Nancy. Sorry, you have to. Sorry, it's my fault.
Talking about e-care, maybe not changing so much because it may sound very familiar. What is e-care? E-care stands for Electronic Clinical Algorithms Recommendations. When you are in the field, in the places where MSF work, to improve quality of care, we rely on a bunch of stuff, booklets, guidelines, sessions with people that have more knowledge than you, and clinical discussions, bed-to-bed discussions, supervision by clinical people, even posters where you put on especially ER rooms, the old ones that peels off very, very easily. So what do we have? We have proper guidelines that are used everywhere, like IMCI, which you heard about it, the La PCME, and we transform it to clear algorithms. So you have the tree saying clearly if you have this symptom, you should consider these in the physical exam, etc., until you reach a diagnosis and you are proposed a treatment. Sounds very familiar because it's the same as IEDA for Terre des Hommes and the same as Almanac from ICRC. And actually it originates there. And this is just to prove how we are all interconnected. It's not by chance that MSF has it. It's our own version. So we do have a plus IMCI. We added ORL diagnosis and skin diagnosis with pictures. So the health worker can check the picture on the tablet, on the phone, and the patient and compare. But essentially is the same IMCI made into electronic algorithms. So we do speak with each other, and this is the beauty. We work in the same places, we have very similar challenges, and we learn from each other. So it was created through Almanac. We thank very much ICRC for that. We have Terre des Hommes that had the same idea. We had to change the program for an open source. We wanted it to be a knowledge that will remain for outside MSF as well, to use the same source code if they want. And ICRC used the same program that we are using right now. So it's a full circle of collaboration that we have between our organizations. So we use this syndromic sequential algorithm and then step-by-step guidance for giving support for the first-line workers. And you may heard about it because it was created originally from OCG. It received TIC funding, the Transformation Investment Capacity funding, to have its own team of up to 10, 12 people, which I was part of, to scale up in all the different sections. The TIC funding, it's over because the project has finished, but on finishing the program, we made sure that each of the OCs incorporate within their business as usual into their own way of working and have their own ownership of the tool. Ownership of the tools that have been created, like these ones, the pediatric and young infant, which are both from IMCI guidelines. The young infant one is from 0 to 2 years old, and then the spin-off from MSF is that we include routine medical examinations of newborns. So midwives, nurses that see PNC, the postnatal care consultations, can use them as well. We have the vaccination one. And STI. STI has been created by OCG after finishing the TIC project because we wanted one. We believe that it would be nice to have an STI electronic algorithm, and it's finishing its pilot this year. So we will share with all the other OCs, whoever is interested to have it. The vaccination one, it was done with the original TIC team, and it's a bit different, more as a calculator. The problem with vaccination is that there is different protocols, different schedules, and within MOH, MSF, what we want, and different scenarios like routine PEV vaccination or mass vaccination campaign with multi-antigen. So this one can be adaptable to any of these type of programs, not only for children, but also for migrants in general, for older people, for pregnant people, all including MUAC if you want, nutrition screening, deworming. All these programs can be inserted inside, and you can adapt it for your use in your setting. It was the places in the map you see, the more than 40 health facilities using it, and etc. It was more on ped and young infant. The vaccination one, we did a trial in OCB setting. We got a good evaluation about it, but the user experience was to improve. So we did this work this year, and now it's ready for use. And the most important, that the health workers would like to use it. So here on the original TIC project, they left also a package of tools. So each of the OCs can use all these tools to implement themselves and also create new algorithms if they want. So you can just click in this website for MSF people only, sorry, and that's it.
Thank you, Nancy. So now it's our fourth presentation. We'll switch to electronic algorithm to electronic medical record with Muima, who is the responsible of OCP e-health unit.
Hello, everyone. So today, how do you switch? Is this one? Is this one right?
Yeah.
Okay.
And then you have the 2 point. If you want.
Okay, perfect. Thank you. Hi, everyone. So today I'm going to talk about digital health records for hospitals and programs that we've implemented within OCP. So I'm going to leave this definition on the screen and kind of set the stage. So back in 2016, when I first arrived to the reconstructive surgical project in Amman, the hospital was quite overwhelmed with the amount of information that was being collected around the patient and inefficient patient and information flow processes. So there were 30 Excel databases that were being used for reporting purposes. the actual patient file was more than 100 pieces of information, and then there was no unique patient identifier that was following the patient throughout their care within the hospital. So this made data management and reporting quite chaotic and often painful for the hospital team. And this is actually not unique in Amman, and it's something that we see in many of our projects, especially for the projects that have a long history within MSF. So our goal was really to ensure that we can have instant, seamless, and secure access to comprehensive patient-level data. And we are slowly achieving this by implementing an open source electronic medical record for hospitals and programs called BAMNI. So, problem statement. One of the biggest challenges, and I think this has been mentioned throughout the day, is the fact that we have a lot of fragmented patient information. So information is often scattered within departments, within various tools, and it makes it quite difficult for the clinical teams to have access to comprehensive patient-level information, to take decisions, and to do accurate reporting. BAMNI addresses this challenge by providing an all-in-one integrated platform for patient management as well as facility management. So there are several features that are currently listed on the screen. So BAMNI allows us to register a patient, to record clinical observations, to record drug orders, diagnoses, generate a comprehensive patient summary, as well as some aspects around facility management, such as recording appointments within the OPD, OT scheduling, and bed management. So within OCP, we are using BAMNI in two ways. BAMNI is extremely flexible and adaptable software. So we're using it in complex hospital settings for point of care EMR, where the clinician has ready access to patient health records, as well as being able to update the patient records in real time. This has been implemented in Amman, in Baghdad, in the Rehabilitation Center, Blantyre Cancer Project, in Gaza and Tabar, but those were stopped due to context. We also implemented it for chronic diseases and long-term conditions, but this is really serving more as a retrospective database with the intention to allow for better programmatic reporting. And both ways allow us to use Metabase, which is a tool that allows us to visualize and analyze all of the data that is collected within BAMNI. So there are some key objectives for OCP when we're implementing BAMNI, and one of the main factors is to provide a centralized platform where all of the key patient medical and administrative information is collected, as well as generating a unique patient identifier. The other part is being able to track the patient status and key transition points by using appointment scheduling and OT, as well as bed management within the wards. And finally, providing quick access to key patient data and hospital performance indicators, so the management team has readily available data in order to take decisions. The implementation process of BAMNI, especially for complex hospitals, really follows a very structured process. So we start with the pre-implementation, where we do kind of a thorough hospital needs assessment, look at the hospital technical infrastructure, and then implement a governance structure to really guide the implementation process. Within the implementation phase itself, we focus a lot on analyzing and streamlining the patient and information flow, focusing on effective change management, and then evaluating the paper medical files so that we can ensure we have structured and streamlined patient data collection as well. Within the post-implementation phase, the focus is really handover to routine activity and then ensuring that we have proper mechanisms in place to monitor the quality of the data and to ensure that there is continued training and support for the teams. So I have a few screenshots on how the UI within Bamni looks like in terms of capturing patient information, as well as how it manages the facility and reporting. So I'm not going to spend time on this, but one thing I will say for the UI or the user interface for Bamni is that it's quite clean. There's not a lot of bells and whistles, and for my side, it looks more appealing than some of the proprietary EMRs that we've seen. So lastly, I just want to talk a bit about the lessons learned and the challenges that we've experienced throughout the implementation process. So one of the things that we quickly realized is that in conducting a detailed and thorough hospital needs assessment, beforehand, it was really essential to ensure the smooth implementation of this tool. So I mentioned the patient and information flow, and I want to reiterate that this is one of the key pieces of information, and probably one of the key challenges is really understanding how the patients are moving throughout the hospital, what information is being collected by the clinicians, how they're communicating, how care providers are communicating about the patient, and what tools that they're using. So for us, it was not simply in terms of implementing a tool, it was really in trying to usher in kind of a hospital-wide change. So we didn't just say, here's the EMR, go forth, do with it what you want, but we really focused on ensuring that we were able to optimize the workflows to ensure the success of the implementation. Lastly, having a strong governance structure in place and a robust training and monitoring plan was really helpful in ensuring that the EMR was well integrated into hospital activities. Yes, and that's it from my side. Thank you, everyone, for listening.
Thanks, Moima. Thanks very much. Adi? No, you can, if you want, but you'll be. But we can go. Yeah, the four speakers can come to the stage if they want. Do we have any question from the room? No? Yes. Yeah. For everyone? Ciao.
Bonjour, une question
I've got one question on MSF eCare, and generally speaking about all these digital applications. Studies report improved quality of care, quality of information, quality of communication with the patients. However, in MSF settings, we can see that quality of care is improved. However, it takes longer per patient. So you go from 5 to 15 minutes consultation. So how can we make sure that the digital systems are sufficiently supportive so that they can be used by possibly non-MSF users, because even if quality is improved, it might be perceived as a constraint if you have to fill in forms on tablets. Now, as we were told, it's never plug and play. There's always some piece of work to be discharged to make sure that it is appropriate for your settings. So you first need to identify the constraints. Why is it that you haven't been achieving the level of quality desired? And one of the things you can check is the consultation time. Say if it's 3 minutes, just forget about eCare. Maybe just increase the consultation time, and then you'll see whether you need additional tools to further improve the quality of care. So you first need to go through this analysis phase or assessment phase. What's different from ICRC or Tête des Hommes is that we want to have a tool that also supports training. We now use it's all very well to train AI, but it's also very important for us to use these tools to train people. If you have people working with e-care every day using a tablet, maybe that it is that after 1 or 2 years, this person has taken on board a number of information and no longer needs to use e-care, and this is indeed the objective. Gradually, gradually the person becomes more familiar with the protocol, and you may no longer need to use e-care to guide you through your consultation. So it all depends on the objectives you have for your project. And there are also tools that can be used in order to monitor learning, quality of care.
The chat probably for Muima. Are there access restriction control in BAMI? And if not, how is the medical confidentiality ensured, considering that everyone could have access to the patient file?
Yes, there are access controls and privileges that are within BAMNI, the software, and the community has made a lot of recent developments in ensuring that only the relevant users and people should have access to the data that they need when they're consulting a patient. One thing that, at least in some of the implementations that we've done, is we didn't want to limit information based on profile if it was a medical professional. So if you're a doctor or a nurse, the objective for us was that you were able to see the same level of information in order to have visibility on the entirety of the care process for a patient. Now, if you go to mental health and some more sensitive information, yes, there are restrictions that can be put in place. However, BAMNI in itself as an open source tool does not have this level of restriction. So for highly sensitive information about a patient, we recommend, and this is what we discuss with the hospitals when we do the implementation, is to keep this highly sensitive information that should stay within a department confidential and kept on paper rather than putting it in the EMR. So this is one of the approaches that we took, as BAMNI's access controls are not as robust as one would hope for open source tool, but this is work that is ongoing within the community that supports BAMNI.
Okay, before moving to another question to the chat, I have a question for you and whoever wants to answer. We saw from this morning and today and this afternoon the whole variety of digital health tools that we have also in MSF and digital intervention. How could we learn from the experience of the various digital health intervention in MSF that has already been carried on to avoid pitfalls and better understanding the challenges in the idea of designing new project and new implementation? Who wants to go for this one?
Now it's working. Yeah. Yeah, a really good question. We could probably talk about a lot. But a few things, I mean, I think even just what we're doing today is the first key step, is being able to share. There probably is a lot of overlap. We know there's a lot of overlap going on between the MSF sections, between MSF and ICRC and so on. So the more we can share and come together, the more we can really take advantage of the opportunities to learn from each other. And I think with digital health tools, there's both the situation where you need to take every tool and every context into account individually when you're designing, to make sure you're really considering the end users in that context, and you're creating something that's appropriate and will be adopted. But at the same time, there are also a lot of similarities where we can definitely learn from each other, thinking about some of the data protection, the regulations we've discussed, the change management, the technology, the infrastructure. All these things are things where we definitely don't need to be doing that again and again for each time. So I think this is a great starting point, and the more we can do this and build either formal or informal opportunities to connect and share what we're doing, then I think that's a great start.
Yeah, go ahead.
Yeah. It's a question for Bhargavi. Yeah. I understood actually that predictive AI being as a tool for anticipation, to be used for anticipation, whatever it is, forecasting or preparedness, response plan, etc. But you said as well that from anticipation we can also predict. So my question is to know what the articulation in between the two prediction and anticipation. It is in the frame of the malaria anticipation project.
Yeah, I mean, I think what I was trying to say is there is anticipatory action, which we would say based on some sort of signals quite close to the event. So at the moment we have a 2-month window in order to sort of develop a response. But really what the teams have come back to us to say is that we need to know 8-9 months in advance in order to be able to plan appropriately. So then it becomes a question of how are we improving our preparedness, which is a little different in a sense to taking an anticipatory action. So we're trying now to go back and see, are there any signals even at a year in advance or 9 months in advance to then how do we use this to both improve the actual actions that we take, but also in order to improve our preparedness. And I just wanted to come back to the question that you just answered. I think the other things that we should learn a little bit from is of course, and everyone's been talking about let's not do plug and play, but I think there is an element, I mean, we're striving to be as plug and play as possible so that people don't need specific training each time or differences, is that something we can just put in to every laptop in every mission or every project so that you can just plug and play it. And it requires limited amounts of contextualization in order to be able to make it as business as usual as possible. And so rather than developing lots of different apps and lots of different tools to base it all on the same kind of operating systems that we use, let's make sure this is all, embedded within Power BI. Let's make sure that we automate our data streams from DHIS2. Let's try and integrate as much as possible in order to make this as useful as possible, as well as everything else you said.
Tu comprends le français, hein, Bhargavi?
Bhargavi, you understand French? Yeah, I can speak French. It's a question I had. You partially answered. One of the benefits of those digital health tools is to increase access, to offer it to a high number of people. But we realize in the examples you told us about, it's time consuming. It takes a long time. We could imagine that we could have e-care in all the MSF pediatric services or departments, and yet it's not the case. But we have to make that step. Otherwise, it will take too long to roll out, to deploy, where caregivers are more used to having those tools available. But, we talked of scaling up. That's a real stumbling block. It's a real challenge, the scaling up. It will take time. And another question, we have to be aware that once we've got those tools, you have to think of maintenance, updating, scaling those tools. Also, what Nada told us, complying with the legislation and regulations. It takes more effort. And beyond the fact that those tools are well accepted, you have to check that they're really efficient and effective.
In the chat, there is an interesting question from Jaun team. So it's links to the EMR, but we can definitely expand it to other tools. Given our commitment toward reducing our carbon footprint around our projects, migration to EMR looks like a big win. However, we seem to be slow in expanding its use. How can we improve this? So, specialist or EMR. Yeah. So it's beyond EMR, but because it's go on.
That is not an easy question to answer. It's something that we have been discussing and brainstorming, and how do we go to scale? I mean, for the full hospital EMRs that are now point of care for OCP, it took years for us to implement it with a dedicated project manager. So Amman took 2 years. Malawi has completed its first wave, but there's still a lot of information that needs to be integrated. So it takes dedicated resources, money, and time. One thing that we're trying with the chronic disease database is doing this plug and play that that she had mentioned earlier. So with the chronic disease database, it is retrospective at the moment, but it is based on the same software that is currently point of care. So our intention is potentially in the future, once projects are used to collecting structured medical information, are used to having this robust programmatic monitoring, able to use the data for decision making, that we can evolve this tool that they're already using now in their projects into something that is more point of care. I don't know.
Big challenge. Probably a last question, and I'll keep the mic actually, if you're okay with that. I had a question on how digital health play a role in fostering a more collaborative and equitable relationship between health staffs and patients. Who wants to go for this one? Nancy, or Johanna, because the two project is really dedicated to the patients actually.
Yeah, let's try. So eCare was dedicated for the medical staff, but we incorporate inside the messages that the health staff should transmit to the patient. So in the design, I think that a lot can be done to incorporate these different interests, and that's what I can think of.
Maybe the other thing, I think it came up a little bit in when Hannah was speaking, but or someone, apologies if I forget, but this ability to maybe bring information to patients and allow them to be more involved in their care and more aware in the processes that are or information that is pertinent to their care can be a very good thing. We also have to be aware, of course, not to increase inequalities by the use of digital, but when done well, I think there's opportunity to do that through the sharing of information, the provision of information, and the involvement of patients, particularly when it is a co-design process or they're taken into account in the design process. And maybe just to obviously that's crucial, but also between healthcare workers, a little bit like for the EMR, increasing that equality between healthcare staff as well, and then between staff and patients. I think there's opportunities on all fronts.
I just add one small thing related to the healthcare provider and the patient. So when we were doing the EMR implementation, we actually looked at how best to place the laptop or desktop or the tablet to encourage better interaction with the physician, because we don't, or the healthcare provider, because we didn't want the provider who's used to interacting more personally with the patient to sit behind and be hiding behind a laptop when we implemented the EMR. So what we set up was kind of a triangle, so that you have the laptop here, the physician here, or the healthcare provider here, and the patient here. And then what we saw when we did the implementation was that rather than sitting behind the computer, the doctor or the surgeon was actually showing the patient the X-ray on the screen, and then demonstrating to, and explaining to them more in detail during the consultation process, which is not necessarily possible when you're just using paper-based systems.
Thank you very much. I think we are already a little bit late. I would like to thank all of you, Javier that was online, and the 8 MSF speakers. So we'll take 10 minutes, 5 minutes break. And we are coming back here. We'll have a last panel that will be moderated by Megan Maguire, the International Health Strategic Advisor at the IO International Office. See you in 5.
Good afternoon, everyone. We're about to have the last panel session on this for Digital Health Days. Just checking to see if our online panelists. My name is Megan Maguire. I work for the International Office under the International Medical Coordinator as the Health Data Strategic Advisor. Working across the movement on various health data and technology initiatives. This panel that hopefully we'll have our online participants joining in a second or up on the screen is meant to kind of bring an external perspective from digital health experts to try to answer the question, how do we select scalable and sustainable digital health initiatives for the future of MSF medical operations. The panel will introduce himself in the interest of time because we really are going to, we have a bit of a time crunch now. The way that the panel will work is they'll introduce themselves and answer the question, what are 3 essential components for planning digital health interventions from their perspective? So I've asked the panelists to tell us a little bit about themselves and then answer this question for us. We're then going to have 2 questions from the online. So whoever's online still, pop your questions on. This is a panel that is both technically and strategically and policy focused in a variety of digital health initiatives, probably covering close to 45 countries. So they know about scale and they know about the complexities going to scale. And then we'll move into kind of a Q&A from myself with the panelists on a couple of different areas that we've identified that we would like to get their opinions on, and then bring it to you guys to ask the panel some questions. So I'm going to first start with Stephen. I hope he's able to turn his camera on. Yes? Does online hear me? Sorry about the...
Yes, we do.
Oh, excellent. Can we get your camera on, both, I think, Stephen, Carl, and Shmisha?
Hi, Megan.
Hi. Wonderful. Is Stephen there?
Yep, I'm here.
Great. So we'll start with the online folks to do an introduction, and then the 2 panelists sitting next to me.
All right, thanks, Megan. Hi, everyone. My name is Stephen Onye. I'm calling from Nairobi. I run a company called IntelliSoft Consulting Limited. We are a digital health development firm based out of Nairobi in Kenya, and primarily work with global goods and work in a couple of countries in Africa, but also work with international organizations and other collaborators from all parts of the world, including Megan, who's been a friend for many years. Really happy to be here. Thank you very much for the invitation.
Great. Hi, everyone. I'm Smisha Agrawal. I'm an associate professor in the Department of International Health at Johns Hopkins University, and I direct a center. It's an interdisciplinary center for digital health that brings together folks from engineering, medicine, nursing, public health, and other business schools. We focus on three areas in our work. The first is policy, and so it's working with normative and other multilateral, bilateral agencies and thinking through where digital investments make sense and what is the right approach to think about them within the context of healthcare. And the second is education. We have a number of short and long-term programs in digital health, including a digital health certificate. And the third, as a research institution, is figuring out what works, what is the right context and setting within which things work to improve healthcare outcomes. And so really focused on evaluation and research. And hopefully this
Speak up a little bit so that bit, and also so that the translators can hear you. Thank you very much.
Okay.
Over to me? Yeah.
Yes.
Hi, I'm Carl Leitner, Technical Officer at WHO. I have two primary responsibilities. One is the business owner operator for the Global Digital Health Certification Network, which is a way to share verifiable health documents across borders, such as the ICVP or the International Patient Summary. I also am the chief architect for the Smart Guidelines body of work, which is codifying in a computable way the WHO guidelines in using open standards. Thank you.
Do you, Nada?
Thank you. Hi, I'm Nada Malou. I'm by background, I'm PhD in microbiology. I worked several years for MSF, mainly on supporting access to diagnostic and especially microbiology and AMR. And based on challenges and difficulties that we faced during the implementation of microbiology lab in the different countries where we intervene, there was this idea because of the lack of human resources, to create a diagnostic test, which is a smartphone-based application that allow any laboratory technician in any microbiology lab to take a picture of the test and to perform the interpretation. This project is called AntibioGo, and now it's a CE-marked medical device used in different countries. Thank you.
And hi, I'm Rohit Malpani. I work as a consultant for the WHO on the ethics and governance of artificial intelligence for health. So that just means I help to manage an expert group that is sort of comprised of people globally that think about AI and health from different angles. And I write guidance for the WHO on these issues and then work with governments. And once upon a time, I used to work for MSF as the policy director of the Access Campaign. Did you want us to talk about the three things yeah, I didn't know. So I'll just throw out mine. So for me, I think the three I was thinking about, the first is just basically thinking through whether or not something should be used. And I think that really is, sort of the first order question. And the reason I think that's so important is these technologies are being developed in a largely unregulated context. And obviously when MSF is designing them, they can think through some of these issues up front. But in most countries also, you have a disconnect between the people who design these technologies, which are primarily programmers, versus the people who use them, which are, medical professionals and healthcare workers. And I think there are sort of higher concerns that have raised because in unregulated contexts, the likelihood of sort of technologies being sort of hyped up and used improperly, and that occurred during COVID-19, are much higher. And then we're also seeing with the rise of generative AI that, there's sort of an overestimation of their benefits. And also just that the barriers to entry with open source technologies means that there's a great benefit to that, but they can also be used improperly. The second is just around due diligence in terms of trying to identify the different human rights and ethical concerns. Even if a technology is designed perfectly, what we've seen is that, there's always going to be challenges that emerge, whether it's the sort of traditional challenges with bias and privacy, or other challenges that often are unexpected, for example, with automation bias as healthcare workers use these technologies and suspend their own judgment. And then the third is just around sustainability. So thinking upfront about whether or not your commercial partner will maintain an active interest in the technology, whether you can maintain the ICT that is needed to run a technology or to update it, and then also to have continuous oversight.
So my 3 points, you already took some of them, so but I will start with something that does not look as sexy as that, the regulatory aspect. I think today is quite clear that before even thinking about developing a technology, we need to understand what's the regulatory stature of those technologies, especially in those highly unregulated contexts where we are working and we have even more, a bigger responsibility than others to provide tools that are, let's say, compliant with the regulation. Then you choose your regulation, of course. It can be the European one, the American one. However, today, I think, for example, within MSF, it should be the first step. And when you speak, for example, Rieux, about the due diligence, as part, even if the regulatory is not something very funny or attractive, but at least it gives you a frame. And this due diligence is done from the beginning when you assess what's the stature of your tool. The second thing I would say, from the beginning, thinking about the scalability. I think we saw how much there are plenty of initiatives. Some of them are duplicating each other's. We cannot afford today in the world where we are living, especially with the change in the, let's say, the global health ecosystem and funding, we cannot continue to duplicate those kinds of initiatives. So the first thing to think about is are those technology already existing? Could we adapt those technology? And thinking from the beginning, not for use case in a specific context, but how we make those technology possibly being one size fits all. It's challenging, but we need to start thinking about that from the beginning. And I would say the third one, which is, let's say, time consuming, because it takes a lot of time to develop those technologies. It takes a lot of time to evaluate them. But then there is the question of the impact. What do we want to achieve with those tools? What is our objective? What are the actions that we will put in place based on the output of those technology? And even if that's true that we heard that all day, it's not technology-centric, it should be health-centric. Sometimes in the everyday activities of developing such tool, we lose those questions about why are we doing this and how are we going to show their impact. It takes a lot of time. In front of that, we have also the pressure of the donors, the funders, the organization, asking for scale-up, asking for did you finish your development? And so we need also to manage the expectation regarding those tools. It was already said, it's not plug and play, but also in terms of showing impact, it takes a lot of time. Just as an example for Antibiogo, if you want to show the impact on introducing a software as medical device like this that will improve the results of a diagnostic test, the final impact is going to be, of course, the improvement of the outcome of the patient, the reduction of non-rational use of antibiotic. But this takes years, especially in the context where we work to collect enough data and quality ensured data to be able to advocate or to have a clear impact.
And I'm going to move over to the online panelists to also answer this question. What are 3 essential components for planning digital health interventions? So I'm going to start with you, Carl, just kind of giving your thoughts, and then Smisha, and then Stephen, and then we'll take some online questions.
Yeah, happy. And I'll try to be quick, but also not be so quick that the translators have a hard time keeping up. I apologize to them. I think there's 3 main things. One is to have a structured process for your digital interventions, and not just thinking about your intervention alone, but thinking through the larger ecosystem of actors that are you will potentially be interacting with. WHO has a guidance on this that might be useful to review, the Digital Implementation Investment Guide, which goes through a very structured process that countries can take in order to develop an enterprise architecture to plan what they're taking. I think there's a lot of applicability, whether you're a government or a large implementing organization, to this process. The second would be to emphasize the standards, interoperability standards, both semantic standards of which you might be familiar with, such as ICD-11 or LOINC or SNOMED, as well as syntactic standards for data exchange, such as HL7 FHIR and others, DICOM for imaging. So making sure that your solutions adhere to the standards, helps ensure not just the primary use of that data, but the secondary use of that data, and really ensuring that you can answer the questions of the health system, because we're not generally acting independently in a silo. And the third is to really think about the digital public infrastructure that may be present in the countries. And I know some of the countries and some of the places and locales you're working in, there isn't that infrastructure, but when it is there, thinking about how can you more effectively make use of that? You know, are there existing communication systems? Are there existing public key infrastructure that can be leveraged as part of your interventions? And so I think these things will help to ensure longer term sustainability, as well as a much more collaborative, open ecosystem for other players to engage. Thank you.
Great, I can come in and yeah, and translators can let me know if you hear me well. So I think, you know, no two humanitarian settings are the same. There is short-term, acute, longer-term situations with displaced populations. I think the first question is always to ask if any digitization makes sense, because it is very context specific, and often digitization doesn't fix a process that's totally broken, right? It does not directly address the lack of infrastructure, for example. There might be creative ways. So, for example, if there are no healthcare providers, telemedicine might help elevate those concerns. But I think really the first question is to ask is, are we being led by the problem rather than being led by a shiny tool? And so that I would start with. And then I think if some type of digitization makes sense, what should it be? And the what should it be, a lot of the conversation here is within the context of service delivery. How do individuals get the care that they receive? But with displaced populations, we know that one of the huge concerns is also misinformation, disinformation. It's with every population, but I think more concentrated mis and disinformation. And people do have access to online social media, even within these settings. And so there are a number of digital interventions online that are targeted at these particular populations. And we should be thinking about that, about how do individuals access their health information in an online medium. And so, yeah, so just want to broaden sort of this thinking of not just direct service delivery, which is essential, but also how people consume and access health information. And then maybe the third thing is starting with no harm first, right? Displaced populations, there are sensitivities which are not typical to maybe other populations as much. And so one thing to think about is we are operating in scenarios with either weak or missing governance and legislation. Can we actually ensure data security if you're going to take that step? Because digitizing data when weak security systems or privacy systems exist means we are putting some populations at risk of being identified or exposed. And so really thinking about, and that I think goes back to, does digitization make sense for this population? Because we do want to start with no harm first. And over to Stephen.
Thank you, Smisha. Yeah, I mean, I think I'll probably just reiterate a couple of things that Smisha and Carl have mentioned. But I think, just going back to something Carl mentioned, the way I look at it, and I think also just taking into consideration, as Smisha has mentioned, the sort of fragile, conflict and violence-prone regions, that are typical of humanitarian settings. I mean, I think it does present a couple of unique challenges, when you're thinking about digital health. And so I think thinking through those critically obviously will require us to think differently than probably how we do in non-FCV context settings. But I think one thing that will always be constant, in my opinion, is I think the digital health intervention that we're thinking about, who needs to change for it to work? I think that's the same thing that Carl mentioned. So thinking about this in a structured manner also thinks that you really think through who are your stakeholders, whose behavior needs to change for that thing to work. So is it the politicians? Is it the investors? Is it the peacekeeping mission? Something needs to change for that intervention to work. And I think thinking through that in a very structured way. And then I think secondly, again, as mentioned by Smisha and Carl, is thinking about this foundationally to the extent that that specific context allows you to, given that obviously it's fairly fragile in most cases for humanitarian folks. You want to do this in such a way that you're able to also invest for the longer term in a sustainable manner, which would have to take you to the foundational layers of this investment portfolio. So as Carl has mentioned, there's a couple of ways that the digital health community is thinking around foundational building blocks for digital health, so-called digital public infrastructure for health. And so by approaching this investment this way, then you're hopefully solving for the immediate, given what the context allows you, given that most of the time it's very fragile, but also to the extent that you're able to really stretch out this investment for the long term, then you'd have to target the foundational level. And then I think thirdly, definitely would be capacity. So in rebuilding, in thinking about the various phases of our humanitarian crisis and long-term rebuilding in a better way to hopefully prevent this from happening again, then you have to think about investing in local capacity as much as possible. And so the standards that Carl mentioned about from a digital health perspective, investing in local capacity, people who are actually able to build what you're implementing in that context will be very important so that when the next crisis comes along, you're in a better place. Thanks, Megan.
Muhima, do you have some questions online that you can target to the panelists?
Yes, so we have one question. We have several questions, but I will go ahead and start with this one. How do the panelists think about the possibility of health systems in low resource settings being able to sustain these digital systems? Short life of hardware, maintenance, IT support, help desk, and troubleshooting, human resources, ability to manage an extensive infrastructure of digital tools, integration of multiple systems. Already there are enormous challenges within simple technology and with less support for health system strengthening expected in the years ahead. Sorry, it's quite a lengthy question.
Who wants to try to answer that one first?
I mean, I think it's a great question. I'm glad that we are starting with that because I think and the donor and aid ecosystem is changing, right? Because often with a lot of digital tools, especially with a lot of the global goods and open source tools, there hasn't been visibility into the costs of developing and maintaining these systems. Often governments don't know what they are paying for and what it costs to maintain these systems because those costs are not reflected on their own budget sheets. And I think, and that's often, right? It's not always. There are many countries that have full visibility into that. So I think we need to be asking these questions because I think I work a lot in community health systems. And the question that I continuously ask myself is, should we digitize community health systems when community health workers are not getting paid, right? Should we build airplanes when there are no runways, right? I think that's a really good question to ask ourselves because there is hype in the space and we need to think about what is practical so that we are focusing on health first. I'll turn over to Stephen. I don't have a solution, but it's a great question.
Well,
Sorry.
Yeah, no worries.
Carl, unmute.
Sorry. I think it's a very good question, but maybe there's perhaps a different way to look at that question and how to respond. I mean, obviously, there's the immediate crisis needs that need to be dealt with, putting those aside, you have to say, well, if these immediate crises are really long-term and they're ongoing, well, what is our recurrent cost for these interventions? And if you look just sort of mathematically at the number of systems that are involved, just how that you need to get them put together, those costs are not scalable unless you have certain interoperability assumptions in your architecture and certain approaches. You will not ever be able to support systems unless you make those initial investments upfront to ensure that the costs are contained and linear. So, I think it's really a trade-off of like when you need to say, okay, well, we've addressed these more immediate concerns. What are our longer term goals here, and what are our longer term costs, and how do we cut those down? And so I think it's actually, what is the cost of not doing this is much higher than the cost of doing it. And so I think it just needs a reconsideration of how we do our investments and what our priorities are. Thanks.
Technology. I think I thought the question was the answer sort of, but I guess the way I think about it is those are all the right considerations, but what is the counteracting force to this is there's, a geopolitical rationale for investments in these technologies that sort of don't have to do with this sort of cost benefits that are being brought up. There's a commercial rationale that we know. So the amount of investment that's going into especially AI technologies is exponentially increasing, and that requires, therefore, then a market to put it into. And then there's a disinvestment in public health systems that, every company we talk to and every government we talk to will always just cite the figure that, we have a shortage of 10 million healthcare workers, and therefore we have to do this. So I think the real concern I have is that not being able to speak to those sort of external forces that are going to push these technologies in, even if the cost-benefit ratio doesn't make sense.
So, Ohima, one more question, and then we're going to do two questions from my side, and then open it up to you guys. Hopefully you have some questions, so start thinking about them now.
Yes, so one more question is related to MSF specifically. So knowing that we have fragmented data collection systems in place, we are using paper-based systems, most of our information can be siloed as well. How can MSF effectively leverage digital health technologies for improved patient care and data-driven decision-making?
I would like if Stephen and Carl can maybe answer this, because I know both of you have experience in trying to answer this question.
Stephen, back on line.
Go first as I try to change my connection. Sorry.
Okay. Yeah, so I think one of the things that we're seeing, maybe a new trend, or maybe the old trend that we've seen is a lot of investments in health information exchange, it's a very large upfront investment and does take a while to see the rewards for that. What we are seeing now in several countries is rather than trying to set up such a large infrastructure at first, is to do a bit of a stopgap solution where the individual becomes the means of exchange of health information. This is obviously not fully doable in all contexts, but in the case where there is, for example, a smartphone, you could have something like the International Patient Summary, which is a standard, international standard for health information that the individual can hold and they can choose to share as they seek care in various settings. For example, we saw Malaysia is doing taking this approach because of their wanting to accelerate the exchange of health information, which then improves the clinical care. That's obviously not something that can work in every context. that said, this same type of approach is also what we'll be taking for the digitization of the International Certificate of Vaccination and Prophylaxis, or the ICVP, the Yellow Book, which countries are going to have to start implementing a digitized version by September of this year based on the updates to the international health regulations that were passed at the last World Health Assembly in May of last year. These types of solutions, I think, will become more prominent. The notion of an individual having their health information and choosing to share it as they seek care, I think will be a future trend that will address some of these things, at least at the individual level. Certainly doesn't address it at the aggregate level, but it does provide a way to at least have that core information needed for unplanned care or routine care encounters. Thanks.
Stephen?
Can you hear me?
Yes.
All right, thanks. Megan, do you mind just rephrasing the question for me? I lost the last part of the question, sorry.
Yes, so essentially within MSF, we have siloed information collection, we have information in various tools, we have, for lack of a better word, quite messy data. How can MSF better leverage digital health technologies for improved patient care and data-driven decision-making?
Thanks. I think I would agree with quite a lot of what Carl has mentioned, but I think from our own experience, where because the scenario that you've painted for MSF is not really unique. I mean, I think it's very prevalent, especially in LMICs, and to a large extent, in my experience and opinion, it's really just come down to the value of data. I think there's a very clear correlation between investments following value, and so where we've seen successes and where I've also experienced successes firsthand is where there's a very clearly identified value for the data. And so the investments that Carl has mentioned, whether that's going to be through a human being as a medium for data exchange, or you're actually also investing in like a health information exchange, then naturally follows the value. And I'll give you an example. Like, for example, in Kenya, we've tried to do that, to break, to basically solve this challenge of silos and fragmentation for a long time. And the use case that has been driven a lot has been through trying to digitalize and transform care in the communicable disease health programs like HIV and all that. And that has had, I would say in my opinion, very low success. Yet in the last 2 years, the Ministry of Health with government and all that decided that we're going to change the use case to one of electronic claims, basically looking at health financing. And what we've done in 2 years, where we've actually covered almost a third of the entire country with the National Health Information Exchange, is, in my opinion, short of miraculous. And it's things that we've known about for the last decade, whether it's the registries that need to be in there for unique personal identification, whether it's technology services, all the key components of a health information exchange that we've all known for a long time, whether it's standards like FHIR and all that, are all of a sudden not as a huge barrier as they've been for the last decade. So I think there would have to be that. Obviously, I think all the other things that have probably been discussed throughout today have to do with technology literacy, having low capacity, and I think, as Misha mentioned, the true cost of digital health, I think, in my opinion, has not been fully nailed, and many governments don't actually know what it costs. Yeah.
Thank you. So I'm going to move the conversation a little bit to some kind of pointed questions to some of the panelists. So this one is for Smisha and then Nada as well. What evaluation and monitoring mechanisms should be used to assess the impact and effectiveness of digital health interventions in MSF? So we've talked a little about the cost, but what is the impact both from a patient care standpoint, but also is it doing what we intended it to do? So if we think about cost, we think about care, and we think about also impact on healthcare workers. So if you guys can just in 2 or 3 minutes, kind of what ways we should consider evaluation and monitoring and the mechanisms attached to that. So I'll start with you, Smisha.
I think, and of course, not having full understanding of MSF systems, but one of the challenges that we see consistently with digital health implementations is fidelity of use. So, are the intended users using the digital devices the way that it was intended? And are they using it consistently over time? What we often see is initially people are excited, it's something new and exciting, and they use it, and then the use trails off. And a number of evaluations, actually, one comes to mind from 15 years ago, where there were targeted messages being sent to women about antenatal care and what to do to care for themselves during pregnancy. And the aim was to improve the health of the mother and the baby, of course, but we saw that less than 5% of the messages were actually reaching the mothers and were being opened. And that was because at that time, this is now 15 years ago, for access has changed. But that was because low access by women of phones, and then poor data, poor 3G, 4G connectivity. And the last was because they were migratory populations, and they moved and they changed phone numbers often. And so that sort of resulted in low fidelity. So I think a really good place is fidelity. And then the second is, I think we need to actually move away from measurement of health outcomes and really look at more proximate measures repeatedly. And this is maybe over 36 evaluations we've seen that we haven't been able to consistently say that digitization improves health outcomes. Where we are able to show value is it improves efficiency of a process, or it improves the quality of the care delivery. And so really honing in the evaluations on these interim measures. And we can extrapolate that if there is efficiency and there is improvement in quality, that health outcomes will have there'll be a downstream impact on health outcomes. I'll pass that over to you there.
Thank you. I agree with the last point about the difficulties of measuring through the outcome on the patient, especially right now with like all those initiatives being implemented together. So you don't even know what has which impact at that time. So I would also insist on the adoption. We see this overexcitement, and we spoke about it this morning around AI. And so we are all like this. It's a human being thing where it's super fancy. We play with it, and then after a few days, we don't use it anymore. So I think the use in time, it's an important KPI to be followed, at least within MSF and the project that we are having. I would say also tools that become part of the healthcare pathway. It's not anymore innovation. In fact, there is innovation is super easy. But then switching from innovation to something that is part of the routine of care and part of the healthcare pathway is the most challenging part. And that's where we fail usually. And so I think crossing this line and moving from the innovation to routine is another KPI. And then finally, I would say the outputs. Are the outputs of those tools actionable? Both within MSF, at least, both for medical care, but also for operation, to organize, to size operation, to anticipate operation. If the output is not directly actionable, then maybe we had initially a problem in defining what was the problem and why this solution was developed. And then I would insist on the quality, even the quality of the training or even the task shifting of or capacity building. Those tools empowered, they should empower human resources. And we heard all day that we don't have enough medical human resources in the majority of the context where we work. So being able to have a tool that provides a service like a diagnostic, but also at the same time empower human resources and succeed to perform this task shifting from, I don't know, a radiologist to a radiology lab technician, or from a microbiologist to a laboratory technician would be also another way to measure let's say, the effectiveness of those tools.
Since you raised the AI topic. I can't have a panel on that doesn't bring up AI. So I'm going to ask you, Rohit, and anyone else on the panel. AI is essentially everywhere. We're seeing it in every aspect of both our day-to-day lives, but also more and more our processes within MSF, as well as we're looking at it from a healthcare standpoint. We're seeing AI pop up everywhere. Could you talk a little bit about the ethical considerations that you are exploring with the WHO, as well as in other areas that MSF should kind of be thinking about? I mean, we've talked about it in MSF, but I think from an external perspective, what are some of the ethical, and then for anyone else on the panel, some of the privacy and security issues that we should be considering around AI?
Sure. So the way that the WHO's tried to work on this, just as background, is we published some initial guidance on to thinking about the different ethical issues in 2021, and that was distinctive because at that point we didn't have generative AI, and so some of the issues that have emerged with large language models are different in some ways than these sort of single-use models that I think a lot of the discussion has been around today that I've listened to. So just in terms of broadly speaking, with sort of older versions of AI, we identified sort of 10 broad ethical challenges. I won't go through all of them, but you know, they range obviously from the well-known concerns around bias, which is, you know, the biases in the design and who participates in the design, the biases in the data, and then the biases in terms of where a technology is actually tested so that it only really works in a specific context. There are all the concerns, again, about privacy and whether or not you end up having algorithms that actually sort of ensure that the primary data and the sort of data that is then produced is actually sort of managed in a way that ensures both data security and sort of isn't used for other purposes that actually would violate the individual liberties or safety of individuals. There are concerns, of course, in terms of the environmental impacts of artificial intelligence, and there's obviously other work I know that occurs in MSF around this, but especially as we move towards more and more use of generative AI models, which really require a lot of both training data and then also a lot of energy expenditure and water expenditure to actually make use of these algorithms. There is a need to calculate the risks and benefits between both using these algorithms and then the wider consequences they have. There are concerns both for healthcare workers in terms of their ability to use these models, and somebody mentioned that, I think, in the last panel, but also their ability to maintain skilling when they are relying increasingly upon these models, and also in terms of not surrendering their judgment to these models itself. And then finally, for example, there are concerns about the balance of power between companies that are developing these models and then those who actually rely upon them. And for example, I think Alphabet last month sort of quietly rewrote their ethical principles that they claimed that they were going to apply to the use of all these technologies that essentially allows them to be used much more widely, for example, for military use and for surveillance and, of course, for sort of purposes of trying to identify people who may be sort of undocumented in different settings. And you know, it is in our peril that we now have less and less regulation and oversight of these models, and essentially are finding that most of this is going to be controlled by companies within their four walls, when we know that sort of the prior versions of technologies that these companies have developed have not followed any moral, ethical, or human rights standards. With the use of generative AI, you know, there are broader concerns also. One of them is just simply who controls knowledge. And certainly one of the concerns with generative AI is that we are displacing sort of the center of knowledge being produced by humans to algorithms that really are often, you know, from 10 to 30% of the time are hallucinating or producing nonsense. And that has real concerns, not only for healthcare workers, but also as we push this out to individuals and communities that don't necessarily have a backstop to ensure that this technology can be used appropriately. Just to quickly mention a couple of things we're working on now. One area that I think is also important to MSF, because you do a lot of scientific research, I remember from my time there, is research ethics committees actually are having to really retool or reskill themselves to deal with the rise of the use of AI. So when you think about research ethics principles, they actually don't integrate AI into how they think about the review and oversight, and a lot of research ethics committees don't have the expertise or capacity to engage in this. So we're actually trying to develop guidance that really tries to get research ethics committees to rethink how they engage in oversight and review. The other area that we're really focused on is around chatbots. So when you think about the rise of generative AI, that's changed how we think about chatbots, and now they're increasingly autonomous. And that means that we're going to, again, push out much more of the the use of chatbots to be working much more sort of autonomously, both with communities and then also with health workers, and that raises real concerns about controls over their use.
Any of our online panelists want to dive into AI?
Maybe just to highlight a few additional concerns with the generative AI, there's also issues with poisoning of the training data sets. I think there was a study that came out with, I don't quote me on the numbers, but something like 0.5% or like 0.05% of the training data having bad data can completely change the outcomes of what's generated. And it was in a medical context that the study was done where wrong decision support guidance was given based on like this very small poisoning pool. There's also some research that's come out that shows that one of the techniques for LLMs is to use RAGs and to really try to constrain sort of the context. But they found that in one case where they constrained a context, they constrained it so much that it picked up this was a sort of security research, but it started picking up the conversations that the people were having as they were developing these algorithms, and basically these hacking communities that were used to train also started picking up neo-Nazi sentiment, and that sort of the discussions came in. So it was completely unrelated, but because the training data sets are so large, we really have no idea what is going to come out of these things. So I think there's a long way to go before we can have any kind of reassurance on testing the safety of these algorithms against normative content that we know, right? If we're using an AI algorithm to test an AI algorithm, we're in a feedback loop of nonsense that we're not going to be able to get out of. Thanks.
Maybe I'll add in briefly. One of the areas where I've seen potential and where I think the risks are lower is social listening, essentially where users are using chatbots or any type of online medium for requesting information or even for conducting searches. We're able to get sort of a footprint of the concerns of the population, including a sense of what the prominent pieces of disinformation are within that population. And when coupled with community-based organization, there is an opportunity for community-based organizations in humanitarian settings to then be responsive to that and target their programs to be responsive to that. And so that's not generative AI, but it is a really solid application of AI with lower risks, and it doesn't deal with patient care, but it does deal with information.
So I'm going to hand this over a little bit to the group here. I know it's been a long day. Everyone's been talking at you. We do have a little bit of time for one or two questions. From the first, I'll look for anyone in the room. If you can use a mic, please.
Thank you again. Maybe a question for the medical position of MSF, so maybe for Rieux. I don't no, but we are talking about all the digital solution we can master, we can encourage as MSF, we can adapt, but in our world, that change very fastly, and now more and more the doctor can have other solution. And for example, WHO just produced an antibiotic guidebook last year, and now they have an application for that. And so now, if our doctor want to use that, should we prohibit that because it's not MSF guidelines? Should we encourage that as educational guide, or how can we react with all this source of information, very cheap? It's like a low-hanging fruit, but it's not MSF guidelines, but it's good information too.
You want your medical director to answer that?
So there is a work right now at the DearMed platform, and the work was made by Claire Mills as a consultant to review the guideline, their utilization, and also all the guidelines. Not she didn't do an extensive, but all the guidelines that now are available, which was not the case maybe 20 years ago, and what shall we do, and what will be the recommendation. Shall we keep the MSF guidelines, or in certain situations just recommend, for instance, to take the WHO guidelines or other guidelines? So this work is ongoing, and there is really the willing to be open, not to duplicate, as you were saying, for other things. So this is very important, and to promote much more the apps. There is already apps, but not enough. And the good thing with the apps is that when there is some review, you can put it the new version very, very quickly. So this work is ongoing, and we will probably have a kind of editorial board, really to select, not to be systematic that this is the guideline MSF you have to review, but wait, what are the other guidelines and how we can cope with them. But it won't change also the need to have some guidance, much more like SOP at the bed of the patient, because there is also some specificity in it's different guidelines from SOP. So this will be needed as usual. Did I answer to your question? Yeah.
Any other questions from the audience or online?
So we have one last question from online, and then I guess we can wrap up. So how do you address the coherence between the myriad digital health apps in these contexts? Can you speak about all of the adverse effects of digitalization in these settings?
I will actually see if I can put that to my online colleagues to see if you want to dive into that question of what do we do with all these digital health apps?
I guess it partially depends on whether you want to keep them around or not, right? Are they providing utility for the people that are using them? And if so, then you need to change management plan, right? To figure out how to either update and integrate them with the larger ecosystem, make use of standards, et cetera. Otherwise, if there is sort of some functionality there, but maybe the tool is dated or et cetera, you can start thinking through what is that approach to twilight or sunset that particular application. And one process is the strangulation pattern, which you say, here's our tool, let's slowly cut off different functionality, replace it with something else until you can replace it with something different. And that way you can sort of retain all of the training and the continuity for the existing users of the tools, but also provide a way to step away from those tools. Over.
Yep. Just to add really quickly, and I think for me, one of the clearest answers to the question is what the world is currently going with all the changes, especially in the global funding architecture. I think with that changing, I think we're starting to see what tools countries really need. I think what's going on is that I think tools are either being inaccessible because maybe governments can't pay for them because they're being paid for by their partners, or for whatever reason they are unsupported, because the technical capacity is now not available because some partner who was funded by an external partner is no longer available to the state. So I think there's a natural consolidation of the really essential foundational and very fundamental apps and systems. And I think that these sorts of changes happen globally, whether it's geopolitics or whatever it is. I think this is going to, in a very strong way, affect these apps. I think when COVID broke out, obviously there's an upsurge of apps because everyone was trying to solve a certain challenge, whether it's of inconvenience, access to service delivery and all that. But now I think we're seeing almost like at the other end of the spectrum. And so I think there'll be a natural attrition and shutdown and consolidation. Thanks.
If I may add, it's like a pressure of selection that is happening right now already. I think when you look to the literature review and what is existing in terms of app, in 1 year or 2 years, you will do the same review and you will not find any more those tools. And we are already experiencing that. So I think if we might find something positive from what is happening worldwide regarding the aid funding, maybe it will impact also and it will help to prioritize where we are putting our resources. I think if I take this question for MSF, we are already very bad at that. Today, you have one patient, but he will have a result with antibiogo. He will have a result with AI for TB. He will have a result with snakes, maybe. And there was no moment where all those projects sit together and discuss about how are we going to make this interoperable. And I think this should be a sine qua non condition in the due diligence for funding and supporting projects that we should launch in MSF. If there is no vision about how they are going to be integrated with tools that already exist, then we should not go for such tool. I think we need to be, it's time to be stringent with the selection of where we invest our resources, both human resources and fund. And for me, it's a call for the TIC selection also committee, because most of the projects, we are lucky to have the TIC who supported this project. I think it should be the criteria to be used to agree to support a project or no. And I hope they will move on this.
Yeah, I mean, I think there's a major question. There's two issues that I think we haven't really tackled in MSF. One is, what is our digital health, and we can even say digital ecosystem look like? What should it look like? Do we aspire for it to be? We also have not tackled this question of interoperability. And I'm not sure everyone understands truly what interoperability means. And there's the technical aspects of it that we are trying to tackle with at the DearMed level with the health data strategy, which is inching slowly. And there's pieces also at the Spark conversation around how to have interoperability, at least in our thinking. But with all these tools, we need to really strategize what is our data strategy attached to it to ensure kind of, as Carl mentioned, the semantic part, but also kind of the exchange part, so that when you have all these applications, it's going somewhere, so that the patient is looked at, with all of the components that were about them and their healthcare.
But that's exactly, to come back to the question, and the purpose of this panel was to have maybe some key messages about the due diligence that we need to put in place in order to rationalize our investment in the future. And I think this coordinated approach and interoperability is a key question. There is, of course, the data protection, the data privacy, the cybersecurity, the regulation. But the interoperability today is urgent because those tools already exist. And we need to find a way to come back to something more comprehensive for one patient and not fragmented as we have today.
So I've been told that we're over time. That's the kind of theme of today. So I want to thank our panelists for kind of being poked at with all these questions, and also for the audience in your kind of attention span for the last 9 hours. We will kind of put a summary of this conversation together so that we can kind of add to what would be kind of a future thinking of what digital health should look like in MSF. Any questions that you have for myself or any of the panelists, please let me know. I'm happy to get that information to the various panelists. And thank you for those of you online for joining. I really appreciate it.
Thank you for poking us.
We will now have just some quick closing remarks from Malika and of the day, and then you can be on your way.
Alors, je vais conclure.
Okay, so some concluding remarks, but before concluding, I'd like to extend all the thank yous. We had 19 people working on that, 17 external participants, the participants online and in presence, and all those who contributed to organizing this Digital Health Day. I'd like to thank Dr. Nada Malou. Where is she? Nada. Because she launched the initiative for this Digital Health Day. She came up with the idea. Many of you know Nada through AntiBioGo in particular. She created that program. And I want to highlight how successful this innovation was. For the speakers, well, first, thank you for accepting to come here to talk to us. Thank you for the quality of your presentations, the richness of all the exchanges we had. So showing a slide, a thank you slide. Here you are. Thank you to all those people. And also the team working behind the scene. I'd like to extend thank yous to the moderators, Sophie, Isabelle Mouniaman, and Megan McGuire, who was the moderator for the last panel discussion. Clara Mazon helped a lot organizing this day. Louima, Hiyat, Bastien, Christina, Aspira. And a big special thank you to Helen, Vanessa, Marion Poulain, and Laura Goulvan. Well, now to conclude this day, as Claire Rieux told you this morning in her introduction, digital health is not something new. We didn't call it by that name, but we heard through all the presentations and examples presented throughout the day. We're already in the midst of digital health, but everything is speeding up very quickly. It makes you almost dizzy, the rate of adoption, alongside with the boom of artificial intelligence. So we are in a new world, in a new era, definitely. Diversity, diverse solutions offered by these tools. So one of the first conclusions is more in the form of a question, a key question for MSF. How should we navigate in this new and ever-changing landscape where everything is accelerating? In guise of conclusion, I'd like to highlight two great opportunities and 2 points we have to be vigilant on, among many others, but I had to select a few for my conclusion. Regarding the potential, the opportunities, we see that those tools are there to serve medical needs, in solutions both for diagnosis or the care management of our patients. In the early afternoon panel, we heard about KDX, telemedicine, and data collection systems with DHS, Praxis, BAMNI now, and the EMR, electronic medical records. So there is great potential there, but it requires meeting a dual challenge. First, being able to develop our own expertise and developing a clear strategy. We need to have a clear framework from the start, and we need expertise as well to be able to fully benefit from the potential of those new tools. It doesn't only concern diagnosis or treatments. Those tools also help us to drive our operations for the follow-up of remote patients, for screening and detection of patients in the setting of a conflict, for example, disease surveillance with data collection, structured data, epidemiology, also the organization of healthcare provision, how to coordinate healthcare, optimizing patients' flows. And with Javier from ICRC, we saw how those tools can facilitate the work organization for caregivers, improve access to information, and improve access to the search for information, all the way to anticipating with predictive solutions made possible by those tools. We can anticipate and forecast future needs in supplies and drugs, whatever. So there is this great potential that we could leverage and optimize. We discussed that at length, and it was really nice to see all the options on the table. About the 2 points we have to be careful about, vigilant. There were a number of questions online about that, by the way. One of the risks associated with digitization is the multiplication of fragmented tools. That's what was highlighted and questioned. One example was given. If you remember, you have a tool, for example, to evaluate the patient, clinical evaluation upon admission, another tool for diagnosis like lung X-ray, and then another tool to analyze the antibiogram, and you can have to use all three tools for one single patient. Hence the risk of a fragmentation of all those tools, and the challenge there is indeed interoperability, not only internally amongst ourselves, but also at the scale of the whole MSF movement, and even more broadly, why not? Interoperability with other medical NGOs. And the other big challenge, you pointed it out, has to do with regulatory and ethical considerations. That's the legal and regulatory and ethical framework for these technologies. It's scary sometimes when you see how quickly things go and develop and change. And you do understand the risks that kind of pile up in terms of, ensuring confidentiality of data, patients' privacy. But if we refer to our anti-BioGo experience, anti-BioGo as a tool leading to a medical decision-making, now we call that software medical devices. Those tools have to be developed, thoroughly documented and tested, and all that in a regulated framework with very strict demands or requests. It's a major constraint, but it is essential if we want to have a secure framework for all. So this approach has to be multidisciplinary. You cannot go for it on your own. You need the support of experts for regulations, for experts in data protection. I turn to Kim, but also ethics expert, clinical use experts. It really calls for multidisciplinarity and for discipline as well, I guess. What is sure is that in view of our first objectives when we started out, I guess we more or less reached the objectives we set ourselves for this Digital Health Day. First, we wanted to share information. What is digital health? How can it be, or what can we apply it to or for? And another objective was to trigger further thinking, reflections, ambitions, and ideas.
So clearly, we need to follow up on all of that, make sure that we cooperate between sections and internally. And it probably requires the definition of our own strategy. We need to make up our minds. We need to know what to do with this trend towards more and more AI, while keeping in mind the challenges and the risks that are huge. So these considerations are very important, and also making sure that we comply with our principles and we are faithful to them, and we also are aligned with our roadmap. What I mean is that we want to do more than just follow suit and jump on the bandwagon of AI. We need to go at it in a rational way with a strategy in mind. Now, thank you very much to all participants who listened to us online, and thank you for their contributions. I know that some of them are in the field. Thank you very much to our medical department. Thank you very much for your commitment, and hopefully you'll be still with us. You'll still be with us for the next steps. Thank you.